So have you used same type of software or different software?
Whether that
Yes,
means
sir.
the photos were processed or not at the first instance, or whether raw photos used. That is another
The
point.
raw photos, sir, raw
No, that's
photos we
fine. I
use,
mean,
sir.
that's
We
fine.
didn't.
That's fine. Dr. Monica, over to you.
Thank you, Dr. Anjan. Dr. Shashank, is your audio working now?
Yes, yes, ma'am. My
Yeah,
audio is
go
working now.
ahead.
Okay, Dr. Abhinav, from my side, one query is which type of suture you use to close the wound in group 1 patients?
In group 2, sir.
Huh?
So we used Vicryl Rapid, sir.
Okay. Do you think that that may be the reason for the scar formation?
Sir, Vicryl Rapid we used in group 2 with smooth type trocar that was absorbable, sir. So less scar was seen in the group 2, sir.
And in group 1?
In group 1 we used non-absorbable suture, sir. We used ethylone, sir.
Okay. And after how many days you remove the suture in group 1?
So we used in group 1 we used after 5 days, sir.
After 5 days.
Yes, sir.
Okay. Because in group 1, the scar is usually plus shaped. I think that plus shaped scar is due to the use of the non-absorbable suture. And I think it may not be due to the trocar type of trocar you are using.
Yeah, trocar, choice of trocar per se.
Yes.
Thank you, Dr. Abhinav. We move on to the next
you.
speaker. Next speaker is Dr. Rohit.
Yes, ma'am. I'm audible?
Yes, Dr. Rohit, you can start sharing your screen, please.
Okay, yes. Is my screen visible?
Yes, it is visible. You can start.
Greetings from Sanjay Gandhi Institute, Lucknow. We'll be sharing our operative technique of transvasicoscopic excision of paravertebral hush diverticulum with bilateral cross-diagonal uterine implantation. Our patient was a 2-year-old boy with history of recurrent febrile UTIs since birth. VCUG showed right grade 4 and left grade 5 vesico-uterine reflux, and DMSS scan showed a right midpolar scar. These are the port position, and we use 2 3 mm and 1 5 mm port. The ports are inserted using Professor Mohan Abraham technique. A pneumovasicum of 8 mm of mercury is created. Now stents are inserted in both the ureters. We can see the roomy left hush diverticulum. The diverticulum is then inverted into the bladder. A plane is then created between the diverticulum mucosa and the detussa. Once the diverticulum is separated, the ureter is visualized and it's mobilized in standard fashion. Now we should not try to devascularize the ureter too much, and carefully the adequate length is achieved. Now the tension is turned towards the right ureter. Again the ureter is mobilized in the standard fashion and the adequate length is achieved. A submucosal tunnel is created for the left ureter. You can see the entire length of the submucosal tunnel is in the ratio of 4:1. The terminal part of the dilated left ureter with the hush diverticulum is then excised, and the left ureter is then passed into the submucosal tunnel. Now the first anchoring stitch is taken with the entire thickness of the bladder wall, including the detussa. After that, mucosa to mucosal anastomosis is done using 5-0 polyodaxanone sutures. The detussa on the left ureteric hiatus is then closed in an interrupted fashion. Now the submucosal tunnel for the right ureter is then created, and the right ureter is passed to the submucosal tunnel. Then the terminal part of right ureter is excised, and again the anchoring stitch is taken with full thickness of the bladder wall, and then mucosa to mucosa anastomosis is done. After this, mucosal closure over the right hiatus is then performed, and then mucosal closure over the left hiatus is also performed. DJ stents are inserted in both the right and left ureters, and a thorough wash is given. This is the final reconstructive image. A Foley's catheter is inserted per urethra. The operating time was 220 minutes. The child underwent an uneventful post-op recovery. DJ stents were removed after 3 weeks, and after 6 months of follow-up, the child is asymptomatic with resolution of reflux on VCUG. In conclusion, transvesicoscopic treatment of bladder diverticula and vesicular reflux is an effective and safe procedure with all the advantage of minimal access surgery. Thank you very much.
Thank you, Dr. Rohit. You finished absolutely in time. I request Dr. Sandeep to go ahead with his questions.
So nice demonstration, good paper. So what was your primary diagnosis in this child?
So the primary diagnosis is a primary bilateral VUR. Basically, we did rule out all the secondary causes and also did a UDS to rule out any bladder abnormality, and it was a primary bilateral VUR.
And cystoscopy was also normal.
Yes, cystoscopy also.
So one question is in the chat box by Dr. Ravi. So
Yes.
were you able to see the was while excising the diverticulum, because it is always in close approximation with that.
No, sir. Diverticula is just an outwashing of the mucosa, sir. So basically, all the layers of the bladder are not tackled. We are able to see beautifully see after excising the mucosa, the diverticula is excised, and you are able to see the ureter. So we can mobilize the ureter.
So, but there has to be some defect in the bladder musculature, then only the diverticular formation would happen there.
So it's that bladder musculature is weak. I agree with that, but it's the diverticula is basically a outwashing of the mucosa. It doesn't contain all the layers, sir. So, yes.
So the point is that the disadvantage of this technique is that we are not able to visualize during the resection. That is one of the minor disadvantages, but obviously well done. Over to you, Anjan. Any questions?
No, I had the same point I had noted, that you are not going out of the, you are not going outside the wall, and therefore you won't be able to see the vas.
Yes.
Otherwise, any other points that make it different from the standard procedure? Because since you have mentioned it is as our technique, so do you think any other substantial salient difference from the standard approach, the operative technique per se?
No, so the technique is basically similar to what Dr. Mohan Abraham sir has described, and it's our initial phase of the learning curve. We have just done 5 cases, and we are still evolving. So
do you think that the PDS is a good suture, or we like to change to some other suture also? Just for sake of asking questions.
So PDS is a good suture as per me, because it's easier to apply in the minimal access setting. We routinely use in other surgeries such as hepatic vaginostomies and lap CDCs. So
what about the knotting properties? Is it easier to apply a knot or in compared to the Vicryl or the other sutures we
no, sir.
commonly use?
Knotting is easier with a Vicryl because it doesn't slips. But Vicryl has its own problems because in Vicryl it's a polyfilament suture. So PDS is stronger and stays for longer time. So
that's where my next question. Do you think that because it stays for a longer time, that too inside the bladder, and the chances of complications?
So we haven't seen it yet. We have a very limited experience. So I can't comment on that based on
Because
the
if you
experience.
see, if you place a DJ stent and remove it after 4 to 6 weeks, even
Yes.
8 weeks, sometimes there are incrustations there, and
Yes.
the PDS will remain there for maybe 6 months.
Yes.
So there may be some chances because of that. There may be some stone formation because it actually foreign body inside the bladder.
Agreed.
So many times Vicryl is used because it is easily dissolvable, and
Yes.
obviously strength is more with PDS in compared to the Vicryl.
Yes.
But again, just good question and just a suggestion maybe.
Yes, thanks. Agreed.
Dr. Shashank, your comments, please.
Dr. Abhishek, in your institute, you are always doing vasectopic reimplantation or any other mode of minimal edge access surgery technique like lap, leg gregor, etc., etc.?
No, sir. We had done in the earlier the extravesical routine reimplantation, especially in unilateral cases, not in bilateral cases. And now, as a routine, we have started from the last 5 cases. We are doing vasectopic.
What do you think? If you want to tackle Hus diverticulum intravesically or extravesically, which one will be easier?
So extravasically will be, as sir already said, extravasically will be easier and more safe because you are able to visualize the vas and all the structures. But intravasically also, I found from the last 5 cases that we have done, we are able to tackle. This was the first Hus diverticulum that we encountered, so we were able to tackle it effectively. It was a surprise for us because it was not visible in the BCOG. So, but we still tackled it, and we didn't find any complications post-op. So we have to be more experienced to comment on it.
Last question: what is the role of anticholinergics before the vasectopic reimplantation? Do you use it routinely?
No, sir. We rule out all the secondary causes of VUR before taking up the patient for vasectopic reimplantation. So anticholinergic we don't use pre-implantation.
Okay.
So intravesical is also not that much difficult in compared to the extravesical reimplantation process. Okay.
Yes. Thank you, sir.
Over to you, ma'am.
Thank you so much, Dr. Rohit, and thank you for a good discussion here. Let's move on to the next speaker. That's Dr. Amit. Dr. Abhishek, are you there?
I have called up Vikesh. He's from Vikesh's team, so he's trying to contact him. If they make it in time before finishing of this session, we will let him present. Otherwise, we'll just give it a skip.
Okay, fine.
So continue with the available next presenter.
Yes, good morning, ma'am. I'll just sharing my slide.
Dr. Ravi, you were saying something, I guess.
Yeah. I just said that continue with whatever the next available presenter is there. We'll just...
Okay, fine.
Is my slide visible, ma'am?
Yes, you are visible. You can start your presentation.
Good morning, all. Today I'll be greetings from Chandigarh, and today I'll be presenting on vasectopic Cohen's reimplantation.
Yeah, I just said that continue with whatever the next available presenter is there. We'll just...
Okay, fine.
Is my ma'am, I'll start again.
Yes, you can start again.
Good morning, all. Greetings from Chandigarh. Today I'll be presenting on vasectopic Cohen's reimplantation for reflux resolution and its comparison with open Cohen's reimplantation. As we all know, vasectopic VUR is an abnormal retrograde flow of urine from bladder to ureters and kidneys, and its prompt diagnosis and treatment is essential to prevent renal scarring and function. So the aim of our study was to assess reflux resolution in 2 cohorts of patients, cohort A, which is open Cohen's reimplantation, and B, which is vasectopic reimplantation, and also compare their outcomes and compare the outcomes of vasectopic group with studies on vasectopic reimplantation available in literature. So ours was a retrospective and prospective cohort study from period January 2012 to June 2020. Inclusion criteria were primary VUR, children up to 12 years of age who underwent ureteral reimplantation in our center and were followed up for at least 6 to 12 months. We excluded redo cases and VUR with ectopic or duplex anomalies. Indications for reimplantation were standard primary VUR with breakthrough UTIs or children up to 4 to 5 years of age not resolving, worsening renal scarring on DMSA, and persistent VUR even after endoscopic management. Surgical technique which we used was open Cohen's cross-trigonal reimplantation and vesicoscopic Cohen's cross-trigonal reimplantation, and also included 6 cases of robotic assisted vesicoscopic reimplantation. So these photographs show our technique. Here I would like to mention that we sutured the DJ stent with Foley's catheter, which is taken out. This DJ stent is taken out with Foley's after 2 to 3 days. So in outcomes, our study was analyzed for resolution of clinical symptoms, ureteral dilatation on USG, reflex resolution on MCU, and resolution of pyelonephritic changes on DMSA scan. So we had total 44 children who underwent surgery. Out of them, 8 were lost to follow-up, 2 were redo cases, and one was duplex, so they were excluded. So finally, we had 14 children in group A, that is open, and 19 children in group B, that is vesicoscopic. And also in group A, 10 were bilateral, and in group B, 7 were bilateral cases. So we have conducted extensive data, which and demographically wise, they are comparable and non-statistically not significant. So in symptomatic resolution, almost 92% in open group and 100% in vesicoscopic group, there was symptomatic resolution. Resolution of ureteral dilatation, 85% in open group and 94% of children in vesicoscopic group had resolution of ureteral dilatation in our case. Reflex resolution in VCUG, 85% in open group and 89.5% in vesicoscopic group had complete reflex resolution on VCUG. Here, I would like to mention that no resolution or decrease in grade has been taken as a negative and is not counted as complete resolution in our study. Resolution of pyelonephritic changes in open group almost 35%, and in vesicoscopic group almost 63% of the children had resolution of pyelonephritic changes in a follow-up period of 6 to 12 months. So to discuss in literature, we have compared the results with open reimplantation in other studies. So after Cannon et al., our study is the only second study which has compared the results of both OR and VR in the same study. And in our patients also, we have a high grade VUR in both the groups. So in our study, 97% of the patients were high grade VUR in comparison to other studies. So VR group has statistically significant low duration of hospital stay in our study. Complete resolution of symptoms has been seen in almost 100% of patients in our study. And reflex resolution, our study reveals that there is less reflex resolution. Maybe it is because of less patients and patients lost to follow-up, and we have taken on the high-grade VUR in our study. That may be the reason. So our study also presents that there is definitive improvement in DMSA findings after surgery. So to conclude, OR and VR are comparable in outcomes, and our study is the first study comparing improvement in ureteral dilatation, pyelonephritic changes, and most studies would be required to have a convincing result. Thank you, sir.
Thank you, Dr. Amit. You took 5 seconds extra. So Dr. Sandeep, your comments, please.
So again, a good paper and lots of data. But tell me, you have used lots of statistical method in these children. So with these number of cases, it is possible to apply those statistical methods?
Sir, I would agree that since this study found out in the period of COVID, sir, so our OPD services were suspended. So whatever follow-up we had was telephonic follow-up, and that is why a lot of patients, we could not have a convincing follow-up of a lot of patients, sir. So I understand that our data and our number of patients is less, sir.
So do you think, so next question, what should be the adequate number of patients in these two groups which you must have calculated when we have designed the study so that you can have adequate power of the study or adequate results?
Sir, initially when we designed our study, we had a target of at least 30 patients in each group to conduct the study, sir. But because of raging COVID, we could not do it.
So it doesn't matter. See, most of these studies in the COVID period obviously have not been able to have adequate number of patients, but that doesn't matter. We should know what should the adequate number so that you can extend this study for adequate duration and add those number of patients and have a good result for publication, as you always say. Okay. Any question, Anjan?
Yeah, Amit, a very decent series and nice data to share with us. Two observations. One, when you said it's both a retrospective and a prospective, you could use the word ambispective, you know. This is just a better way to present it. And you always use the PICO components for the prospective. What were your outcome parameters and all in a slide you could just mention, because in the presentation, neither in the abstract, it was clear. So the one point, the other point that I could note was glaring was the DMSA findings. So do you think the pyelonephritic changes, they are really, do you mean to refer to the acute pyelonephritic findings or the scars? So that you have to clarify, because scars I thought are never reversible.
So renal cortical scars would not resolve, but
Yeah.
acute pyelonephritic changes.
Yeah, so that you have to just mention it, because for surgeons, as what we see, the nephrologists are more tuned to the acute pyelonephritic changes, and they use it more often even in the acute phase. We do not use so. So for us, it is the scars which shouldn't be reversible. The other point that was okay about your stenting policy, I think you had mentioned it's a uniform policy, isn't it, in both the open and, because that would have a bearing in your discharge ability of the.
No, sir. Only in vesicoscopic cases, the DJ stent which is put is fixed to the Foley's and is removed on post-operative 2 and 3.
So
in
what about the open?
Cases, sir?
Yeah, what about the open group?
Sir, in open group, we keep the DJ stent we remove in follow-up period after 2 to 3 weeks, sir.
Okay.
Because Foley's we
Foley's, when do you remove the Foley's?
For a week, sir. We keep the Foley's for a week.
And how is it? The patient goes home with the Foley's on day 6?
Sir, if the patients are not from far off place, and if they are generally with good socio-economic condition, we can allow the patient to go with Foley's. Otherwise, we try to keep them.
Okay, that's all from my side.
Dr. Shashank?
Yes, Dr. Amit, you are measuring the ureteric dilatation in follow-up ultrasound, I think.
Yes, sir.
Okay. And what is the time period after the surgical procedure to measure the dilatation of the ureter?
Sir, USG we have repeated anywhere after 1 month. 1 month after surgery, sir.
After 1 month of the surgery.
Yes,
and
sir.
you are keeping the digestant or the external tube in open group for around 2 weeks. If you are putting the digestant in open group and you are removing in the subsequent follow-up under general anesthesia, that means you are keeping the digestant for 1 month. That means the ureteric dilatation after the removal of the just after the removal of the digestant will be minimal. But you are removing the digestant after vesicoscopy reimplantation after 2 days or 3 days.
Sir.
So I think the uniform protocol should be followed. That means in either in vesicoscopic group, you should have removed the digestant after 1 month, or you should not have used digestant in the open group, because the uniformity is not maintained for the assessment of the ureteric dilatation. Because till the stenting is there, ureter will be uniformly dilated, or it will not be dilated for the follow-up criteria.
Yes, sir.
What is your opinion?
So this time limit of 1 month is the minimum time limit. That is minimum. That is after 1 month of surgery, or later on we in follow-up we get an USG KUB done. And I take your point, sir, that yes, we should have followed a much more standard criteria for, because of COVID, our prospective arm was less. So it is mostly the data is of retrospective patients, sir. So to have very standardized data, we could not get because of COVID, sir.
So that makes it more important to use the word prospective very carefully. So if it is so, you have, otherwise you have to mention like the PICO is part of that only. The protocol has to be uniform. So that has to be, Shashank, please go on. Sorry to interrupt.
No. Carry on. I will
I
have another
think
question. after
we
that.
had a good discussion on this paper because it's time for the next session also, and we have one more speaker for this. So thank you, Dr. Amit. We'll move ahead to the next speaker.
Thank you.
And Dr. Abhishek, are you in the room there?
I don't think Abhishek is here.
Okay.
I've tried to call them, but he's not answering. It's okay. We'll just, you can conclude the session and move on to the next one.
Yeah. Thank you so much. Thank you all the speakers. It was a good session with good discussion because few speakers were not there. So we could have good discussion on each of the papers. I request all the three judges to continue as the judge for the next session as well. I hope it's okay with Dr. Anjan, Dr. Sandeep, and Dr. Shashank.
Yeah, sure.
Yes, yes, sure.
Okay, ma'am.
And I hope you have the marking sheet as well.
No, I don't have marking sheet for the second session.
I will send Shashank.
Okay,
Yeah.
sir.
In a
I
minute.
have also do not have marking sheet for the second session.
Yeah, I am sending Sandeep. Just give me a
Okay,
second.
okay. So I'm marking the
At that
first
time,
one.
I'll take a quick roll call. Dr. Basu,
Yes, ma'am, I'm here.
Dr. Rahul, Dr. Abhirami,
Yes, ma'am.
Yes, ma'am.
Dr. Aditi, maybe she can join later, Dr. Chandramouli,
Yes, ma'am, I'm here, ma'am.
Dr. Abhishek Tiwari. He was not there for the first session either. Dr. Shamendra Pratap Sharma.
Yes, ma'am.
Okay, fine. So we'll start with the next session. Dr. Asu, you can start sharing your screen, please.
Yes, ma'am.
And the time is 4 minutes for your presentation and 2 minutes for the discussion. Please try to abide by the time.
The presentation is visible?
Yes, it is visible. You can start.
Yes. Good morning, judges and audience. Greetings from TNMC Mumbai. I'm Dr. Shamantak Basu, Assistant Professor, Department of Pediatric Surgery. I present our institutional experience of modified transumbilical lap-assisted appendectomy of 116 cases. Pediatric appendicitis is divided over its concepts and modes of management. Appendicitis is managed conservatively or by open or laparoscopic surgery. Many meta-analyses of conservatively treated appendicitis show recurrence, hence making surgery essential in an elective or emergency setting. 3-port, 2-port, single-port, and single-site laparoscopic surgeries have been described. These are the many variations of single-site laparoscopic procedures that have been described. In our procedure, we make a 1 to 1.5 centimeter infraumbilical smiling incision, and a 5 mm cannula is inserted via the umbilical tube. Pneumoperitoneum of 6 to 8 millimeter of mercury with a flow rate of 1 liter per minute is used. Laparoscopy is done. The left side of the umbilical tube is cleared and the sheath is incised just left of the umbilical tube with direct insertion of a 5 mm non-tooth grasper. Additions are dissected off, the appendix is held near the tip, and after confirming free mobility, the intervening tissue is incised and the appendix is delivered through the wound. Then extracorporeal appendectomy is done. This is the postoperative wound. Retrospective analysis of 116 elective cases is done. We included cases of conserved acute appendicitis taken up for elective surgery after 6 weeks. Acute appendicitis or cases with generalized peritonitis and appendicular lump did not undergo the surgery. Demographic parameters, perioperative and postoperative parameters were studied as shown. All statistical analyses were performed using descriptive statistics. Mean age of our study was 8.75 years with 72 boys and 44 girls. About a third of the cases were operated by residents. Intraoperatively, adhesions were present in 31% of the cases, which varied from flimsy to dense. Only 8 cases postoperatively had surgical site infection, and 2 of them had added postoperative ileus. 11 cases needed additional ports and 8 needed conversion to open surgery. Most could be discharged on the second postoperative day, as we can see, and a few could be discharged on the next day of surgery. So to discuss to decrease costs and complications of laparoscopic surgery, techniques with lesser ports and laparoscopic guided procedures have been devised. Transumbilical lap-assisted appendectomy was described using an operative laparoscope in 1992. Since then, several modifications have been devised, some using a SILS port, a glove port, needloscopic instrument ports, and others. Advanced energy sources and endostaplers have also been used, as we can see in this chart. We have used a single small incision axis without using any fancy or expensive instruments, using simple extracorporeal knotting, needing lesser intercorporeal movements. We found that there is lesser collision and the procedure was simple, as the direct insertion of the instrument improved maneuverability. Another positive point is the decreased CO2 expenditure due to low pneumoperitoneum pressure and time, as this is a hybrid procedure. The rates of complication were comparable to other lab procedures as well. Early discharge and rapid recovery was possible with a good scar and overall lesser cost. It is important to note that completion was achieved laparoscopically in 91% of the cases and 84% of which was single incision. Knowing that this is a retrospective study with ordinary randomization and some selection bias, prospective randomized comparison is needed for better evaluation. To conclude, we can say that this procedure is easy, safe, with good reproducibility and outcome in children. Even in the emergency setup, a good number of cases should be able to undergo this procedure if cases are selected well, like early uncomplicated appendicitis. Gross additions may need additional ports or conversion. Single-site laparoscopy has come a long way in reducing surgical trauma. This modification using a direct instrument increases maneuverability and ease of surgery. Thank you.
Thank you, Dr. Shamyantak, for finishing in time. Dr. Anjan, can you start with your comments, please?
Yeah, very nice presentation, Swamita. I have few points that needs a clarification. First is, why did you choose to do the non-operative management? What do you think are the advantages?
In our department, it's a protocol to manage uncomplicated appendicitis conservatively. If there is
definite advantages, two definite advantages that is also quoted in literature.
Two definite advantages is that we can we can go in with a single port surgery, single site incision surgery, so we don't need additional
I think I would argue that because the main argument is that you avoid general surgery, general anesthesia, and the abdominal surgery. And because the belief is that most of these patients don't want or would require an interval appendicectomy. So what I understand is that you are avoiding an operation at the initial phase, but you said all of them would go through interval appendicectomy in follow-up. Is that right? That's your protocol?
Yes.
So which is unlikely what is found in literature. So those who are offering non-operative management would selectively do interval appendicectomy rather than offering the interval appendicectomy to all, because that will defeat the purpose of doing a non-operative management at the first point, isn't it?
Yeah, but most of these cases which have been operated and we've been put in this study have come back with attacks.
Yeah, so that you have to mention. So
yes,
that you have to mention that protocol.
They have come back with attacks.
Yes, so that needs to be. That brings me to the another question. What was the indication? So that has to be clear in your presentation. So the other point that is mentioned is that that I needed to highlight is that in your presentation or on your abstract you had mentioned ethical clearance not required. Why do you think so?
So because this is a retrospective study, sir.
But I don't think so. Even in retrospective, you are handling the data of them. It's you can always waive off certain portions from the ethics committee, but I think even still ethical clearance would be required. That is one point. Dr. Shandip, sir, you could take over.
So two questions more on the technical aspect. One, you have said that you have utilized the flow rate of 1 liter per minute with the pressure of 7 to 8.
6 to 8.
So
yes.
6 to 8. Yeah. So is it possible? Why is it so?
So it was possible to in our procedure, we are just visualizing the ileocecal region. We are doing a laparoscopy first, and then we are visualizing the ileocecal region. In younger children and in most children, we can do it with 6 millimeter of mercury as well. But in some older children with adhesions, we are needing 8 millimeters.
So was there any leak from the port side because you have installed a 5 mm instrument through that port? So was there any leak?
No.
So why?
We are just taking a stab at the 5 mm instrument side. We are just taking a stab. So usually it doesn't leak.
So because for 1 liter flow rate, it is difficult to maintain pneumoperitoneum, more so if you are placing a umbilical one more port at the umbilical side. Okay. The second point, was there any perforated appendicitis in your one of these patients?
There was appendicular lump, so that which was operated later on. So
during surgery, have you found any appendicular perforation or complicated appendicitis?
No. There were adhesions, gross adhesions were there, but gross perforation was not present.
So we were excluding those patients from your study.
The patients which present with perforation directly went into 3-port laparoscopy or open surgery. They did not undergo single port surgery, single incision surgery.
Okay, so again, that begs to the next and the last question. So why this conversion? You have approximately 10 to 15% conversion rate to open surgery. 8%.
Yes.
So even 8% conversion rate to a simple appendicitis is not justified. If you are offering laparoscopic appendicectomy to a child, if you're offering open appendicectomy, that's good. But why this 8% conversion rate?
All these conversions were because of dense adhesions. I think selection of cases may be a thing, because when we had done the laparoscopy and when we are doing the procedure, the azimuth angle is very low. So we cannot do many maneuvers with the procedure, but that's why that may be a cause. But one thing has to be seen, sir, that even in spite of these adhesions, we are being able to complete a lot of cases with additions, where 31% have additions and only 8% are going into conversion.
So the point is that if you're converting those age patients, have you thought about converting to 3-port appendicectomy in those patients?
Yes, yes.
So in spite of conversion to 3-port, we have to do open appendicectomy in those.
Yes.
Okay, so they must have been done by some residents or in the emergency scenario. That may be the reason for that. Otherwise, conversion that too in appendicectomy nowadays, with most of us doing pediatric laparoscopy is unheard of. We never have to convert it, but maybe in a teaching hospital where more so resident operating in the middle of the night, we may have to do the conversion.
Dr. Shashank, a quick question from you.
No, ma'am, no question because time is up, I think.
Yeah, thank you so much. And I request the judges to stick to one question each. In fact, I wanted to invite Dr. Partha Pratim. Good morning, sir. If you have any questions or comments, please go ahead.
Thank you. No, thank you. Carry on.
Thank you, sir.
Thank you.
So I request the next candidate, Dr. Rahul Krishnan. Dr. Rahul, are you there? I think he's not there, although he had said yes. Dr. Rahul?
I'm just hold on. He's joining.
Hello?
Ma'am, he's joining again.
Okay. So till that time, we can move ahead to the next candidate, Dr. Abhirami.
Ma'am, he has already joined. And Rahul sir, you can start presenting. Please make it quick.
Okay. Are you able to see my presentation?
No. Even
No,
your
Dr.
camera
Rahul,
is blank.
we cannot see your presentation.
Okay. I'm sorry for the confusion.
Yes, Dr. Rahul, your screen is visible.
Visible now?
Yeah, it is visible, but your audio is not good. Can you go close to the device, please?
I'm very close to the laptop.
Yes, now it is better. You can start your presentation.
Rahul, switch on your video as well so that people can see you.
Good morning.
Dr. Rahul, we cannot see you. We can only see your slides.
Good morning. My webcam is on, sir. Good morning.
No, it's still not. You are not visible.
I believe the signal strength is low. So I would suggest to keep the camera off.
Okay, so you can go ahead with your presentation.
Okay. Good morning, everyone. My name is Dr. Rahul Krishnan, and I'm a general surgery resident from Bangalore Baptist Hospital. I'll be presenting on laparoscopic assisted extracorporeal appendectomy for uncomplicated appendicitis in children. A laparoscopic appendectomy is typically performed using
Dr. Rahul, you are not audible.
laparoscopic appendectomy can be performed using one of 4 ports. We are presenting our experience of a 2-port laparoscopic assisted extracorporeal appendicectomy for uncomplicated appendicitis.
Go to the slideshow format. Go to the slideshow format.
This study was conducted between September 2018 and September 2021. A total of 101 appendectomies were performed. All children were under the age of 16. 60 of the cases were complicated or perforated appendicitis, so they were excluded as per the exclusion criteria. And port laparoscopic assisted extracorporeal appendectomy, one such patient. Exclusion criteria were obesity, appendix, appendicular abscess of phlegma, and localized or generalized peritonitis. The procedure was a 2-port method. 5 mm umbilical Hassan port and a 3 mm port was placed in the right iliac fossa. All surgeries were performed within 8 hours of admission. So here you can see that an umbilical port was used, as well as a suprapubic or a right iliac fossa port were used. Here you're able to visualize the appendix clearly. The appendix was typically exteriorized through the umbilical port site, and transfixation suture was taken, and the appendix was excised. There were a total of 101 cases that were performed. 40 were performed using the 2-port extracorporeal laparoscopic technique with a single preoperative dose of IV antibiotics. 61 of these cases met the exclusion criteria, so they were performed using a conventional 3-port intracorporeal laparoscopic appendectomy. Of these, 4 had to be converted to open. 2 were due to dense adhesions, 1 was due to a perforation with an abscess formation, and 1 was due to an unhealthy base with an associated sacral perforation. These patients required between 3 to 5 days of IV antibiotics. The average age at presentation was about 10 years in the 3-port technique and 8.5 years in the 2-port technique. Duration of symptoms, counts, and CRP were comparable in both techniques. The interval to OT was about 5 to 5.5 hours in both techniques. In the 2-port technique, 85% of cases were simple appendicectomies, simple appendicitis, but 50% of them were retrocecal in position. The surgery took on average 34 minutes in the 2-port technique and 51 minutes in the 3-port technique. Antibiotics were given only for about 1 day in the 2-port technique and around 2.5 days in the 3-port technique. The time to feeds was much lower in the 2-port technique, was only 8 hours, and the conversion rate was 0. 5% of cases in the 2-port technique had postoperative ileus. This was up to 25% in the 3-port technique. And the length of hospital stay was also shorter in the 2-port technique. There were no specific complications related to the 2-port technique, and the extracorporeal step can be safely performed by general surgical residents, giving them first-hand experience in pediatric surgery. In conclusion, this is a simple approach and can be converted to conventional intracorporeal or open when required. The advantages is that there is a full laparoscopic view of the abdomen. Its limitations include non-feasibility in obese children when there is a thick mesentery, or when there is gangrenous or perforated appendicitis, hemorrhage, or adhesions. Thank you.
Thank you, Dr. Rahul. You exceeded by a little time, just 10 seconds although. I request the judges to stick to one question. So Dr. Sandeep, go ahead with your questions,
So
please.
let's tell Dr. Panda to ask first question.
That's okay.
Okay. So question from Rahul, good presentation, obviously for a general surgical resident. But the point that as a general surgery resident, you must know how to mobilize the appendix more so in a small child with a small abdomen. So rather than converting and pulling it out, it is better that if you want to train yourself under the guidance of your senior, better to use the three techniques and try to develop the hand-eye coordination. Obviously, it can be possible. I noticed that one of the pictures we have removed the appendix from the right iliac fossa. Is it true?
Yes, sir. There were a few cases where the second port was placed in the right iliac fossa, not the suprapubic port, and the appendix was removed out of that port.
And what energy sources were using?
So typically we used monopolar cautery, sir.
Okay. Dr. Panda?
Yes, same point from my side, because during initial days of training, you should learn first the 3-port technique, because it's very difficult for a junior resident of general surgery to adopt to the 2-port or single-port technique while doing the laparoscopic appendicectomy. One question from my side, you told in 4 cases you have converted to open. While converting from 2 technique to open, have you tried 3-port technique? Because it is very easy to release the adhesions by using extra port.
Yes, sir. So initially a 3-port technique was attempted, and after the consultant had decided that it would be better off converting, we converted to open, sir.
Okay. Another question is about your antibiotic policy. You told that in 1-port technique you have used only 1 sort of antibiotic post-op. That is true?
Yes, sir.
And after that, 1 sort of IV antibiotic. Then after that, oral antibiotic?
So we typically do not give any more antibiotics, sir.
Now, whether you are doing single port, 2-port, 3-port, or 5-port, how does it will affect the antibiotic policy?
So we feel, sir, in a simple case of simple appendicitis without a perforation or a collection, a single shot of antibiotics post-operatively should suffice.
Okay.
There's a question for you, Dr. Rahul, from Dr. Partha Pratim. He's asking, does simple appendicitis require intervention at all? What does the recent literature say about it?
Ma'am, so the recent literature does say conservative management can be attempted, but more than half of these cases come back with recurrent appendicitis. So if possible, surgical management should be done.
Dr. Anjan, questions from your side?
A quick one. Quick one, Rahul. Nice presentation. And since you are from general surgery background, just tell me the advantage. I mean, why it's a promising option of doing this transumbilical or delivering it transumbilically? Why is it possible? Why do you think it is possible to do it in children? And not in adults, maybe.
The mobility of the bowel is much higher in children, sir. So in our experience, that was one reason that we were able to exteriorize the appendix completely through the umbilical port.
In addition, it is the spino-umbilical distance. If you see the distance away from the umbilicus, that length also is important. And as I could see, most of your children had a mean age of around 10, which is little higher considering the pediatric age as such on the higher side. But nonetheless, a very nice presentation. That's all, Dr. Monica. Over.
Thank you, sir.
Thank you. Good morning, Dr. Ravi Ramadwar. I can see you in the hall here. Good morning, sir. I think sir is not around. Anyways, thank you, Dr. Rahul. We'll move on to the next presenter, Dr. Abhirami.
Good morning, ma'am. I'm sharing my screen.
Can you start sharing your screen, please? And you have 4 minutes for your presentation. Try to stick to the time, please.
Okay, ma'am, sure. Is my screen visible, ma'am?
Yes, it is. You can put it on the slideshow mode. in your screen, please. And you have 4 minutes for your presentation. Try to stick to the time, please. Sure.
Some audio is getting echoed.
For us, it's okay. You can start with your presentation.
Okay. Good morning, all. From Rainbow Children's Hospital, Hyderabad, I'll be presenting our experience on the outcomes of laparoscopic pyeloplasty in infants. No disclosures. Uretropelvic junction obstruction is the second most common of antenatally diagnosed congenital abnormalities of urinary tract. It may be extrinsic and intrinsic. In infants, it is mostly intrinsic cause. The gold standard procedure is Anderson-Hines dismembered pyeloplasty, against which the minimally invasive procedures are compared. Laparoscopic pyeloplasty is very well described in older children and its success rate has been described, but infant lap pyeloplasty, it's very few papers has been published. So we plan to present this paper. The aim of the paper is to evaluate the short and long-term outcomes of the infants, to analyze their outcomes. We did the study from January 2017 to January 2020. The children either came antenatally diagnosed or presented with abdominal mass. They underwent ultrasound 3 to 5 days of life after the birth, and any children with anteroposterior diameter more than 15 mm will undergo repeat ultrasound at 4 weeks of life and 1 month diuretic renogram. If there is a reduction in the anteroposterior diameter, increase in the anteroposterior diameter, or reduction in the parenchymal thickness, or if the diuretic renogram is showing an obstructive curve, the infant will undergo a laparoscopic pyeloplasty. The outcomes have been measured in terms of gender, laterality, age, presentation, ultrasound, diuretic renogram, associated anomalies, operative time, duration of the stay, complications, and follow-up. So we had a majority of boy babies, which is 93, and we had 3 bilateral UPJ obstruction who underwent bilateral pyeloplasties in a different period. And most of our children were in early infancy. And the mean weight of at surgery is 5 kilos, and we had a total of 107 patients, out of which 103 were antenatal and 4 were postnatal diagnosis, which is a palpable mass. And with 107 children and 3 bilateral, we had a total of 110 renal units. The ultrasound was assessed in terms of anteroposterior diameter and parenchymal thickness, which was studied with the statistical app ANOVA, and there was a significant difference between the preoperative and postoperative values. And diuretic renogram, which was assessed in terms of splitinal function, cortical perfusion, and drainage pattern across the UPJO, which was not mentioned. This only splitinal function has been mentioned in the literature, and we have assessed in terms of the drainage pattern grading, which is very new, and we like to introduce the grading. And the splitinal function, the difference between the pre-op and post-operative values are significant. And we had a total of 110 renal units, out of which 21 had a normal cortical perfusion and 75 had a reduced preoperative perfusion, which improved in 71. 4 had a reduced perfusion post-op, out of which 1 is a poorly functioning kidney. But the grading curves in the other 3 improved, and in the poorly functioning kidney, there was a decrease in the anterior posterior diameter post-operatively in serial ultrasound. This is a new grading system for the E-Iapscon, which has been designed by our nuclear medicine consultant, Dr. Kumaresan in Hyderabad. He has graded the curves according to the peaking, and it has been graded from 0 to 4. 0 is the normal drainage, and 1 is mildly prolonged. 2 is the moderately prolonged drainage, and 3 is the obstructive pattern, which we most commonly see in the preoperative infants with UPJ obstruction, and 4 is for the poorly functioning kidney. Most of our infants in our study fall between the preoperative infants were in grade 3, that is 83 infants had grade 3 pre-op curve, and most of the transition was from grade 3 to grade 1. That is out of the 96 infants, 59 had 59 had a transition from 3 to 1. And the most common associated anomaly is the VUR. And the operative time was 1 or 2, which is skewed because of the training of the residents. But we had a mean time of 90 minutes in a lot of patients. 10 had a nephrostomy and 3 had a retrograde stent placement. And the duration of hospital stay was 2 days in most of the child. 1 had associated pulmonary agenesis, so she had to stay for 8 days. And the most common complication was a postoperative UTI, and there was a recurrent obstruction in one child who underwent redo pyeloplasty, and she's doing well in the follow-up. To conclude, this is one of the large prospective series, and this renogram grading is the first grading which we like to present to you. And very few papers have used parenchymal growth as an outcome of early pyeloplasty. And with advancement in technological development, standardization of technique, and improved experience of surgeon, LP could be safely and successfully performed even in small infants with an acceptable complication rate and good results. Thank you.
Thank you, Dr. Abhirami, for finishing in time. Dr. Sandeep, you can go ahead with your questions, please.
So good presentation. Just my general question. So although I moved from the government to private sector, do you think that the age of laparoscopic pyeloplasty is decreasing slowly, or is it general that most of your patients are in their infant age group?
So because of the invent of the fetal sonography, and a lot of children are getting picked up with antenatal ultrasound and they're presenting for the counseling, we're able to counsel them prenatally, and a lot of early presentations are there. So.
Because more than 80 to 90% laparoscopic pyeloplasty which we are doing here is less than 6 to 7 months of age. They are presenting early to us in the private setup. That was not true in the government setup. Dr. Panda?
I think so, sir. Your reason, your reason is okay.
So any questions you can ask?
One question, as you are a resident, one question you told that viewer is the most common abnormality associated with most of your cases. How will you tackle a case of secondary PUJ? You will tackle first the PUJ or viewer?
No, sir. We had associated viewers, but we do RGP for all those children, and then we do the pyeloplasty initially, and we'll wait for the viewer to settle down later on with the age. And we'll keep the children on follow-up.
Okay. When you will stop the follow-up of pyeloplasty patients?
5 years, sir. 5 years of age, we'll stop the children for follow-up. If they are uneventful, like if they are doing well with growth and all this.
Okay.
Dr. Anjan, your question, please.
Yeah, very nice, decent series and outcomes. Just a quick one. Correct me if I'm wrong, I saw that the mean preoperative SRF was 40. So that means there would be some patients who had SRF of more than 40, is it?
Yes, sir. We had SRF of more than 40, but there is a very like the obstructive curve was significant, so that, and there is an increase in the parenchymal increase in the APD also. Like if it is more than 25 or 30, we'll take up the child for pyeloplasty.
So yeah, so because a school of thought would be believing that we could have waited and watched, unless of course those parameters that you told were forcing you to opt. But otherwise, I think even the grading, is it a published one?
No, sir, it's not published. He has introduced to common cases only. He introduced it.
Yeah,
he said, sir is trying to publish it.
Yeah. Yes. You should seriously think of publishing that, collaborate with them and publish if it is really useful. And because you devoted your 4 slides on an unpublished grading, you should first try to get it published, right? Thank you.
Yes, sir. And that grading was very useful in a child. In one child, we had a single side functioning kidney. The other side was a non-functioning kidney. And this grading really helped us in picking up the obstructive pattern. Yes, sir. Yes.
Thank you.
Because of lack of time, we are not asking questions related to that grading, because it can be a whole seminar on that.
Yes, sir.
Yeah.
Meanwhile, Doctor, for the previous presenters, Dr. Abraham had even a nice comment. You could just go through the chat box. Over to you, Dr. Monica.
Yeah, thank you, Dr. Abhirami. Dr. Parker has made a very nice comment that ideally the follow-up of hydronephrosis is much more than 5 years. Initially, there is a honeymoon period, and later on, these children do have problems and they come back. So you should take care of that. Thank you. We'll move on to the next speaker, Dr. Aditi.
Good morning, ma'am.
Start sharing your screen, please.
Yes, ma'am. Am I audible, ma'am?
Yes, you are audible.
Is my screen visible?
Yes, you can start your presentation. You have 4 minutes to present.
Yes, ma'am. Good morning, everyone. This is Dr. Aditi from KEM Hospital, Mumbai, and I'll be presenting our experience of laparoscopic pyeloplasty in pediatric surgery. Our aim is to study the safety, efficacy, feasibility, and success of laparoscopic pyeloplasty in pediatric patients. It is the main cause of hydronephrosis in childhood, and as the experience is limited in published literature, we present our experience of laparoscopic pyeloplasty in children. Our total number of cases was 30, and the study design is descriptive retrospective. Study period is from October 2017 to April 2021, and age range of children was 4 months to 11 years with a mean of 5 years. All patients underwent laparoscopic Anderson-Hines dismembered pyeloplasty. Inclusion criteria were antenatally or postnatally diagnosed cases of PUJO on follow-up with either USG showing increasing hydronephrosis, progressive deterioration of renal function on scans, persistent pain or palpable PUJO. USG parameters like parenchymal thinning, anteroposterior diameter, RI index, and pyramidal thickness were used. We also used parameters like corticocalicial transit time, Tmax, T2R retention more than 60%, and obstructed renal excretion curve. The position of the patient was lateral or semi-prone with bolster under the flank. Camera port is either 5 mm 2D or 10 mm 3D camera port at the umbilicus, and working ports are two in epigastric and suprapubic or contralateral flank. With earlier we used to use 5 mm ports, now we use either 3 mm ports or direct instruments. Opening is made in the mesocolon. This is a case of left-sided PUJ obstruction patient, where opening is made in mesocolon followed by identification of ureter and PUJ. Stay suture taken on pelvis, orientation suture on the ureter, a marking suture on superior pelvis and anterior pelvis to help us identifying the extent of reduction of pelvis. Redundant pelvis is disconnected after spatulating the ureter. Posterior layer of uretropelvic anastomosis is done, followed by DJ stent insertion and confirmation of position of DJ. Anterior layer of uretropelvic anastomosis, followed by closure of pelvis and mesocolon. We keep the patient lateral or semi-prone with bolster under flank. A flatus tube is placed per rectally to deflate the colon, especially in left pyeloplasty. Percutaneous hip stitch is taken over the pelvis for easier elevation. PUJ we keep connected to the ureter while spatulating the ureter for ease of spatulation. A marking stitch is taken on lateral part, and we use intracath number 16 as with guide wire for placement of DJ in antegrade placement. Bladder is filled with dilute betaine to confirm its flow from proximal end of DJ, and we remove the periurethral catheter while holding DJ before anterior layer of anastomosis. Parameters assessed were duration, intra-op blood loss, length of stay, conversion to open and post-op complications, and we followed up the patients by USG and EC scan at 6 months. Out of the total 30 cases, 3 were done by 2D and 27 by 3D laparoscopy. There were 20 boys and 10 girls. 18 patients were left-sided, out of which 13 were approached by transmesocolic approach, which was easier, and 5 by retrocolic. 1 had to be converted to open for difficult DJ insertion, and 12 were right-sided, out of which 10 were retrocolic. Our median duration of surgery was 3 hours, intra blood loss minimal, median hospital length stay was 4 days, and need to conversion was 1. Minor complications like post-op ileus and fever were managed conservatively, and DJ stent migration was present in 1 patient, for which we did cystoscopy and pushed the DJ in with the scope. Preoperative PCN insertion was done in 2 patients, neonates with giant hydronephrosis with pyonephrosis and unsettling RFTs, and the surgery was done later on. DJ stent insertion was antegrade in 28 and retrograde in 2 patients. 25 patients have completed 6-month follow-up, and scans show improved excretion. There were a few special cases in which 2 had posteriorly rotated pelvis, 1 had bilateral PUJO, 2 had lower pole crossing vessels where anastomosis was done anterior to the vessels, and in 2 cases we did interval lap appendectomy and stage 1 Shihata traction orthopexy along with pyeloplasty. This is our comparison as index series along with the other published literature, in which we have 96.7% success rate. First, pediatric series of transperitoneal laparoscopic Anderson-Hines pyeloplasty was published by Tan in 99 in 18 children. Laparoscopic management has evolved rapidly in the past 20 years and continues to do so. Apart from advantages of laparoscopy, for pyeloplasty, there is better identification in abnormal anatomy like anomalous vessels and horseshoe kidney. Disadvantages are steeper learning curve and long operative time in the initial cases because of difficult spatulation or intracorporeal suturing. We would like to conclude by saying that laparoscopic pyeloplasty is a safe, efficacious, and feasible approach with excellent cosmetic outcomes even in infants. Thank you.
Thank you, Dr. Aditi. You have exceeded your time. In your slideshow, it says it's more than 1 minute, 30 seconds. However, in my system, it says about 45 seconds. Anyways, I request Dr. Anjan to ask the questions.
Yeah, Aditi, nice presentation. How do you think your findings are different from what data we have already exists in the literature?
So this is just our experience of laparoscopic pyeloplasty. We also have done 3D cases, which are 27 out of 30 patients. And 3D cases especially have a lot of advantage over 2D as the learning curve is lesser.
I think that was not your that was not part of your presentation. That's fine. Tell me the success rate that you have quoted and the literature that you have shown. Why do you think there is a marked difference in your case? What could be the reason, or it is same? I thought it's slightly higher.
It's slightly higher, sir. The number of cases also that we've used is higher. It's probably because of the few things, the few steps that we do, the precautions that we take. Like
I think it's too early. The issue is it's too early to say
yes,
that. That you have to answer.
Yeah.
Dr. Sandeep?
So, my question is, what is your average age?
5 years. Median age was 5 years.
And in the conclusion, you have told about the infant pyeloplasty. So are they matching with each other?
Yes, sir. Out of 30 patients, 10 were infants in our series.
Okay. So the point is that we were presenting a data. Obviously, if you are concluding something, it should be based upon your presentation. So obviously, 1/3 of your patients were only infants. You can say that only 1/3 of the infant patients were there. Dr. Panda?
One quick question. What is the indication of RGP in 2 cases? You have mentioned in 2 cases you have done RGP.
So we had to do a scopy in 2 patients. Cystoscopy for difficult DJ insertion. We had to confirm the position of the DJ from below by doing a cystoscopy, whether it has reached the bladder. The antegrade insertion of DJ stent was difficult. That's why intra-op cystoscopy was done.
And in both cases, DJ stent was inside the bladder.
Yes, sir.
Okay. If there is difficulty in DJ stent insertion antegrade, then what are the other techniques described laparoscopically?
Sir, retrogradely we can try inserting the DJ.
Okay.
Via cystoscopy, by inserting a guide wire and guiding the DJ stent over it.
Okay.
Or in the cases if it is not possible, we can have the option of placing a nephrostomy tube via inserting a Maryland in the calyx in one of the calyces and then guiding a tube like an epidural catheter or a pigtail catheter externally, which will help us in protecting the anastomosis and draining the urine, draining the pelvis.
In any of your cases as urinary leak in the post-op period?
No, sir, no urinary leak in any of the patients.
That means nowadays you are not putting drain.
No, sir, we none of our cases we have put drain.
Thank you.
Thank you, Dr. Aditi. The next speaker is Dr. Chandramouli. Dr. Chandramouli, you can start sharing your screen, please.
Yes, ma'am. Is the screen visible and I am clearly audible?
Yes, you are visible as well as audible. You can go ahead with your presentation. 4 minutes.
Okay. Good morning, respected judges, chairpersons, delegates, and seniors. My name is Chandramouli Goswami, and I am presenting our experience with single port laparoscopic surgery from the Department of Pediatric Surgery, AIIMS, New Delhi. I have no disclosures. Laparoscopic laparoendoscopic single-site surgery was popularized due to minimal scarring and incisional pain relative to conventional laparoscopic surgery. However, problems like difficult access, lack of triangulation, and lack of customized instruments often challenges us. Aim of our study was to establish feasibility of use of an intra-umbilical coaxial scope in various pediatric surgical procedures. This prospective study was continued for 7 years. Patients operated by coaxial scope through the umbilicus by a single surgeon were included. Several parameters were observed for analysis. Transabdominal peak and fix suture is a surrogate port for laparoscopic procedure. The operative laparoscope necessitates insertion of 12 mm port. Our standard approach is intra-umbilical insertion, that is through the umbilical cicatrix with meticulous reconstruction at the time of port closure for maximal aesthetic benefit. The 6 mm working channel of this scope allows us to dispense with one of the additional 5 mm ports. Sutureless appendicectomy developed at our department consists of anchoring mesoappendix to the anterior abdominal wall by an extracorporeally inserted pick and fix suture, followed by dissection and division of mesoappendix and appendix only by harmonic scalpel. One of the major difficulties of pick and fix stitch is to achieve proper organ retraction. The string puppet technique is a useful maneuver to overcome the problem, and it can be used in any areas of abdomen. In hammock stitch, insertion of a loop of one-of-proline suture was done under vision through the right upper quadrant into the fundus of gallbladder. This resulted in the loop of suture emerging out of the fundus. Another nylon suture was introduced in the same manner through the body wall and then through the Hartmann's pouch with the needle tip directed into the loop of the proline as a sling. Nylon thread was then pushed in while simultaneously withdrawing the needle. On placing the traction on this suture, callus triangle was opened up and dissection was continued. This photo showed the intraoperative view. 76 patients were selected in the study with a mean age of 6.5 years with slight male preponderance. Patients with cholelithiasis followed by appendicitis were majority. Laparoscopic cholecystectomy and appendicectomy accounted for majority of the procedures. Of the total number, almost 42% were single port procedures. Mean operating time for a single port and conventional laparoscopy was comparable. Mean hospital stay was 4 days, and they were allowed orally earlier as compared to conventional laparoscopy. There were 9 conversions to conventional laparoscopy and 1 to open surgery. 4 cases of umbilical erythema and 1 with surgical site infections were reported, and 1 patient developed bile leak who was managed conservatively. Swift learning curve, cosmesis, and patient satisfaction outweighs the negative sides of umbilicoscopy. Single incision can be hidden under the belly button and a far less disfiguring scar. To conclude, better cicatrix, to conclude, better cosmesis, shorter hospital stay, and lesser postoperative pain and early return to activity favors the use of umbilicoscopy. With further popularization, this could revolutionize the laparoscopic surgery. Thank you all for giving me this platform to present. I would also like to thank all the faculties and seniors of our department.
Thank you, Dr. Chandramouli, for finishing before time. I request the judges for the questions and comments, please. Dr. Sandeep.
So I think we have heard this and it was presented earlier in one of the conferences also. And after learning from Dr. Bajpayee, we are utilizing those techniques. Nomenclature sir has published earlier, I think in the literature also, the pick and etc. technique which we have described. So is the same or something different from the earlier presentations?
Yes, sir. In the earlier presentation, the pick and fix stitch was described only for the surgery for acute appendicitis in laparoscopic appendicectomy. But in this study, we have selected 76. We have done this study for 76 cases of including appendicitis, cholecystectomy, and urological procedures like orchidopexy. And even for our pseudocyst drainage was done.
So you have expanded the horizon of that technique. That's why we are presenting.
Yes, sir.
Dr. Panda.
One quick question: what are the indications to convert the technique to 3-port technique?
Sir.
Procedure?
Yes, sir. Sir, we had converted 9 surgeries to conventional laparoscopy. These 9 were Of these 9, 5 were for, sorry, 7 were for laparoscopic cholecystectomy. In this, the use of the hammock stitch could not clearly demonstrate the callus triangle due to some additions. So in these 5 cases, it was converted to open, and in the rest, the 2 pseudocysts, it was also opened because they were having some difficulty while while doing cystogastrostomy. So total 9 cases were converted to open 3 ports.
And you have not utilized any Laga clip, etc. on the cystic duct. You have used harmonic.
Yes, sir. We have used only harmonic. Sir.
And there was one bile leak.
Yes, sir. There was one bile leak, but it was not significant, and it was only managed by pictal drainage.
That's
Dr. Anjan, your quick question, please.
I think you have to spare me. I'm from the same department, so I'll mark him although unbiased. But
okay, thank you so much. We have some few senior people with us in the hall. Dr. Partha Pratim, sir, would you like to give any comments?
Yeah, it's a good technique. No comments.
Thank you, sir. Dr. Ravi Ramadwar, sir. I can see Dr. Mohan Abraham also. Sir, do you have anything to add to it or any other comments? Okay. Thank you, Dr. Chandramouli. Dr. Abhishek is the next speaker. I think he is not there. As for the last presentation, not the least, Dr. Shamendra Pratap Sharma. Yes, you can start sharing your screen, please.
Okay. Yeah, my presentation is visible?
Yes, it is visible. You can start your presentation.
Okay.
4 minutes.
Greetings from SGPGI Lucknow. I am Dr. Shaman Pratap Sharma, PDF in Department of Pediatric Surgery. Laparoscopic adenectomy, after its introduction in 1992, became the gold standard for adenectomy in adults. However, in children, experience is limited due to various factors as infiltrative nature of the tumor and technical challenges in small children. We aim to share our experience of laparoscopic adenectomy of solid tumors in children. This is a retrospective chart review of 5 years. All the children with localized adrenal tumor without vascular encasement and adjacent organ involvement are included. Study variables like clinical feature, diagnostic workup and intra and post-op variables were recorded. Pre-op workup include hormonal workup and imaging studies. The patient were admitted day prior to the surgery. Routine bowel preparation is not used. Adequate blood pressure control was achieved in all children. Perioperative steroids were used if required. The technique of right adrenalectomy via lateral transperitoneal approach. Here we present a 3-year-old girl with precocious puberty. She had a 6 into 5 cm right adrenal mass as shown in CT. Serum estradiol and DHEA were raised. The lateral transperitoneal approach is used. The child is placed in position as shown and we use 4 ports. The first step on right side is to divide the right angular ligament of the liver. The liver is retracted. Short and wide adrenal vein is dissected, clipped and divided. The adrenal tumor dissected all around. The small adrenal arteries arising from renal artery and aorta were carefully dissected and divided. The normal adrenal tissue is removed along with the specimen. The specimen placed in the endo bag and removed through the large port site incision. Child may undergo event-filled recovery. Histopathology showed adrenal adenoma. For laparoscopic left adenectomy, lateral transperitoneal approach is used. Here we show 6-year-old boy with Cushing syndrome. The CT scan shows 5.4 into 4.8 cm adrenal mass. Serum cortisol and DHEA is elevated. Again, lateral approach is used with 4 port as shown in figure. On entry, we see increased fat in peritoneum. First step to mobilize the left colon. The spleen and pancreas reflected medially, exposing the left adrenal mass. Tumor is dissected all around. A small adrenal artery dissected, clipped and divided. After separation of the tumor from upper pole of the kidney, The left adrenal vein is seen, dissected, clipped and divided. The specimen was removed through enlarged port site incision. Histopathology shows adrenal adenoma. At the 6 month of follow-up, the child is asymptomatic with normal hormonal profile and imaging. Total 9 children were operated during 5 years. Mean age is 52 months. 5 children have hormonal active tumor. Tumor was common on right side. Mean tumor size was 5.8 centimeter. Most common diagnosis was adrenal adenoma. Mean operative time was 90 minutes. No conversion. Rapid post-op recovery noted. Mean hospital stay is 5 days. At mean age of the follow-up of 37 months, all children asymptomatic and no recurrence is noted. So on conclusion, laparoscopic adrenalectomy for solid adrenal tumor in children is feasible, safe and effective, but should be reserved for localized well circumscribed masses. Surgery should be done in experienced center. Thank you.
Thank you, Dr. Shamendra, for finishing absolutely in time. Dr. Sandeep, you can go ahead with your questions, please.
So good presentation. One again technical point. I've noticed that in none of the children we have placed camera port at umbilicus.
Yes,
So
sir.
is there any advantage of placing the port in the left flank?
Sir, we have done that for 5 port or 4 port laparoscopy, and the camera port is placed in the umbilicus, sir. It gives a good visualization, sir.
But here on both of the photographs, we have marked that the port was not at the umbilicus. The camera port was not at the umbilicus side. It was more on the left flank. That's why I asked this question in the videos and the photograph which you have shown.
Sir, we have placed the port in, sir, one case I have shown that is Cushing syndrome baby. We have put the camera port in umbilicus because the baby is fat is more, so little port entry is very much difficult. But in the first case, we have placed the camera port just in the right flank. Right side of that iliac fossa or between the spino-umbilical line. Because the length is vision is more in that port. We are using open technique for that.
Okay. Dr. Panda.
Okay, one basic question while doing adrenalectomy, what important complications, intraoperative complications you expect, and how will you poke your anesthetist?
Yes, sir. Adrenal crisis may occur, but we have very good pediatric endocrine department. They tell us about that pre-operative steroid dose, intraoperative steroid dose, and post-op steroid dose to tackle this crisis, because that higher due to suppression of ACTS, that we are removing one adrenal also. So this adrenal crisis may occur. So we give intra and pre-op, intra-op, and
sorry for
post-op
interrupting.
steroid.
Time is over.
Hello.
Hello. You can go ahead with the last question, please.
Okay, ma'am. Yes, sir. We tackle, sir, in right side, that adrenal vein is very short and directly draining to the IVC. So we firstly ligate that, dissect and ligate that adrenal vein, then go for adrenal arteries, which are multiple and tackle with the harmony.
Okay.
There's one question from Dr. Partha Pratim. Sir is asking, do you tackle the vessels first before trying to excise?
Yes, ma'am. We first dissect that vessels. That on right side we took the vein first because it's very short and directly draining to the IVC. So the tumor may stretch the vessel. So we first dissect vessel and ligate it, and then thorough dissection of the tumor is done, and then arteries and other vessels ligated.
Thank you, Dr. Shemendra. A quick question from Dr. Anjan and Dr. Panda.
Yes, ma'am.
Dr. Shemendra, nice presentation and
Yeah,
it
thank
was
you.
good to share it with us.
Yes,
Just a quick point about when would you think about using a retroperitoneal approach? I can
Sir,
understand your tumors are quite large
yes,
and
sir.
it's better to go transperitoneal.
Actually, sir, we have no experience in.
No, I can understand. I'm just saying,
Yes, sir.
when would you choose? I mean, when will you think about, okay, let's approach it from the retroperitoneum? What would be a good selection for selecting a case? What would you look for?
Sir, size of tumor may be less than 2 centimeter is.
Think over it. Okay. Thank you.
Yes.
And Dr. Panda, the last question, please.
No, ma'am. Thank you. I have asked one question. I think it's time.
Okay, thank you so much.
Thank you.
Thank you, Dr. Shemendra.
Thank you.
With this, we end with this session. I thank all the three chairpersons for adjusting with us, accommodating with us at the very last moment. I hope you have all submitted the sheets after marking them. And with this, I conclude this session. Thank you so much. Thank you all the speakers. Thank you all the judges for a wonderful discussion and a well-presented session. I hand over to Dr. Nitin, who will be taking over the oncology section. Good morning, Dr. Nitin.
Good morning, ma'am. Nice to see you.
Same here. So I hand it over to you.
Thank you, ma'am. So good morning, all honorable judges, respected senior members, and all the speakers in the first oncology session. This is a 5+2 session, and please stick to your time. You will be prompted around 30 seconds before the end of your presentation. So I'll invite Dr. D'Souza. Dr. D'Souza, are you here?
Yes, sir.
Yes, please share your screen and put your video on. I request all the others in the hall to please mute themselves.
Is my voice audible and the screen visible, sir?
Absolutely. Please put it in share screen and slide show and go ahead with your presentation.
Yes. Good morning, everyone. I am Dr. D'Souza from St. John's Medical College, Bangalore. I'll be presenting on the surgical etiquette of pediatric ovarian tumors. So as we know, ovarian tumors are very uncommon in children, and about 1/3 of them are malignant. Germ cell tumors predominate, unlike the epithelial neoplasms that are seen in adults, and surgery is the primary treatment with emphasis on preservation of ovary and hence fertility. Preservation of fertility is now the norm in pediatric ovarian tumors. So our aim was to study the behavior of pediatric ovarian tumors and to highlight any divergence from the natural course, as the case may be. This was a retrospective analytical review of over 10 years. We included children from the neonatal to 18 years of age who were admitted and treated in our department. The total number of patients was 53, and all were investigated with tumor markers and ultrasound scans. Among the 53 patients, 12 were neonates and 10 were between 1 month to 5 years of age, and about 31 were above 5 years of age. 31 of these tumors were right-sided, with only one child presenting with a bilateral tumor. Out of the 12 neonates, 8 of them were detected antenatally to have an adnexal cyst, which was confirmed later on ultrasound postnatally. And the most common symptoms were abdominal pain, followed by an insidious or an insidious mass abdomen that would probably be detected by the attenders, an acute abdomen in cases of torsion. Overviewing the pathology, torsion ovary was the most common pathology. Malignancy was detected in 12, and about 10 were benign cysts. One child diagnosed as an ovarian tumor with an ultrasound was found to have tuberculosis. 12 patients were conservatively managed and kept on serial follow-up ultrasound scans. Surgery was done in 41. 65% of these underwent unilateral oophorectomy. 34% underwent oophorectomy with a contralateral oophoropexy. 10% underwent marsupialization with or without oophoropexy, and one child underwent bilateral oophorectomy. 23% were neonates, with almost all of them detected antenatally. 85% of the tumors were benign, unilateral with right-sided predominance. 20% were managed conservatively, and ovarian torsion was the most common pathology across all the age groups. A few cases that we would like to share. This was a 14-year-old girl who presented with pain abdomen and menstrual irregularity. Ultrasound picked up a bilateral tubo-ovarian mass, and laparoscopically we could see some peritoneal nodules with bilateral tubo-ovarian masses. And hence we subjected this child to just a biopsy. And the biopsy AFB was seen, and she was promptly started on anti-tubercular therapy. She's doing well on follow-up. This child was detected in the antenatal period to have bilateral ovarian cysts and was postnatally confirmed. The laparoscopy revealed a firm mass, and hence a biopsy was done which showed a gonadoblastoma. And after counseling the attenders, and she underwent bilateral oophorectomy, she had a normal 46XX female karyotype. This was another child with a 5-year-old with isosexual precocious puberty and mass abdomen and menses. She had high estradiol levels and a huge mass abdomen which was insidious in onset. This was the tumor, a large size tumor, which turned out to be a juvenile type granulosa cell tumor. These are found to be higher in size, more in size than their adult counterpart, and these are functional too. So on follow-up, the menses, once excision was done on follow-up, the menses have stopped, but the thelarchy and the pubarchy that had started have remained dormant. Mixed or immature germ cell histology was found to constitute maximum of our malignant tumors, and these were all amenable to chemotherapy and surgery. Primary ovarian tumors in children include a diverse group of both benign and malignant lesions. Incidence, presentation, imaging, histology are very distinct from those in adult. Tumor markers and imaging characteristics will help in differentiating benign and malignant tumors, and ovarian sparing surgeries increasingly proposed, especially in centers that have facility for frozen biopsies. In conclusion, these ovarian tumors, though uncommon, they are a cause of great anxiety to the parents and a challenge to the surgeon. Routine use of ultrasound has increased the incidence of antenatal detection, and the role of contralateral oophoropexy following unilateral oophorectomy is debatable. Minimal invasive surgery favoring ovarian salvage and preservation of fertility will ensure favorable outcome. Thank you.
So thank you, Dr. D'Souza. You finished well in time. So I'd request the honorable judges, Professor Binde Kumar sir, Professor Sushmita ma'am, and Dr. Devendra Yadav to take up questions. Dr. Binde sir.
Dr. D'Souza, am I audible?
Yes, sir. Yes, sir.
Your data is 53% patients. So 65% of 53% patient has gone oophorectomy.
Yes, sir.
But the malignancy was there only in 12 cases. That is 40%. So you can tell me, for 23% is benign conditions, why oophorectomy was done?
So benign conditions, oophorectomy would be a torsion ovary that would be present. The ovary would look very gangrenous on table, and the biopsy would not come as anything malignant. And that is why these oophorectomies were done for these benign patients.
So the next question, corollary to that question is,
yes,
you have told the torsion. Torsion is a complication. It's not a pathology.
Yes,
and if any normal ovary doesn't go for a torsion. So can you tell me the higher number of torsions, what pathology was there, benign pathology?
So with higher number of torsion, we had benign pathology. Most were just ovarian cysts, probably large size ovarian cyst on a pedicle which would have torted, and they presented with acute abdomen.
Dr. D'Souza, that is
Yes,
the point I was making. So ovarian cyst and giving the ovary preservations, it is very easy to take the ovary out, but to preserve it requires a lot of guts. So why all the cases went for the ovarian cystectomy? Why not preserve it? What were the limitations?
Yes, sir. So initially, if they were outrightly gangrenous on table, we would definitely do a oophorectomy. But in the recent years, our practice has, this is over 10 years, sir. In recent years, our practice has moved towards detorsion and oophoropexy rather than a direct oophorectomy, which would have been done in earlier years.
So that's all from my side. Thank you very much, Dr. Nitin.
Thank you, sir. Thank you. Sushmita ma'am, a quick question from your side.
Yeah, Dr. D'Souza, you mentioned about oophorectomy even in neonatal. So I would like to focus. Binde sir has taken care of lot many other matters, but specifically neonatal. What was the indication for intervening in the neonatal period? And specifically because all of them have been cysts except one, gonadoblastoma. Am I right?
Yes, ma'am.
So what was the criteria or indication for doing surgical intervention in these patients and also doing oophorectomy in these neonates?
These would be ovarian tumors which would have been reported torsion. So
how many of these neonates ended up with torsion? You said they were antenatally detected,
yes,
and they were operated in the infantile period. So
yes,
we don't have that slide which gave us the exact classification of when who was operated at what age. So
yes,
these antenatally detected, you would have you waited for all of them to develop torsion and then did you operate, or how did you decide to operate on these neonates?
Ma'am, these neonates would be antenatally detected to have an ovarian lesion or adnexal cyst. Postnatally on the ultrasound would be reported as torsion. And the child would have features of probably of decreased capillary filling time, of shock, of sepsis. Only in those cases we have gone in and done these surgeries. And huge size of
so I don't still have a clarification on the number of cases
yes,
who had torsion and whom you operated of the overall number of neonates who presented with ovarian. If you have the number, you can give it to me, or otherwise it's okay.
Ma'am, 4 patients in our study out of the 12 neonates that we had, 4 of them had torsion, and 4 of them out of the 3 underwent oophorectomy, and 1 of them we just detorted and had a PEXI done at that time.
Okay, thank you.
Thank you, ma'am. Dr. Devinder, any comments from your end?
Just one question my side. In cases of ovarian tumor with solid masses, what is your criteria for preserving the ovary? Did you do frozen?
Sir, I'm not able to hear the question, sir.
Sir, could you please repeat your question? Maybe, sir, you could type your question in the chat box. You're not able to hear your voice clearly. And Dr. D'Souza can answer it in the chat box. So we'll move on to the next presenter, Dr. Gaikwad from Vellore, and welcome Vivek. Please share your screen. Yeah, Vivek, please go ahead. He's talking about his experience from Vellore about pulmonary metastectomy. Go ahead, please.
Are you able to see the screen, sir?
Clearly. Please go ahead, Dr. Vivek.
Good morning. My name is Vivek Gaikwad from CMC Vellore, and it gives me immense pleasure to present to you long-term outcomes and prognostic factors affecting after pulmonary metastectomy in solid tumors of childhood. This is a single-center experience. Oh, I'm sorry, my screen is not moving. Can I just log in again? It's got stuck.
Yes, please do that, Vivek. You're not moving.
So for screen to move, you just have to click on the presentation. That's it. Go on the full screen mode, please. Now click.
Is it visible now, sir?
Yes, it is. Thank you.
Management and prognosis of metastatic solid tumors in pediatric and adolescent population has significantly evolved from palliation to a highly specialized multidisciplinary approach, often with a curative intent. It is modern surgical dogma that pulmonary metastectomy be undertaken only after complete clearance of the primary tumor, after confirming the absence of extrapulmonary metastasis, and ensuring sufficient residual pulmonary reserve. This study seeks to assess the long-term survival and the prognostic factors affecting survival following pulmonary metastectomy to solid tumors in children. All children and adolescents at or below 16 years of age are diagnosis of the primary tumor who underwent treatment in our institution for solid tumors with isolated lung metastasis and also underwent pulmonary metastectomy in our department over a 13-year period were included in the study. Patients were divided into those in whom pulmonary metastasis was their diagnosis and those that occurred at relapse. For those in whom pulmonary metastasis occurred at relapse, Disease-free interval was defined as a period from resection of the primary tumor until detection of metastatic pulmonary disease. Response to chemotherapy was defined as good if there was radiological evidence of decrease in size or number of nodules or both. The converse was defined as poor. Completeness of resection was defined as complete clearance of all tumor, including any pleural extensions, as evidenced by CT or PET CT. The outcomes assessed were post-surgical overall survival, event-free survival, and the prognostic factors affecting survival. Overall survival is defined as the period from pulmonary metastasis to the last follow-up or death of the patient. An event was defined as recurrence, progression, or death. A total of 22 patients were included in the analysis. The median age at diagnosis was 10 years. There was a male predominance. Pulmonary metastasis was noted at diagnosis in over half the patients, while 2 developed metastasis while undergoing therapy, chemotherapy that is, and 8 after completion of therapy. Disease-free interval was 20.5 months. Looking at the histological subtypes, high-grade osteosarcoma followed by Wilms tumor were the most common histological types encountered. 16 patients, unilateral nodules were present in over half the patients in a peripheral subpleural location, and these were the most common locations. Pleural extension was noted in over half of the patients in our study. 16 patients received chemotherapy prior to pulmonary metastacectomy, and 6 patients underwent upfront pulmonary metastacectomy. Among those 16 that received chemotherapy prior to pulmonary metastacectomy, only 3 patients demonstrated a favorable response, which was confirmed radiologically. And out of these, 2 were having Wilms tumor and 1 neuroblastoma. The median size of metastatic nodules was 2 centimeter with a median number of 2. There was an agreement between both the number and size of nodules detected by imaging and those discovered at the time of surgery. The interval for the surgery of a primary lesion and metastacectomy is 11.5 months. Open thoracotomy was done in 18 patients, while thoracoscopic surgery was done in 2, and a combined approach was undertaken in 2 patients. Most patients underwent a wedge resection, with 2 having a lobectomy. Completeness of resection was achieved in 95.5% of our patients. The median postoperative hospital stay was 3.5 days. 2 patients developed transient complications in the form of bronchopleural fistula and postoperative pneumonia, which resolved with conservative antibiotic management. The
last 30 seconds, Vivek.
Yes, the median post-op pulmonary metastasis follow-up was 15.5 months with a 31.8% survival. The event-free survival was 4.5 months with the overall survival of 15.5 months. Of the various factors analyzed, including histology, completeness, disease-free interval, location, laterality, number, size, response to chemotherapy, extension into the pleura, and mode of access, the only prognostic factor associated with outcome was found to be preoperative response to chemotherapy. The limitations of our study included a small sample size with inadequate representation of various histological types and limited follow-up period. In conclusion, pulmonary metastacectomy offers long-term survival in a select group of individuals. Favorable preoperative tumor response to chemotherapy is a significant prognostic factor influencing survival according to a study. Thank you very much.
Thank you, Dr. Vivek. You've exceeded your time by around 30 seconds. I'll just take one question each from the judges. Professor Binde sir, your question here. Dr. Binde Kumar sir.
Presentation and I appreciate the effort made to make the patient, and that's all from my side.
Thank you.
Thank you for that comment, sir. Ma'am, Sushmita ma'am, your comments.
I wanted to ask you, when the patient had not responded to primary therapy, that is the neoadjuvant chemotherapy, then why were they subjected to pulmonary metastacectomy? Because when the patient has not responded to therapy, then how would pulmonary metastectomy help in tumor-free survival or even recovery of the patient?
Yes, the patient had no other evidence of extrapulmonary metastasis, and as you said, this actually was discussed in our pediatric oncology tumor board meeting, where this was found to be the only viable option for the patient to offer a chance of survival, and hence this was embarked upon. As you said, it mostly was futile in most of the patients.
Right. So 15 patients did not make it. They
Yes.
expired. So out of 22, 15 patients expiring is probably it means that you have concluded also that unless there is a good response to therapy before undertaking pulmonary metastectomy, it's not really useful. And you mentioned it is futile. So, and this is very well known actually. So that is why I asked this particular reason for subjecting the patients to surgery.
Thank you, ma'am.
Nitin,
Dr. Devinder, any
just
point?
one question from my side. Nitin?
Yes, sir. Yes, sir. Please go ahead, sir.
Just ask a question. What he will prefer for the metastectomy, open thoracotomy or thoracoscopy?
I think we have been very badly bitten by attempting thoracoscopic resections, especially in osteosarcomas, because we lack the tactile and visual perception, and inevitably we'll end up missing nodules, taking out erroneous specimens. So I think in oncological surgery, at the moment at least, open surgery in our experience has been better. All the ones who underwent thoracoscopic resection developed recurrence and had an adverse outcome in our study.
The tactile, especially in deep-seated lesion, tactile sensation is needed most of the time. That's why I think
Yes. Tactile and visual both are, lacking.
Thank you.
Thank you, sir. Thank you, Dr. Vivek, for a crisp presentation. Dr. Rohit Kapoor,
Yes, sir.
could you please share your screen?
Yes, sir.
Yeah.
Sure, sir.
So, yeah, thank you. Rohit, please start and please stick to the time.
Yes,
Whenever
sir.
you start, I'll start the clock.
Shall I start, sir? The screen as well? Yeah.
Yes,
Thank
yes.
Greetings from Sanjay Gandhi Institute, Lucknow. Today we'll be sharing our experience of ovarian masses in children and adolescents. Now, pediatric ovarian masses are rare, comprising 1% of all tumors in children. The presentation is often variable, and pathology ranges from functional ovarian cysts to benign to highly aggressive malignant tumors. The imaging techniques and tumor markers help us to differentiate benign from malignant lesions preoperatively, and the ovarian preservation is aim variable possible. This study aims to review ovarian masses in children and adolescents treated at our institute with emphasis on presentation, diagnosis, treatment, and outcome. It was a retrospective observation study conducted in the last 12 years that included all the patients below 18 years of age who underwent surgical treatment for ovarian masses at our institute, and the patients operated elsewhere were excluded. According to histopathological diagnosis, the patient cohort was divided into two groups. Group 1 comprised of non-neoplastic and benign histopathology lesions, and Group 2 comprises borderline malignant and malignant histopathology lesions. The study variables were recorded. The benign lesions were operated upfront, either by a lab or open technique. For malignant lesions, either an upfront surgery was done or surgery was done after neoadjuvant chemotherapy, and all the patients were operated using open technique. Chemotherapy was given in almost all the patients with malignant or benign malignant pathology. Now, we'll not demonstrate our technique of laparoscopic left side finger oophorectomy in an index case of 11-year-old girl with the MRI picture as shown here. This is the patient position, and we use 3 ports. Now, I'll demonstrate a short video. Here we can see left ovarian tumor. We cannot see left ovary separately. We identify left ureter before starting the dissection. The left ovarian vascular pedicle is dissected, clipped, and divided. Broad ligament is then divided with the help of harmonic. We now make a window below the fallopian tube, and the fallopian tube is then clipped and divided. The specimen is removed from the broad ligament.
The specimen is now free, and we place the specimen in an endo bag. An endo bag is then removed by an enlarged right inguinal port incision. Now, the intraoperative and postoperative course of this girl was uneventful, and the child was discharged after 48 hours. Histopathology of this patient showed mature teratoma, and at the follow-up after 9 months, patient is asymptomatic with regular menstrual cycle and normal USG. Now, coming on to the results. Now, we had a total of 27 patients, out of which 5 were non-neoplastic and 8 were benign. This constituted group 1, and that forms 48.1% of our cohort. So, and out of the malignant lesions, there were 14 patients having borderline malignant or malignant lesions that constituted group 2, making 52% of our total patients. That included borderline cystadenomas, immature teratomas, dysgeminomas, mixed cell tumors, and juvenile granulosa cell tumors. Now, mean age was comparable in both the groups. Notably, pain abdomen was most common symptom in benign group, while abdominal mass was most commonly presenting symptom in the borderline malignant or malignant group. Now, mean size was larger in malignant group, though this difference was not statistically significant. Now, ultrasound finding was significantly differentiated both the groups, as lesions were predominantly cystic in benign group, while predominantly solid in malignant or borderline malignant group. Tumor markers were also raised in most of the malignant or borderline malignant tumors, and this difference was also statistically significant. Now, open surgery was done for all the patients with borderline malignant and malignant lesions, with 4 patients in benign group undergoing laparoscopic sulfur oophorectomy. Chemotherapy was given in 71.4% of the patients in group 2 with malignant or borderline malignant histology. So, in conclusion, pediatric ovarian masses often pose a diagnostic dilemma, and the real challenge is detecting a small number of malignant or borderline malignant of all the ovarian lesions. The imaging and tumor markers are most important parameter to differentiate benign from malignant preoperatively, as shown in our analysis. Still, management has to be tapered as per histopathology, staging, and patient factors. Thank you.
So you've finished, Rohit. You've just finished exactly on time. Questions from the honorable judges. Professor Binde, sir.
Dr. Rohit.
Yes, sir.
Dr. Rohit, am I audible?
Yes, sir, you're audible, loud and clear, sir.
Can you tell me how your patient with granulosa tumor presented to you?
So, patient with granulosa cell tumor presented to us as a it was a functional tumor actually, sir, and the patient had excessive hairs in the on the body.
It's okay.
And
it's okay.
Yes, sir.
Tell me again. Tell me again.
Yeah, it was a functional tumor, sir. Actually, the child has a history of excessive acne and excessive hair on the body.
So it was a male child or a female child, or isosexual or heterosexual?
No, sir. No, sir. It was a female child.
You have only 4 patients, malignant patients. We're not talking about. And the one patient is one is germinoma, one is dysgerminoma, one is the teratoma.
Yes, sir. Immature
The one
teratomas
is
and
3-4
teratomas.
you were presenting. So, so what type of the functional tumor it was? The male, female, and how?
So, male. It was a female presenting with male. Are you audible, sir? Am I audible? Hello.
Yes, Rohit, you are clearly audible.
Yeah,
Please go ahead.
It was a female presenting with excessive male type features like excessive hair and acne.
So what are the hormone? What are the markers you have seen in the when the female presenting with the male? Heterosexual. What were the markers you went for?
We went for all the tumor markers like.
And the last one, what is the role of inhibin in these patients?
Inhibin, sir. So we went for
That's all,
tumor.
that's all from my side, Nitin.
Right. Thank you, sir. Thank you. Sushmita ma'am, any comments from your side?
Yeah, I was just wondering that you have evaluated all of them with pre-operative alpha-fetoprotein and meaning tumor markers.
Yes.
Then why all were subjected to surgery first? What was the criteria to decide that those who are malignant, where there were raised tumor markers? I didn't see that slide with raised tumor markers and to what extent they were raised. However, I assume that the tumor markers were raised in those malignant tumors.
Yes.
So why were they upfront subjected to surgery?
On CT scan, when they were resectable, there were no any metastasis seen, gross metastasis seen, and on CT scan there was not any addition to the structures. So they were resectable. They seemed resectable on the CT scan. So we go on with an upfront resection in them.
So that slide was missing. That criteria should have come into your presentation.
Yes. Agreed. Yes.
Thank you.
Thank you.
Thank you, ma'am. Dr. Devinder, sir, any questions from your side?
Nitin, just one question from my side.
The next presentation is already running through. Can we not have this presentation because?
Okay.
Yeah. So Dr. Shashwati, please stop sharing. Dr. Shashwati, don't move your presentation, please.
I will type the question, Nitin.
Right, sir. So Dr. Rohit, please look at the chat box and answer to Dr. Devinder Yadav.
Yes,
Dr.
sure.
Shashwati, could you please unmute yourself? Dr. Shashwati, please unmute yourself. You're muted. Can the host please unmute Dr. Shashwati? Dr. Shashwati, please unmute yourself. Can the hall
We can't
manager
hear
please
you,
help?
so please check. Please type in the chat box what is the difficulty, Dr. Shashwati. Please type because we can't hear you at all.
Dr. Shashwati, please type in the chat box if you are having any problems. You can unshare and share again. Please unshare and share again. Okay, there is some problem at her end. She's able to not able to go ahead. We'll go on to the next presenter, Dr. Naveen Kumar. Are you here? Dr. Naveen?
Yes, sir. Yes, sir. I'll share my screen, sir.
CMC Vellore. Yeah, please share your screen. We'll get back to Shashwati. So to just mention to the judges that this is the title of the talk is Management and Outcomes of Pheochromocytoma from Dr. Naveen, and it is not Shashwati's talk. So Dr. Naveen, please, whenever you're ready, we cannot see your presentation.
1 second.
Go to the first slide and start the slideshow.
Is it seen, sir?
Yes, clear.
Is it
Please
visible?
start.
Yeah.
Visible and you're clearly audible.
Yes, sir. Yes, sir. So good morning to one and all over here. I'm Dr. Naveen Kumar from Christian Medical College, Bello, hereby to present a single center experience of management and outcomes of pheochromocytoma. I thank my guides, Dr. Sushin Chahagir and Dr. Juju Jacob Kurian for helping me in all this. So we all know that pheochromocytomas are literally uncommon, and this is called as a neuroendocrine type of tumors, which are derived from the chromaffin cells of adrenal medulla, and which is arising other than adrenal medulla, these are called extra adrenal pheochromocytomas, which are also called as paragangliomas, or it can be a component of polyglandular endocrine disturbances or associated with any other neuroectodermal tumors. But we all know that usually it is recognized as an isolated finding. Because of its variable clinical manifestations and proper diagnostics for pheochromocytoma, it is always a high index of suspicions. Our aim and objective in this study is to analyze the clinical characteristics, management, and long-term outcomes, and also to correlate the histology and phaeochromocytoma adrenal gland scale score with its outcomes, which is commonly done in case of adults and not usually done in case of children. So coming to the materials and methods, it is a retrospective analysis which we conducted from January 2009 till December 2020, including the age group up to 18 years. And the mean is around 24 patients we just got. So the demographic data comparing to male and female ratios, we have a male of around 15 and female of around 19. The usual average age of presentation is around 17 years, with the mean is around 13 to 18 years. And comparing to the side, left adrenal lesions are around 5 and right is around 9, and bilateral involvement is involved in 4 types of children, four children. And coming to the extra-adrenal involvement, we have got 5 cases where the commonest is involving in the organ of super candle, and left para-aortic region is 2, and aortic bifurcation is 1, and both adrenal as well as the extra-adrenal lesions is 1. And we also have the familial associations. We have 4 children which are associated with familial, both involving both mother and paternal uncles, and 2 syndromic associations like von Hippel-Lindau syndrome associated with 7, and succinate dehydrogenase deficiency is associated with 1. So coming to the clinical presentations, most of our children are presented with hormonal type of symptoms. Usually we hear the phaeochromocytomas will be differentiated into common symptoms like generalized features and with hormonal features and with hypertensive crisis. Where 6 children associated with hypertensive crisis, and generalized features like pain, fever, and abdominal masses are occurred in around 8 cases, and purely presented with hypertension is only around 12 children. And the hormonal features like mostly associated with headache and nausea and malaise commonly associated with 23 cases. So coming to the first investigations, or we always used to confirm the diagnosis by biochemical parameters. We use a urinary metanephrine in which all the conditions have shown some normal metanephrines and normetanephrines are usually elevated in all our studies. And to confirm the diagnosis, we proceeded with the computerized tomography, where the left side of the image shows adrenal lesions, which is above the kidney, which can be clearly seen, and the right side is located in the triangle. And conforming to the extra-adrenal type of lesions, we update with the MIBG scan, where we can able to see the uptake noted in the lesions, which is usually done at the level of 24 hours and 48 hours and after 72 hours. So in all of cases, the preoperative stabilization was done by both pediatric oncology, pediatric endocrine, and pediatric. Sorry. Sir, I think my screen is. Sir, can you hear me?
Yes, we can hear you, Dr. Naveen. Can you move your slide?
Yes, sir. So in all our cases, we just made a corresponding team with pediatric oncology, pediatric endocrine plays a major role, and associated with preoperative stabilization with control of hypertension, initially with the alpha blockade 1 to 2 weeks prior. With after achieving the alpha blockade, we just proceed with the beta blockers, and in case of any presentation,
Naveen, you have only 30 seconds left.
Yes, sir. And in case of hypertensive encephalopathy, we proceeded with. So we proceeded with the surgeries. This is definitive management. Open surgeries around 14 cases, and laparoscopy around 8, and retroperitoneoscopy around 2. So we just calculated the passport post-operative histopathology is calculated for 16 children, where less than 4 is 14 and more than 4 in case of 2 children. All children behave as a benign course. So follow-up, we monitored with vitals and urinary catecholamines in the first week as a baseline investigation, and 3 months and 6 months later with USG and CT. So continuation, there is no disease recurrence occurs in a case of study. 2 children has a pass score of more than 5, which is.
So Naveen, just go to your conclusion slide. You have exceeded the time. We won't have time for questions.
Yes, sir. So the children with phaeochromocytoma presents in adolescence and vomiting and hypertension. Base management is establishing the biochemical diagnosis, adequate preoperative blockade, and appropriate imaging and image surgical approach based on tumor location and size. So the tumor carries a very good prognosis. We calculate the pass score, which is in our study, which carries a poor association and poor prognosis in our study, and it needs a larger cohort to examine its relevance and its prognostic signification. Thank you.
Right, thank you. We won't take any verbal questions. We'll ask the judges to type them in the chat box, and Naveen, you can answer them. we have a validity function to finish at the end of the day. So thank you
Yes.
for your presentation. I'll request Dr. Shashwati, can you share your screen again?
Yes, sir. Yes, sir. I'm sharing.
Yes, please.
Sir, can you see my screen, sir?
Yeah, please make it full screen.
Is it visible, sir?
Visible and you're clearly audible. Please, when you start, I'll start your timer.
I'm starting, sir.
Please go ahead.
Good morning. Warm greetings from PGI Chandigarh. I'll be presenting our experience on extracranial malignant rhabdoid tumors in our center. So as we know, this malignant rhabdoid tumors are aggressive embryonal tumors which can be broadly classified into 3 categories. They could be malignant rhabdoid tumors of kidney, atypical teratoid rhabdoid tumors affecting the central nervous system, and extracranial, extrarenal rhabdoid tumors. The gene involved in such tumors are the SMARCB1, which is the key gene involved in the pathogenesis, and it is situated in chromosome number 22q11.2, and it has a potent bona fide tumor suppressor function. So it has a critical role in the epigenetic regulation, cell cycle progression, and many signaling cascades. Not only malignant rhabdoid tumors, also other tumors like renal medullary carcinomas, other carcinomas and other soft tissue tumors as seen in this table are also having this loss or aberration to variable extent in this gene, and it is expressed in this tumor. So this is a challenge to our histopathologic colleague for having this dilemma, because many tumors are also there who have a loss of function in another similar gene, which is a tumor suppressor and located in the same chromosome. So I'm coming to the extracranial tumors. It could be renal tumors or non-renal tumors affecting the liver, soft tissue, thymus, and peripheral nerves. Coming to the renal rhabdoid tumors, they present early, they have a male preponderance, and they have a poorer prognosis because of early onset of malignancy. Out of the 8 patients, we had 4 patients who were diagnosed with renal rhabdoid tumors, and at presentation they have metastasis to variable extent, including the lungs, liver, and even the mesentery. All these 4 patients had a lethal outcome. This was one of the patients who had a left side renal malignant rhabdoid tumor with multiple pulmonary mets, and even intraoperatively, when we took the patient for nephroureterectomy, the left cuff of the diaphragm was involved and it was excised. Similarly, another patient with left side renal malignant rhabdoid with pulmonary mets were taken up for nephroureterectomy and lymph node dissection, and the patient could not be saved even after aggressive palliative chemoradiotherapy. This was another patient, and we took this patient for surgery for debulking, but intraoperatively we found multiple metastatic deposits involving the peritoneum and mesenteric bed, and even the larger vessels were completely encased. So we just took the biopsy and came out. Coming to the extracranial non-renal rhabdoid tumors, they have a better prognosis than their renal counterpart, and the onset of malignancy is somewhat in the latter period of childhood. Out of 8 patients, we had 4 patients with extrarenal rhabdoid tumors affecting the chest, 3 out of this 4, and 2 of these patients are doing well after surgery and chemoradiotherapy in the postoperative period. One of the patient was a neonate who was antenatally diagnosed to have right side chest mass and was intubated in the postnatal period due to respiratory distress. After cross-sectional imaging, we took the child for surgery and we found a friable mass in the right side thorax. The HPR came out to be malignant rhabdoid. Similarly, another patient, this patient did well in the follow-up period. He had a soft tissue mass, which in the histopathology, the margins were involved and it was the malignant rhabdoid. So we took the child again for local radical resection and margin clearance of around 1 centimeter of healthy margin. This child is under follow-up since last 1 year and he is doing well after chemoradiotherapy. So it is not only a challenge for the clinician, it is also a challenge for the radiologist and also especially the histopathology people, because of the heterogeneity and diverse immunophenotypic profile And the loss of INI gene, that is the SMART-CV, is the underlying oncogenesis of this malignant rhabdoid masses. So immunohistochemistry and its analysis is an important tool of diagnosis. And despite of having multimodal approach for such patients, including chemoradiotherapy and surgery, the outcome is lethal even in literature. Further understanding of this gene, that is SMART-CV1, is the need of the hour for newer therapeutic means for these children. Thank you, everyone.
Thank you, Dr. Shashwati. You've completed well in time. I would request questions from judges. Professor Binder Kumar, sir, any questions from your side?
There is Akriti,
Yes, good
Dr.
morning,
Behra, there is no protocol worldwide for this tumor. What protocol you propose?
Sir, yes, sir,
Barring
there is no protocol
immunohistochemistry,
because
it's okay. Go ahead.
yes, sir. So there is no defined protocol. That's why we are presenting our experience. We had a lethal outcome. Whenever a patient comes to us, and in radiology, the initial radiology, we suspect this kind of aggressive nature, like encasing the nearby structure, the vascular encasement. We go for a tissue biopsy for a tissue diagnosis, and on suspicion, we go for an immunohistochemistry of these children to stamp it out, to diagnose these rhabdoid tumors. Then we go ahead with our tumor board for neoadjuvant chemoradiotherapy and surgery, and if required, chemoradiotherapy in the post-operative period, sir.
So the patients who were presented all went for neoadjuvant chemoradiotherapy before going for operation.
Not radiotherapy for every patient, but chemotherapy, yes. Most of the, 7 out of 8 patients, they went for chemotherapy. One of the patient had received chemoradiotherapy from outside center and was referred to us.
And this is the same chemotherapy what we are prescribing in a SIOP, or it's different?
Sir, 6 patients out of 8 patients received the same chemotherapy regimen as of SIOP, but one of the patients received chemotherapy including platinum drugs, sir.
That's all.
So what was the chemotherapy regime?
Sir, ma'am, they received 3 drug regimen for at least 6 to 8 weeks in the pre-operative period. But for the child who received platinum group, cisplatin group of agents, he received chemotherapy for at least 8 weeks before the surgery.
Because do you know the names of the drugs which were used as chemotherapeutic agents?
Yes, ma'am. They received cyclophosphamide, adriamycin, and actinomycin D.
Okay, and did you do genetic workup for any of these cases?
Ma'am, genetic workup facility is not available, so we just did the immunohistochemistry to look for the loss of INI.
So how many patients had loss of INI?
All the patients had loss of INI.
All patients?
All the patients.
Okay. Thank you.
Thank you.
Thank you, ma'am. Dr. Devinder, sir, any questions from your side?
No, wonderful presentation. No question from my side.
Thank you, sir.
Thank you, sir. Thank you, Dr. Shashwati. You can unshare, and I'd request Dr. Anju Verma from SGPGI. Dr. Anju, are you here? Yeah, Dr. Anju, could you please share your screen?
Yes, sir. Yes, sir.
I would request the speaker next in turn to share the screen as soon as question and answer session starts. Anju, if you are having any problems, we can go on to the next speaker and you can come back again.
Okay, sir. Yes.
Okay, so we'll go on to the next speaker, who is Dr. Manasa A from Indira Gandhi, Bangalore. So, Dr. Manasa, are you here in the meeting? Yes, please make it full screen and switch on your video, please.
Yes, sir. Can you see me, sir? Yes.
I can't see you. Yes, I can see you now. Okay. So please go ahead with your presentation, Dr. Manasa.
Good morning, one and all. Greetings from IGICH Bangalore. We studied the spectrum of sacrococcygeal teratoma at our institute with the aim to study the clinical presentation, management, outcome, with special emphasis on individualized management. It was a retrospective analysis of 7 years with the following clinical parameters studied. 18 children were included in our study with a median age of 8 months with a female preponderance. 12 children presented beyond the age of 1 month with 7 children presenting beyond the age of 1 year. The symptoms varied according to age with increased incidence of bowel and bladder disturbances and limb weakness occurring in older children. Alpha-fetoprotein was the most common tumor marker analyzed, with 50% of children having an elevated alpha-fetoprotein at diagnosis, the value being adjusted to age. This was indicative of malignant focus. The value returned to normalcy in an average of 8 months in the post-op or post-chemotherapy phase. While ultrasound was the commonest imaging modality that we used, CT and MRI was done in selected cases where we needed better tissue characterization and determination of extent and evaluation of metastasis. There was no exclusive correlation between the nature of the lesion and the histopathology. We had a fair distribution in all types as per Altman classification, with type 1 being the most common. Children who presented late with urinary or fecal disturbance with a progressive swelling, presence of solid components, type 3 or type 4 tumors with query METS at diagnosis and a clinico-radiological dilemma underwent FNAC. Thus, among the 7 children who underwent FNAC, 6 children were diagnosed to have immature grade 3 tumor or malignant elements, subsequently undergoing neoadjuvant chemotherapy, while 1 child had mature teratoma. 12 of the 18 children underwent upfront surgery, 5 among whom further underwent adjuvant chemotherapy. 5 children underwent neoadjuvant chemotherapy followed by surgery. While type 1 and type 2 tumors warranted a perineal approach, type 3 and type 4 tumors with significant intrapelvic extension warranted an abdominal or a combined approach. Coming to complications, 2 of our children had superficial surgical site infection, which settled on conservative management. 1 child had intra-op tumor spillage whose histopathology was immature grade 3 teratoma and underwent 6 cycles of adjuvant chemotherapy and is now tumor-free. Another child with mature teratoma had a recurrence 9 months post-primary procedure, diagnosed with a swelling, underwent excision of the tumor and is now tumor-free. 6 children diagnosed with FNAC underwent neoadjuvant chemotherapy, whereas children with the background of late presentation, bowel and bladder disturbances, progressive swelling, solid components, or type 3 and type 4 tumor with an inconclusive FNAC were also considered for neoadjuvant chemotherapy. Adjuvant chemotherapy was given in children with immature grade 3 or malignant focus. The risk of malignancy was definitely higher in children who presented late to us, had a rapidly progressive swelling, heterogeneous lesion on imaging, or type 3 or type 4 tumors. All the above children were followed up at 3 monthly intervals for 5 years with clinical examination, serial AFP monitoring, ultrasound abdomen and pelvis when warranted, and we also kept a tab on the bowel and bladder disturbances that they developed. 11 of our children had no complications at follow-up, whereas 2 children had constipation secondary to dietary habits, and 1 child had recurrence as mentioned above. We had an overall survival of 14 out of 18 children and a mortality of 4, where 1 child expired in the neoadjuvant chemotherapy phase and 3 in the adjuvant phase, all secondary to chemotherapeutic intolerance. Challenges at our institute was antenatal imaging, which we certainly lacked, and we had a significant number of children presenting late to us. Us being a high volume center and also a referral center, we did get a handful number of cases who were improperly or inadequately managed elsewhere and then referred to us, thus delaying the initiation of treatment. Concluding my topic, our treatment decision was whole and solely based on all the clinical parameters studied. Tailor-made individualized management has helped us enhance our outcome and minimize the short-term as well as the long-term complications. Establishment of tumor board was ideal, which was initiated 2 years ago at our institute. It has provided us with a holistic perspective and helped us improve our outcome. Thank you.
Thank you, Dr. Manasa. You finished well in time. Questions from the judges, Professor Vindya, sir.
Dr. Manasa, the individualized approach you are asking in cases of sacrococcygeal teratoma,
Yes,
it's
sir.
based on the clinical presentation, most of the late presenter you have.
Yes, sir.
Now, the message you have given us is that whenever the late presenter has a malignancy is very high and one have to go for FNAC, where the tumor markers stand in this scenario?
Sir, we couldn't have a correlation exactly with older age of presentation and AFP, sir. 9 out of 18 children had an elevated AFP at diagnosis.
So of these 9 who had elevated AFP, how many were malignant, correlating post-operative?
Ma'am, 4 were malignant, ma'am.
So why was the AFP elevated in these other 5? Only 4 were malignant, you said, and
Yes,
5 turned out to be benign.
Yes, ma'am.
So why were they having elevated AFP? Was there any evaluation? Now, why we are kind of focusing, because you mentioned individualized management.
Yes, ma'am.
So ideally with high AFP, these patients would have got neoadjuvant chemotherapy.
Ma'am, they also had immature elements, ma'am, in the FNAC. So probably the elevated AFP could be secondary to immature elements present in the tumor.
So if immature elements are present and if AFP is high, how would you treat them?
Ma'am, we did proceed with an FNAC, ma'am. When the FNAC, in all of our 6 cases who underwent FNAC, they all had immature grade 3 tumors, and we did give them neoadjuvant chemotherapy followed by surgery, ma'am.
So I'm only concerned with those 5 who had elevated AFP and did not have histopathology corroborating. Or are you saying that all of them had a histopathology with immature element?
Yes, ma'am, they did. Immature
So we
grade
can't
3
call it
sites.
benign, no? Those 5
No,
are
ma'am.
not benign then.
No, ma'am, they were immature. They had our criteria to give neoadjuvant chemotherapy and then proceed to surgery was the presence of grade 3 immaturity or malignant focus. And all the children who had elevated AFP had those kind of focus in the tumor, ma'am. So then we proceeded with neoadjuvant chemotherapy followed by surgery, ma'am.
Right. So that is one. Dr. Binde, you were, I was actually just taking up your question about the AFP. Do you want to ask anything else? Because I have one more question. I'll ask after you.
What are the other tumor markers you have taken into consideration apart
Sir,
from the AFP?
So beta HCG also was considered, sir, but since predominantly most common component in malignant tumors was yolk sac tumor, so AFP was followed up, sir.
And what chemotherapy you have given neoadjuvant?
Sir, we gave BEP regimen in 4 of our children, sir, and one
That
child.
means you are giving the same chemotherapy.
Yes, sir. Yes, sir. Yes.
You are giving the post-op.
Yes, sir. Same cycle, same drug, sir.
Right. So I
How
wanted
is
to
to-
know. Sorry. Can I
Please,
ask?
please. Yes.
So when you say individualized management, I would say that all tumor patients, in fact, why tumor, all patients in children or pediatric patients have to be given individualized care with the same diagnosis also. So what is special in your individualized management in sacrococcygeal teratoma that you want us to look at?
Ma'am, actually, we had a varied set of presentations, ma'am, from swelling to bowel and bladder disturbances to limb weakness, and also there were a lot of parameters to be considered, ma'am. So we can't exactly design a protocol which is blanket. We can't exactly provide a blanket therapy to all sacrococcygeal teratoma based on a few parameters. So in each children, we considered all these parameters. Then we discussed the case in tumor board and then came to a conclusion as to what kind of regimen has to be given for this child, ma'am. So that is the individualized management because all the children went through tumor board and then were decided.
Right. And what was
sorry for
dietetic
interrupting.
workup
Time
done?
is over.
Ma'am, the time is exceeded quite a bit, so we'll go ahead with the next presenter. Dr. Anju, are you able to share your screen now?
Yes, sir.
Yep, please put on your video. Yeah, please share your screen and start your presentation.
So my slides visible, sir?
Yeah, put it in full screen.
Yes, sir. Just now.
Yes, please go ahead.
Yeah.
Please go ahead.
Good morning, respected judges and teachers. I'm Dr. Anju from SGPGIMS Lucknow, presenting extracranial germ cell tumor in children, perioperative problem. Introduction. So we all know primary extracranial germ cell tumors are rare. Only 4% of all this germ cell tumor. Those seminoma 30 to 40%, and non-seminomatous germ cell tumor 60 to 70%. Histogenetic origin is still debatable. They arises in midline and around 50% of them in mediastinum, followed by retroperitoneum, pelvis, and sacrococcygeal region. Only known risk factor is Klinefelter syndrome. Retroperitoneal germ cell tumor represent 10% of all primary retroperitoneal tumor. They present late and present with large size. Symptoms vary depend on the size and origin of the tumor. They are highly chemoradiation and have good prognosis after complete excision. But complete excision with conservative approach is advised. Complete excision and perioperative management is a challenge as they lack relatively tumor capsule. So the development of germ cell tumor occur because of abnormal migration of germ cells, and when they migrate in the extracranial germ cells, they lead to development of mature teratoma, and if they get in the extraembryonic phase, they lead to development of choriocarcinoma or yolk sac tumor. So aim was to review or experience perioperative problem and morbidity during management of human patient of extracranial germ cell tumor. Metrology, it was a retrospective review of peritoneal or abdominal germ cell tumor cases from July 2012 to January 2020. Data collected regarding age, sex, clinical presentation, complication, diagnostic investigation, treatment outcome. Inclusion criteria of patient with adequate records who follow up to more than 6 months were included. Coming to the result, total of the duration of July 2012 to January 2020, total 23 patients were included. Age was from 2 months to 6 years with median of 3 years. Out of these 23 patients, 8 patients were female and 15 were male. And in the final diagnosis, 10 patients were of mature teratoma, 7 patients of mature teratoma, and 6 patients were of yolk sac tumor. Raised AFP was found in 17 patients. 8 beta SG was found in 2 patients, and there was progressive decline in the follow-up. So coming to the presentation, the 20 patients presented with abdominal mass, pain, and heaviness. 2 patients presented with respiratory distress, and 1 patient presented with a subacute obstruction. And of them, 2 also had fever and vomiting. In the management, complete excision was done in 17 patients. Only surgery was done in 15 patients. Chemotherapy plus surgery was done in 8 patients. New adjuvant chemotherapy was given in 6 patients and adjuvant in 2 patients. Chemotherapy follows was a BP regime. Till now, no recurrence is found in any patient. This is a CT picture showing a large yolk sac tumor in a child. This is a large teratoma in the child. This is a patient. Sorry, this is a patient having large retroperitoneal mass. And the intraoperative picture it is showing a retroperitoneal mass adhered to kidney. This is an excised tumor which came out to be a yolk sac tumor. Now the perioperative problem included we have excessive bleeding in the 2 patients, hypothermia in 1 patient. We have to excise the part of wall in 2 patients because of adherence. The 2 patients have respiratory problem, and 2 patients have chemo-related toxicity in perioperative region. Subacute obstruction was found in 6 patients. In the total follow-up is from 6 to 16 months. 3 patients were lost in follow-up, and 1 patient died because of respiration refilling. Among the 6 patients who have adhesive obstruction, 4 patients need exploration and adduced disease. Discussion: extracranial germ cell tumor may reach a large size with relatively few symptoms. Most common presenting symptom rapidly enlarging pelvic mass and pain. They have good prognosis. 5-year event-free survival and overall survival is more than 90%. Risk of recurrence depend on primary site of tumor, histological grade of maturity, immaturity, and completeness of resection. Mature teratoma considered benign, but is not completely possible to sure about the maturity in big tumor mass. Absence of well-defined tumor capsule makes surgery a challenge. Close monitoring or surveillance recommended in follow-up. En bloc or aggressive approach of resection may result in bleeding or adjacent organ injury. Excision of large tumor result in wide or raw area in abdominal cavity and which favors bowel adhesion. So as per a few studies in the malignant germ cell tumor, age is the most predictive factor in event-free survival. and there is significant intervention between age and primary site. And another study says that surgical resection is alone effective treatment
Dr.
for
Anju,
immature
20 seconds
teratoma.
left.
Yes, sir. So coming to the conclusion, it is a highly chemosensitive and good prognostic tumor, but complete excision and surgical difficulty and morbidity depend on presentation, size of tumor. Excessive dissection may lead to bleeding, risk of adjacent organ and adhesive wall obstruction and post-op period. Thank you.
Thank you. You just finished in the nick of time. So a quick question from the judges. Professor Binde, sir.
Madam Anju,
Yes, sir.
you have presented the this extra embryonic germ cell tumor. The surgical difficulties you faced is adjacent organ injury, bleeding, adhesive obstruction lateral. Ma'am, what precaution one should take in order to prevent it when you are going for and planning, intending to operate the baby?
So during surgery, we have to cautious during dissection, and we have to ligate, and each cell is not necessary to use cautery every time. If there is a chances of bleeding and not sure, it is or we can use if we have given previously chemotherapy, then it is reduced vascularity and causes shrinkage of size of tumor, which lead to better surgery.
So, are you suggesting us for preventing all these things, we must proceed and must have more neoadjuvant chemotherapy before taking the tumor, or we should go straight forward irrespective of size of the tumor?
No, so we should not give neoadjuvant chemotherapy in all the tumor. If it is a teratoma, we usually go for upfront surgery. Then if it is mature and or immature, then we decided for adjuvant chemotherapy.
Thank you.
Thank you, sir. Sushmita ma'am, questions from your side?
Just one observation. You had 23 patients. Tumor markers were raised in 19 of these patients, but 5 of the patients had mature teratoma. So it does not correlate. In mature teratomas, we don't have raised tumor markers. So how did you have 5 patients who had raised tumor markers? Or the figures don't match up. Can you explain, please?
And we have 6 patients of immature teratoma, and 7 patients of immature tumor, and 6 patients of yolk sac tumor, and 10 patients of mature teratoma.
10 patients of mature teratoma, but 19 patients had raised tumor markers. Am I right?
70.
That was in your slide. 17 plus 2. 17 were alpha fetoprotein, 2 were beta HCG.
2 were beta HCG, yes, sir. 17 were beta.
So 19 patients, right?
Yes, sir. Yes, sir.
So, so that's why of these are 10 were mature teratomas. So I'm just wondering as to how did you get these figures?
It was in all the yolk sac tumor AFP was raised, and in the teratomas, mature teratomas was also raised.
Okay.
Okay, ma'am, we'll go on to the next question. Thank you, ma'am. Dr. Devendra, any question from your side?
No question.
Okay, thank you, sir. We'll go on to the next presentation. Dr. Apurv, please switch on your video. Okay, you're there. So whenever you start, I'll start your timer.
Okay, sir, is my video visible and am I audible clearly,
Yeah,
sir?
clear. Both things are clear.
Just a sec. Yeah. Okay. Shall I begin, sir?
Yes, please.
Okay. Respected chairpersons, session judges, seniors, and my dear colleagues, from the Department of Pediatric Surgery at AIIMS New Delhi, I will be presenting our experiences in managing retroperitoneal germ cell tumors at our center. I have no disclosures. Teratomas are germ cell tumors that contain tissues from multiple germ layers. They are mostly reported in the midline and paraxial locations. A majority of these are benign, accounting for approximately 80% of the reported cases. This study aims to report the epidemiological aspects and outcomes of children with benign retroperitoneal germ cell tumors presenting at our center, and also to discuss the surgical challenges faced in them. This was a single-center retrospective study, including all the pediatric patients with retroperitoneal benign germ cell tumors who were treated at our center between January 1998 to December 2018. The patients with raised alpha fetoprotein or malignant histology were excluded. We had also excluded 2 patients of renal teratomas. The data included and evaluated was the patient demographics, presenting symptoms, radiological and histological findings, surgical procedures, post-operative complications, and recurrences. In total, the study included 24 patients with 9 males and 15 females. The median age at presentation was 10.5 months, with the youngest patient being 10 days. At presentation, all the patients were symptomatic, with 80% presenting with a palpable mass as a primary complaint. Some patients also had varied presentations, with one patient presenting as a case of hypertensive emergency. All the patients underwent operative intervention, with all except one of them undergoing complete excision of the tumor in the primary surgery. Majority of the retroperitoneal tumors had involvement or displacement or encasement of vital structures. This was one similar patient with a large tumor going up to the porta hepatis, along with compression of the right ureter, resulting in right hydroureteronephrosis. Similarly, this image shows a large tumor displacing the bowel loops toward the left. To summarize, intraoperatively, 7 patients had major vessel involvement. One patient had engulfment of the superior mesenteric artery and celiac axis, resulting in necrosis of the jejunal loops. This patient was managed with resection of the jejunum with tube ileostomy, followed by duodenojejunal anastomosis at a later date. One patient had a right renal vessel involvement, requiring right nephrectomy. One patient had an extensive abutment of SMA, celiac axis, and bilateral renal vessel origins, resulting in incomplete excision of the tumor, which was re-excised at a later date. One such similar case had to be operated by transection of the tumor for approaching the celiac artery. One patient also had an IVC rent requiring repair. Similarly, the renal involvement was also documented in 3 patients, with one patient having a very large mass severely displacing the right kidney, which was reported as cross-fused ectopia on preoperative radiology. One patient had presented to us with obstructive uropathy resulting in CKD and came to the casualty with hypertensive emergency. Subsequently, this patient also required renal transplantation for the same. Three patients had bowel involvement, with one of them undergoing resection of the adherent duodenum followed by anastomosis. Interestingly, one patient had a bilobe tumor infiltrating into the thoracic cavity via untreated Bogdalic hernia. This patient then underwent a concomitant repair of the hernia as well. Post-operative histology was present in all of the patients, with the majority being reported as mature teratoma. The median follow-up in our cohort was 24 months. One patient had a surgical complication in the form of adhesive obstruction. There were no recurrences reported in the cohort. Becker et al. And Chaudhary et al. Have reported series of 12 cases each, with the most common location being pararenal location. They also showed that these tumors are likely to be adherent to vital structures with risk of subsequent injury. Similarly, Jones et al. Had reported a series of 6 patients, one patient interestingly having stomach involvement. However, they reported one recurrence in their cohort. All the above studies, however, have included patients of malignant teratomas as well as gastroduodenal teratomas, making our study the largest cohort in the same. To conclude, these tumors are large tumors with infiltration and involvement of important structures, resulting in distortion of the anatomy preoperatively, hence requiring caution and fine dissection along with adequate visualization intraoperatively. Still, complete excision is feasible and in most patients is curative with low recurrence rates. And lastly, regular long-term follow-up is required to look for any recurrences and manage the complications. Thank you.
Thank you, Apurv. You finished in time. Questions from the judges. Professor Binde, sir.
Dr. Apurv, when you shall call it encasement, when you shall call it invasion of blood vessels? What were your criteria of saying that the blood vessel is encased or blood vessel is invaded?
So encasement was described as a tumor abutting the vessel more than 180 degrees or more, and invasion was if there was histopathologically the vessel's wall was involved by the tumor. None of our patients had any vascular invasion. There was, however, many of our patients had more than 180 degree of contact of the tumor with the vessels.
So encasement, you want to say this 180-degree involvement. And what was the histopathology came out, all the encased cases?
Sir, a majority were mature teratoma, sir.
That's all.
Yes, yes, sir. The total number was 20 were mature and 4 were immature, sir, of the total count.
Thank you, sir. Sushmita ma'am, your question, any question or comment from your side?
Sorry,
Professor Sushmita?
I was muted.
Yes, ma'am.
Sorry, yeah, I'm here. Your title
Yes,
was about benign tumors, right? Benign
Yes, ma'am.
retroperitoneal tumors.
Yes, ma'am.
So would you consider immature teratomas as benign?
Ma'am, we actually had included patients with raised AFP at presentation, and these patients did not have any raised AFP at the time of presentation. So they were initially taken up as benign tumors only, but the postoperative histopathology came out to be mature.
Right. So once the histopathology is there, then would you term them as benign?
Ma'am, yes, still, ma'am, because ma'am, immature means.
No, you can't term them as benign. Am I right?
Yes, ma'am.
Okay,
Yeah.
thank you.
Thank you, ma'am. Dr. Devinder, you're a co-author in this paper. Any comment from your side?
No comment. Just one comment from my side. Basically, in our institution, we treat immature teratoma as a benign tumor, and we don't give any chemotherapy. And I will not mark for this paper because this is from my
Right.
institution.
Thank you, sir. We have senior people, Professor Roy Chaudhary in the attendees. Can the hall manager please make Professor Roy Chaudhary unmuted? Sir, would you like to discuss about about the points you're writing in the chat box? Just a quick comment, sir. I think we'll move on to the next talk, and we can take comments from Professor Roy Chaudhary or Dr. Partha in the end. The next presenter is Dr. Deepthi Pai. So Dr. Deepthi, please put your slide on full screen.
I'll start.
Yes, go to the slideshow, not rehearse timing.
Okay. Shall I start, sir?
Please do.
Good morning and greetings from PGI Chandigarh. I'm presenting a 5-year audit on ovarian tumors. Ovarian tumors constitute around 1% of childhood tumors, out of which 1/3 are malignant. A subset of patients also present with syndromic association. Age of presentation is variable, with the set of patients who are antenatally diagnosed presenting in neonatal period. Next peak is in infancy and later at menarche. Since there are very few data from India, we decided to analyze the clinical presentation types and management of ovarian tumors in children and adolescents. Hence, we retrospectively analyzed the records of patients with ovarian tumor between 2016 and 21, and data was compiled. The following principles of ovarian surgery was followed. A generous incision was given, sampling of ascites was done, and if there was no ascites, peritoneal washings was collected. Delivery of ovary was done carefully, ensuring there is no capsular breach. After ligating the pedicle, salpingo-oophorectomy was performed. Ovarian preservation was done wherever possible. Next, we did omentectomy, and in girls more than 10 years of age, retroperitoneal lymph node dissection was also done. Coming to results, we had total of 16 ovarian tumors with the mean age of presentation as 8.6 years. Only one of our patients was antenatally diagnosed. Mass per abdomen was the most common presenting symptom in our cohort, and pain abdomen followed by pain abdomen, constipation, vomiting. Precocious puberty was also seen in one of our patients. We did ultrasound abdomen for all patients. CT abdomen and pelvis was done for 15 of our patients, and 4 had MRI abdomen and pelvis. Coming to tumor markers, AFP was raised in 5, beta HCG in 2, and 1 had raised LDH as tumor marker. In 3 patients, tumor markers were not assessed as ovarian pre-op diagnosis of ovarian tumor was not made. We had 2 intraoperative surprises in our series. One patient presented as rhabdomyosarcoma of urinary bladder, which turned out to be a small cell carcinoma of ovary. Another patient was explored with an antenatal diagnosis of mesenteric cyst, which was found to be a torted ovarian tumor. So a patient with small cell carcinoma, another with dysgerminoma ascites, and one with a neuroblastoma, which was extending to ovaries, received chemotherapy in our cohort. Coming to management, our patients underwent staging laparotomy as described earlier. 14 had undergone unilateral salpingo-oophorectomy, and one patient also had retroperitoneal lymph node dissection as shown in the picture over here. One patient underwent ovarian sparing surgery in the form of cystectomy. Coming to histopathology, 12 of our patients had germ cell tumor, which included 6 dysgerminomas, 5 mature cystic teratomas, and 1 immature teratoma, and 1 each of small cell carcinoma, granulosa cell tumor, benign cystadenoma, and neuroblastoma with ovarian extension. One of our patients recurred after 4 months of surgery and was not compliant with adjuvant chemotherapy and succumbed. Coming to discussion, there is ample literature available on childhood ovarian tumor. However, there is very limited data from India. Age of presentation in Rajeshwari et al. Was 10 years, which was similar to what's seen in our series. Akin to Mukhopadhyay et al., the rate of malignancy was 62.5% in our case cohort. Coming to individual tumors, germ cell tumor is the most common ovarian tumor in childhood. In the series by Dibakar et al., 25% presented as surgical emergency and fertility preserving surgery was done in them. Recurrence rate was 4.5%. We also had germ cell tumor as the most common tumor, and fertility preserving surgery was done for all patients with no recurrences or metastasis. Granulosa cell tumor is a hormonally active tumor, and one of our patients presented with precocious puberty and tumor resection was done. Since there were no malignant cells in ascites, we did not give chemotherapy. Small cell carcinoma of hypercalcemic type is a highly aggressive and a very rare tumor, which has often been misdiagnosed. And so it happened in our case as well. Adrenal neuroblastoma with ovarian extension is extremely rare with only 10 reported cases in literature. Our patient underwent oophorectomy and distal pancreatectomy along with adrenalectomy in that case. Ovarian tumor has often been misdiagnosed. One of our patients with ovarian cyst was masquerading as mesenteric cyst. To conclude, ovarian tumors are rare in childhood. Germ cell tumor is the most common tumor, and pre-op misdiagnosis is not uncommon. Follow-up with tumor markers and repeated imaging should be done, and fertility preservation surgery should be aimed for. Thank you.
Thank you, Deepthi. You've completed 15 seconds before time. Questions from the honorable judges. Professor Binder Kumar, sir.
So your voice is breaking.
Sir, your voice is not clear, sir. Could you type in your question in the chat box, sir?
No question.
Okay, sir. Thank you, sir. Thank you, sir. Dr. Sushmita, ma'am, any question from your side?
Just one clarification. It was a good presentation. I wanted to know how many turned out to be benign of the overall, because in such a short time it's difficult. So out of 16 patients, how many were benign and how many were malignant overall?
Ma'am, out of 16 patients, 4 of our patients are benign and rest are malignant.
So you are including the teratomas also.
Ma'am, mature cystic teratoma is considered benign, and immature and dysgerminomas. Yes, ma'am.
No, have you included immature teratomas in your in your benign lesions?
No, ma'am. Immature is included in malignant.
Okay, fine. Thank you. That's all.
Thank you, ma'am. Dr. Devender, any question from your side?
Yeah, Deepthi, one question from my side. What was your diagnostic protocol for pre-operative diagnostic protocol for ovarian tumor?
Yes, sir. Sir, any patient who came with who was diagnosed on ultrasound abdomen in whom we found an ovarian mass, we went ahead with CT abdomen. If the diagnosis was clear on CT abdomen and it was limited to ovary, we went ahead with upfront surgery if it was completely resectable on imaging. If the diagnosis was unclear, we went ahead with tissue diagnosis. And if on imaging or on tissue diagnosis, it was found to be a malignant tumor, which required, it was a higher stage tumor, we gave neoadjuvant chemotherapy followed by surgery.
So you don't include CT chest for the to look for the metastasis in the lung?
Sir, for the patients who the size of the tumor was more than 10 centimeter, yes, we did do CT chest as well.
Okay, thank you.
Thank you, sir.
Thank you, sir. And thank you, Deepti. There's a question from Dr. Rohit Kapoor, so you can answer that in the chat box. We'll move on to the next presentation by Ashish from Vellore. So Ashish, whenever you're ready, please start presenting.
Can you hear me, sir? And my slide
clearly? Yes, please.
Yes. Good morning, everyone. I'm Dr. Ashish from CMC Vellore, MCH registrar here. I'll be presenting on our institution's experience with solid pseudopapillary tumor of pancreas over a 12-year period. This is a retrospective chart review of 15 children who were treated between 2009 and 2021. Most of these children were girls. Most children presented in the second decade of their life with abdominal pain and vomiting as the major symptoms. More than half of the children had a palpable mass at presentation. CT scan was done in all of these children, and in 8 of these children, we had to do also an MRI because the ductal anatomy was, pancreatic ductal anatomy was better on an MRI. So this is the CT scan where you see a well-circumscribed tumor within the head of the pancreas, but the pancreatic duct is better seen on the MRI. These tumors tend to grow large. Most of the children had a tumor of size of more than 5 centimeters in our series. Majority of these tumors were located in the head of the pancreas. 7 of them underwent Whipple's. 2 of them we could manage with wide local excision. 2 of the tumors were located in the body of the pancreas, for which central pancreatectomy was done, while 4 of them were in distal pancreas, tail of the pancreas, so for which distal pancreatectomy was done. So this is the intraoperative picture of one of the patient who had a pancreatic head mass, for which Whipple surgery was done. We had one child who had come to us after 4 years, where primary excision of the tumor was done elsewhere with disease recurrence in the tail of the pancreas. The tumor was involving the spleen and the splenic fracture. She underwent en bloc resection of the tumor. But the child had recurrence of the tumor. The child was given gemcitabine with cisplatin-based chemotherapy. There was pelvic recurrence, for which she underwent pelvic tumor debulking with radiation to the abdomen and pelvic boost. The child is on follow-up with us. At 4 years of follow-up, she is disease-free. So this is the pelvic recurrence in that child, and after on follow-up, the tumor has disappeared. So we have been doing IHC markers in pseudopapillary tumors. Most commonly done is beta-catenin. 100% positivity is seen in beta-catenin, while other tumor markers like synaptophysin and chromogranin are also done. It doesn't show as much positivity rate as beta-catenin. We have a mean postoperative follow-up of 34 months, ranging between 1 month and 106 months. At least one ultrasound abdomen screening is done in the first year of follow-up. The complications which we have encountered, early complications are the pancreatic leak and intra-abdominal collection, while late complications were exocrine pancreatic insufficiency, which was the most common complication. The primary ovarian failure, which has been mentioned here, is for that child who had radiation to the pelvis. She is under endocrine follow-up as of now. In conclusion, this is a tumor which behaves as a benign tumor. Some of them can become metastatic and can also recur. The cornerstone of treatment is complete resection of the tumor. If the tumor recurs, the meticulous surgical clearance has to be done. Adjuvant chemotherapy, which is gemcitabine based, and radiation may be helpful. Further research into immunohistochemistry will be helpful in diagnosis as well as prognostication of the tumor. Thank you.
Thank you, Dr. Ashish, for finishing well in advance. Questions from the judges. Professor Binde Kumar, sir.
Dr. Ashish, those patients who have recurrence, what was the histopathological diagnosis?
So there was pseudopapillary tumor of pancreas itself. We had discussed this in a tumor board and went ahead with gemcitabine and cisplatin-based chemotherapy. There has been literature where gemcitabine has been done in metastatic tumors. In this child, actually, after gemcitabine and cisplatin chemotherapy was given, she again had recurrence, for which we had to do pelvic debulking and then give radiation. After that, she is now tumor-free for the last 4 years.
That's
This is
all.
only one patient, which it is of the 16, one patient.
Thank you.
Thank you, Dr. Ashish. Sushmita ma'am, your comments and questions on this presentation.
Yeah, thank you for this presentation. The pseudopapillary tumors of the pancreas are pretty rare actually. They are not so common. So to have 15 cases is a huge achievement, I would say, and plus successfully managed. My question is, in patients where you have done central pancreatectomy, how did you, can you just elaborate the surgical steps in terms of which part was removed and how did you anastomose and what was done?
I mean, central pancreatectomy, what we have done is the tumor, when only the body of the pancreas is involved, we have removed the tumor in the central pancreatectomy, where we have used the jejunum to anastomose the pancreatic duct. We have anastomosed most of them as one is side to side in the tail of the pancreas, dunking the pancreas into the jejunum, and the head of the pancreas is anastomosed from end to side. So this is what has been done in central pancreatectomy.
End to side and the same jejunal loop has been used for both ends, or you have used separately?
Same jejunal loop has been used.
So one side you have done side to side on
yes,
the distal aspect, and the proximal you have done end to side.
End to side, yes.
So any complications of these strictures or anything else that you have noticed?
Most commonly these children had the anastomotic leak and pancreatitis. On long-term follow-up, many of them have pancreatic insufficiencies.
So only the central pancreatectomy ones have insufficiency.
Sorry, ma'am.
So that's not mentioned in your presentation. This is that's why I'm asking. Insufficiency was only for those central pancreatectomy patients?
No, ma'am. I meant to say for the 15 patients who have been done, the most common was pancreatic insufficiency, and the immediate complications was where we had this pancreatic leak.
Okay, thank you.
Thank you, ma'am. Thank you, Ashish. Dr. Devendra, sir, any comments from your side, sir?
But just one question from my side. In cases of pancreatic mass, any tumor marker was done pre-operatively or not?
So this on the CT scan, this was mostly suggestive of a solid cystic area. So our way of going at, we didn't do a biopsy pre-operatively. Most of them had only a radiological diagnosis.
Okay, thank you.
Right. Thank you, sir. There are senior teachers and senior members in the group. I would request if anybody, Professor Ramsamud is here, Professor Ramesh is here. If anybody wants to give any comments, Dr. Prathapatim sir is here. Any of the senior members would like to make any comments? We'll close the session after this.
Can I, Dr. Peters, listen?
Sir, please.
Dr. Vail Gurukat, yeah. See, I'm interested in the last presentation, the solid pseudopapillary tumor. Those tumors, I personally believe that they recur locally, if at all. And It is my belief that they are not very chemo or radio sensitive. And that is the reason why we don't even attempt a pre-op biopsy. And we go in and once we confirm on a CT scan, we go ahead and remove it. I entirely agree with what Safe has done. Only thing I would have tumors in the body and tail, I would have preferred to do a distal pancreatectomy from the normal site. And in 2 cases so far, one recently I have done because of this worry about tail of pancreas, I do an en-bloc splenectomy also if it is too close to the tail of pancreas. Thank you.
It's a good paper.
Sure, thank you.
The only thing is that one has to take care, as always, that there shouldn't be any tumor spillage and get the right plane.
Yes, sir.
Thanks.
Thank you, sir, for your comments. If there are no more comments from any of the senior teachers and members in the group, we'll close this session. Thank you, Honorable Judges, Professor Binde Kumar from Patna and Dr. Sushmita ma'am from Bombay and Dr. Devinder from Delhi. Thank you all of you for joining in, and thank you all presenters for working hard and giving wonderful presentations. So we'll move on to the next session now. The next session is also on surgical oncology, and the judges, I am happy to invite Dr. Archana Puri ma'am, Dr. Velumurugan sir, and I'll request Dr. Sailesh Solanki to join us as one of the judges. So if the judges are all here, we'll start off with the next presentation. The first presenter in this group is Dr. Christopher from ICH Chennai. So Dr. Christopher, please start your video, and you can, when you start your presentation, we'll.
Good morning, sir. Am I audible? Is my screen visible, sir?
You're audible. There's a bit of echo, so take care of that, and you can start.
Yes, sir. Good morning, sir. Myself, Dr. Sriram Christopher from Madras Medical College, going to present on the topic of technical aspects of liver resection in hepatoblastoma, single unit experience. Liver tumors are the third most common solid abdominal organ tumor in children, representing 0.5 to 2% of pediatric neoplasm. The diagnosis and the treatment of hepatoblastoma is a well-established protocol with chemotherapy and surgery. Liver resection is a major abdominal surgical procedure. The aim of this study is to share our experience in liver resection and highlighting the surgical steps which we follow. It's a retrospective study of the children admitted with the diagnosis of hepatoblastoma in 2 hospitals by the same author for the duration of 6 years between June 2015 to June 2021. We had 8 cases operated for hepatoblastoma. All patients underwent imaging studies as necessary, and after biopsy they were treated with chemotherapy. After 2 or 3 cycles they underwent resection. Technical aspects, the main principles of liver resection lies in the taking control of the inflow and the outflow tract. And first I'll begin with the right hepatectomy. We'll make bilateral subcostal incision deepened in layers. Falciform ligament was identified and divided, and liver was mobilized by incising right and left triangular ligament. And we mark the line of resection 1.5 centimeter away from the tumor margin, anteriorly, inferiorly, and posteriorly. And then is from the GB fossa, and cystic duct is maintained intact with the CBD till the last step of the procedure. Here you can and the common hepatic artery is marked by means of red sling, and the CBD marked by means of yellow sling. On further total dissection, right hepatic artery and right hepatic vein, the slings were advanced and divided, and the right portal vein is now marked means of blue sling. After taking control of the inflow tract by portal dissection, we proceeded with the outflow tract, where we dissect and ligate the right hepatic vein. As both suprahepatically and infrahepatically to take control of the IVC and to avoid torrential hemorrhage at the time of resection of the liver, and also for the retrohepatic dissection. And then we proceed with the retrohepatic dissection by reflecting the liver towards the left side, and each veins entering into the liver must be carefully identified and divided to prevent torrential hemorrhage. And we proceed with the division of the liver parenchyma with the line of demarcation by vessel sealer and bipolar artery. And we will encounter multiple intrahepatic veins which must be carefully ligated and divided, sir. This was the post-resection status. The key is cholecystectomy is the final step, and it's a good pointer to the CBD's integrity and also to identify biliary leak by squeezing the bile in this gallbladder. This was the post-resection picture. Similar procedure was followed for left hepatectomy, and the main anatomical difference is the left portal vein has the more oblique and longer course, and the left hepatic vein joins the middle hepatic vein either intrahepatic or extrahepatic, which must be carefully identified and divided. Out of the 8 cases, we operated 5 as survivors, and 2 cases died due to post-op and intraoperative hemorrhage, and 1 had a recurrence which was operated again and died. These are the pictures of the survivors. Thank you, sir.
Yeah, thank you, Dr. Sriram. You finished on time. I invite questions from the judges. Dr. Velumurugam, sir.
Sriram, it was a crisp presentation, but I would like to know whether did you encounter any portal vein thrombosis or hepatic venous thrombosis in your series?
No, sir. Portal vein thrombus and hepatic vein thrombus would have been considered as tumor thrombosis and would have considered contraindications for surgery. Sir, for
okay.
It was considered transplantation if after chemotherapy.
In a portal vein thrombosis, you will consider transplantation.
No, sir. We can remove in toto means no issues.
Okay, I'll leave that. You said you had 5 survivors, right?
Yes, sir.
Okay. So 6 pictures. I thought I saw 6 pictures there. Yeah.
1 child died.
Okay, right. Maybe the survivor. Okay. That's all, sir.
Thank you, sir, for the question, sir. Thank you. Can I request the hall manager to promote Dr. Archana Puri to the panelist so she can share a video? Hall managers. Meanwhile, I'll take the question from Dr. Salesh if Dr. Salesh is there. Dr. Salesh, please.
Thank you. Just 2 quick questions. First, regarding you mentioned you assess the bile leak at the end of the surgery. So, do you put any dye to the gallbladder or cystic duct to see the bile leak at the end of the procedure? And second thing, to dissect the liver parenchyma, do you use a finger fracture technique or use PUSA? Thank you.
First thing is the bile which was remaining in the gallbladder itself would have enough for us to assess any CBD leak. While squeezing the gallbladder, we will assess any leak in the CBD or in the transected cut surface. We will see whether any leak is there. That bile was enough for us to assess the leak, sir. And another thing is we use usually we will use bipolar and vessel sealer, and routinely we won't use finger fractures. So if we will carefully identify the crossing veins and ligate, and then we proceed, sir.
Okay. Thank you.
Thank you, Dr. Salesh. Professor Archana Puri, ma'am, you are in the panel group now. Would you like to ask any questions on this presentation?
No, I enjoyed his presentation. I have no comments or questions for him. Thank you.
Thank you so much, ma'am.
Nitin, can I add
Yes,
a comment?
sir.
I agree. In fact, I don't agree with the presenter when he says that the bile which is there in the bile duct during the procedure itself, when you compress a gallbladder, that will be good enough for identifying the leak. I don't agree, because hepatectomy is a prolonged procedure. It will take a long time, and for him to identify, to have enough amount of bile may be misleading. In fact, if they are have to be very sure about no leaks, they need to inject it, particularly if it is a non-anatomical resection. So I think it will be, they are lucky that they got away with it, but I would definitely feel that it is safer to do a dye study, sir.
Yes, absolutely, sir. Thank you for that very relevant comment, sir. Professor Ashley is also there in the meeting, sir. Any comments from your side? I think we'll get back to Dr. Ashley if he's there in the panel. We'll take questions from senior teachers at the end of the discussion. Dr. Krishna Rao, are you ready with your presentation?
Yes, sir. Good morning, sir. Sir, is my
Good
screen
morning,
visible?
please. Screen is visible. Please put it in share screen. Yeah, please start whenever you're ready.
Good morning, everyone. Warm greetings from PGI Chandigarh. We are happy to share our early experience on non-anatomical liver resection in pediatric age group. Liver tumors are relatively rare. Malignant hepatic tumors accounts for 1 in 1 million children per year. The most common is hepatoblastoma. Complete surgical excision is the prerequisite for better outcomes and cure. Hepatectomy is the procedure of choice. Non-anatomic liver resection is defined as resection of the tumor with at least margin of 1 centimeter without regard to segmental, sectional, or lobar anatomy. Earlier studies have described the non-anatomical liver resection in view of high risk of residual disease and recurrence. In the advent of radiological imaging and staging, availability of the preoperative chemotherapy, and the advent of newer energy resources for parenchymal resection, non-anatomical liver resection is feasible. The aim of our study is to study the indications, feasibility, and outcomes of non-anatomical liver resection in pediatric age group. Over the past 4 years in our department, we have done 19 hepatectomies, after 3 were non-anatomical liver resection. Our first case was a 11-month-old boy presented with vague abdominal lump. On evaluation, he was found to have a large pretext to liver tumor on the left lobe of the liver. FNAC showed hepatoblastoma. He received 4 cycles of cisplatin as a neoadjuvant chemotherapy. This is the intraoperative picture showing large exophatic mass arising from the left lobe of the liver. He underwent anatomic resection of the left lobe and tumor margins were free. On follow-up after 6 months, he showed an increased level of alpha-fetoprotein. He was further evaluated with CECT. CECT shows a hypodense lesion in the segment 6 of the liver. This is an intraoperative picture of the segment 6 showing the recurrence of the tumor. He underwent non-anatomic liver resection with harmonic scalpel with 1 centimeter margin. This is a post bed showing the gel has been placed in the bed. Our second case was a 2-year male child who presented with large heterogeneous tumor on the segment 4B, 5, and 7 of the liver. FNAC showed hepatoblastoma and CECT imaging was pretext 3 with involvement of the portal vein. He received neoadjuvant chemotherapy as a superlato regimen. Post chemotherapy, he had significant reduction in the size of the tumor and there was involvement of the portal cavernoma. Intraoperatively, there was inflow access was difficult, so on-table decision was made for the non-anatomical liver resection. This patient also underwent complete clearance of the tumor, with histopathology showed negative margins. A third patient was a 1-year boy who presented with vague abdominal pain and failure to thrive. CCT showed a large mass arising from the right hypochondrium. The exact origin of the mass was not clear. On intraoperative by exploration, there was surprise that there was a large encapsulated tumor arising from the segment 5 and 7 of the liver. He underwent resection by non-anatomically with 1 centimeter margin. Complete clearance of the tumor was done. Histopathologically, it showed as a pure fetal type of histopathology. He did not require any post-op chemotherapy. In results, intraoperatively, all the 3 patients had lesser blood loss compared to our anatomical resection. Duration of surgery was shorter and unable post-operative recovery. None of the patients had bile leak. Histopathological exam showed hepatoblastoma in a big free margin. None of the patient had recurrence in our follow-up. The primary aim of non-anatomical resection is to avoid major hepatectomy for proportionally small tumors, preserve the functional non-tumor bearing liver parenchyma as much as possible. Negative margin should be achieved is the goal of the treatment, and whenever there is inflow and outflow access is difficult, NAR can be considered. NAR has shown the proven oncological safety and distinct benefits of parenchymal preservation and reduction in the volume resected and blood loss and the operative time. NAR can be considered whenever tumor is away from the photostructure, major hepatic veins and pedunculated regions located in the inferior segments of the liver. Study done by Qureshi et al. Also have shown that NAR is feasible and results are comparable oncological also with the anatomical resection. conclude NAR is feasible in diligently selected patients. Radiological and intraoperative assessment of the key for decision making. Complications or outcome are comparable with the anatomical resection. It should be included in the armamentarium of the surgical resection of the liver tools for the any hepatoblastoma or liver tumors. Thank you.
Thank you, Dr. Krishna. You've finished 30 seconds in advance. Questions from the judges. Dr. Velumurugan, sir.
Doctor, are you advocating a lumpectomy or a simple tumor resection for cases where you can get away with it? Is that the thrust of your presentation?
Sir, actually, we usually do the anatomical resections, and non-anatomical resection can be considered some of the tumors like the tumors which are away from the major hepatic vessels and portal vein.
Yeah.
And
that is
are pedunculated, and the relatively small size of the tumor is there.
That is my point. Only the problems are your major venous vascular problems when you go for a non-anatomic play, unless you have got a very localized thing. Your case one, I may not agree it is a non-anatomical resection because you did an anatomical resection, there was a recurrence. And then you went in and did a metastacectomy or a tumor excision for biopsy purposes.
No,
that may not, your first case one.
Like the first surgery we did anatomic resection of left hepatectomy, sir. Second surgery, there was segment 6, there was a recurrence segment 6. So we did a non-anatomic resection during the second surgery.
Okay.
Thank you, sir, for that question. Dr. Archana, ma'am, any question from your side?
Yeah, I have got two questions for him. Thank you, Krishna, for your presentation. My first question to you would be that it's a comment more than a question. That yes, I do agree that it is feasible, but I am not very sure whether it would be advisable barring the pedunculated tumors of the liver. My question to you would be that what are your indications of using cisplatin monotherapy as in case 1 and plato regime as in case 2? So how do you decide?
Ma'am, first case was low standard risk hepatoblastoma was there, ma'am. So we usually give 4 cycles of cisplatin neoadjuvant therapy, and post surgery we give 2 cycles of cisplatin in the standard risk group. And the second case, there was involvement of the portal vein during the second case. So we consider it as a high risk, ma'am. So we gave a super plato as a regimen.
Okay, thank you.
Hello. Hello, can you hear me?
Yes, sir.
Yeah, please. Ma'am, sorry, I lost audio in between. Any other question from your side?
No, no other question. Thank you. I'm satisfied with this answer. Thank you.
Thank you, ma'am. Dr. Sailesh, any questions from your end?
Yeah, thank you. Thank you, Dr. Krishna. Nice presentation. Just 2 comments. Like first, you are lucky that in last 2 cases you didn't get recurrence. Second, I'm not agree with your point that whenever there's a difficulty in the vascular access to control the outflow and inflow, then you should go for the non-anatomical resection. That should not be the criteria for the non-anatomical resection. Thank you.
Thank you, Dr. Sailesh, for that comment. We'll move on to the next presenter. I would request Dr. Nilay to please share his screen. He's going to discuss vascular involvement of Wilms tumor. Yeah, please make it full screen.
Hi, sir. Is my screen visible, sir?
Visible and you're clearly audible. Please start your presentation.
Greetings from AIIMS, New Delhi. I'll be presenting our 17-year experience on the management and outcome of Wilms tumor with intracaval thrombus. I have nothing to disclose. So Wilms tumor is the most common renal malignancy in children, and 4 to 10% of these patients have tumor thrombus in the inferior vena cava. Neoadjuvant chemotherapy causes regression of the tumor thrombus, and this decreases the complications and decreases the need for cardiopulmonary bypass. So aim is to present our experience in the management and outcome of Wilms tumor with intracaval thrombus. It was a retrospective study, and we reviewed the records from July 2000 to December 2017, and we included the patients with Wilms tumor with tumor thrombus extending into the inferior vena cava, and those patients who had lost to follow before the reassessment of response to chemotherapy were excluded. Neoadjuvant chemotherapy based on the NWTS5 using vincristine, dactinomycin, and doxorubicin was given, and the further treatment was also as per NWTS5. We evaluated the tumor stage, management, and outcome in these patients, and the survival estimates were also compared with the cohort without IVC thrombus. So we had 34 patients in our study, and the median age of presentation was 48 months, and the metastasis at presentation was seen in 44% patients, with 15 patients having lung metastasis and 1 patient also having liver metastasis. This is the flowchart showing the outcome in our study. So out of 34 patients were included, 32 patients received neoadjuvant chemotherapy and 2 patients had upfront surgery, and 32 patients were operated. 2 patients have progressive disease and died. After the surgery, 2 patients again had progressive disease, 8 patients had recurrence, and at the end of the study, 9 patients had died and 25 patients were alive and disease-free. This is a table showing the response of the tumor thrombus with respect to the modified downstaging of the vascular thrombus. So the start of the chemotherapy, around 56% of the patients had either stage 1 or 2 tumor thrombus, and after the neoadjuvant chemotherapy, 31% patients had complete resolution of the tumor thrombus, and the tumor thrombus was persistent in the remaining. 32 patients required surgical intervention, and these included cavotomy and removal of the tumor thrombus in 17 patients, excision of the part of IVC wall and patch repair in 1 patient, cavectomy in 5 patients, cardiopulmonary bypass and aortotomy in 2 patients. Tumor spill was there in 5 patients, and the viable tumor cells were present in 17 out of the 19 documented cases. This is the survival estimate in our study. So the patients with Wilms tumor and IVC thrombus had a 5-year overall survival of 67% and event-free survival of 59%. We had also a cohort of stage 3 or 4 Wilms tumor without IVC thrombus of 202 cases. And in comparison, their 5-year overall survival was higher at 87% and event-free survival higher at 63%. But however, the difference was not statistically significant. Similarly, the patients with IVC thrombus and metastasis had a lower overall survival at 29% as compared to the patients with IVC thrombus but without metastasis, who had a higher overall survival at 94%, and this was statistically significant. The patients who had complete resolution of the IVC thrombus had a 100% 5-year overall survival as compared to the patients who had incomplete resolution of the IVC thrombus, who had a significantly lower survival. So the incidence of IVC thrombus in our cohort was 9.4%, but the reported literature, it is 4 to 10%. Stage 1 or 2 thrombi constituted more than half of our cases, and the contrast and CT scan was accurate to diagnose the tumor thrombus. For this, the quality of CCT should be optimal, and the Doppler evaluation of the IVC to rule out the tumor thrombus is done if CT is not optimal. Duration of neoadjuvant chemotherapy is still debatable, and prolonged neoadjuvant chemotherapy will not affect the thrombus size. But the median duration of neoadjuvant chemotherapy in our study was 8 weeks. And the response rate reported in most study of the IVC thrombus is 70 to 100%. But in our study, only half of the thrombus responded because there was no measurement of the thrombus length in our study, so we cannot subclassify as stage 1 or 2. Similarly, the presence of metastasis is an important prognostic factor, and another but the favorable prognostic factor is complete resolution of tumor thrombus. The strengths of the study were a relatively large sample size which were treated uniformly with long follow-up. However, the limitation was the non-measurement of the thrombus length in our study. So I'd like to conclude that management of Wilms tumor can be complicated by the presence of caval thrombus, and complete resolution of the thrombus on neoadjuvant chemotherapy, and those patients with non-metastatic disease have a favorable prognosis. Thank you.
Thank you, Dr. Nilay. You finished well in time. Questions from the honorable judges. Professor Archana, ma'am.
Yeah, Krishna, this is a very large study on IVC thrombus. And but you said that you are giving DD4 regime to these patients.
Yes,
am I right?
Yes, ma'am.
So this DD4 regime that you are giving in NWTS is the same as you give for stage 3-4, or when you are giving it for a thrombus, do you have any alterations in that? Any extra dose of adriamycin or something like that?
No, ma'am. We gave the same protocol only followed, but in our study, actually the median duration of chemotherapy was larger at 8 weeks. We usually do the response assessment at 4 to 6 weeks as normally we do in a normal stage 3 to 4. But this larger duration was because like some patients had defaulted with the treatment, and so they had to be given longer duration of treatment, and some patients had presented to us with receiving chemotherapy from outside. So these factors influence the total analysis in our study.
And were there any patients where you were not able to remove the thrombus? Were there any patients out of the 34 that you had presented?
No, ma'am. If the stage, according to the modified downstaging, if the tumor thrombus was stage 3 and above, that is above the suprahepatic, above that location, then we had also taken the help of the CTVS surgeons, and so we were able to remove the tumor thrombus in all the patients, ma'am.
Okay, thank you.
Thank you.
Thank you, ma'am, for your questions. Dr. Velumurgan, sir, any comments from your side?
Dr. Krishnan, good presentation. You mentioned out of the 32, one was upfront surgery for thrombus. What was that case? It didn't give chemotherapy.
Yes, sir. So that was because
in which case you said we had a uniform protocol for all cases. So you have done upfront surgery for tumor thrombus without chemo.
Yes,
Kindly
sir.
explain.
Yes, sir. Yes, sir. That was because this patient, during the imaging, there was no documented IVC thrombus. So we had done
it was a surprise.
It was a surprise.
I am also surprised by the fact that you were able to remove the thrombus in all your 34 or 32 cases because post chemo, many times the thrombus, it's been my experience that it probably adheres to the wall and gets organized, and it's very difficult to remove it post chemo. So I'm very surprised that you have been able to remove it totally in all cases. My third question is that's just a comment regarding the cycles of chemo. How long do you give the chemotherapy before you you do the endpoint of chemo and the indication for surgery, complete resolution of the tumor thrombus, or do you have a fixed number of cycles? Because you didn't mention that in the paper.
Yes. So in our study, we followed according to the NWST protocol. We did the tumor reassessment at 4 to 6 weeks post the neoadjuvant chemotherapy. But as I said, some patients had longer duration of chemotherapy as high up to 12 weeks. But this was because they had defaulted in between, and so they had to be given a longer duration when they presented again. And some patients are also presented after receiving the chemotherapy from outside. As to the as you said, the longer duration of chemotherapy will lead to larger adherence of the tumor to the IVC wall. So therefore, we do not recommend giving chemotherapy more than the 6 to 8 weeks as we did in our study. But we were able to successfully remove the tumor thrombus, but we required extensive resection. For example, in one patient, we required excision of the part of IVC wall on patch repair, and some patient required cavectomy, and some patient even required cardiopulmonary bypass and aortotomy. So with these interventions, we were able to successfully manage the tumor thrombus, sir.
And Dr. Krishnan, you are a resident?
Yes, sir, I'm a resident, sir.
Yeah, then I can ask you a question. Now, what do you prefer to diagnose? Which is a better modality to diagnose a thrombus in the IVC or the renal vein? A Doppler or a CECT in your experience?
So CECT is the best modality to diagnose as well as document. But if for this, the major thing is the quality of CT should be very optimal.
No, my question is very clear. Would you prefer a Doppler or would you prefer a CT to look for
CCT imaging?
So you say a CCT is a better modality to diagnose a thrombus.
Sir, because this will be also able to locate the kidney.
Suppose you have got a pelvic mass, the kidney doesn't image. How will you see the thrombus? Right.
Yes,
so how you would still maintain that CECT is a better modality? Okay, I think I've made my point. Thank you. We should give opportunity for others.
Thank you, sir. Comments and questions from Dr. Sailesh.
Thank you, Dr. Krishnan. It was very nice presentation. Just curious about your IVC patch case. So, which type of graft you used in that? And I want to also know that in that patch IVC, what was the histopathology? There was viable tumor because, like Velumurgan sir said, it's after chemo, it's almost fibrotic. So it's very difficult to remove, and that was I think that was the reason to remove that IVC patch. So tumor was there in that segment.
Yes, sir. The tumor thrombus was documented in only the total, even though the total number of surgical interventions was 32, but the tumor thrombus was documented in only 19 cases. But of those cases, 17 patients had a viable tumor thrombus, sir.
No, I just want to know that whatever the IVC part you resected and sent,
Yes,
in
sir.
which section the tumor was viable?
Yes, sir. Within that, in that thrombus within the IVC, the tumor was viable in the out
In
of the
which type
documented
of
cases.
graft you used for the IVC? Which graft you
Pardon,
used
sir?
for IVC?
I
What
didn't-
type of graft you used for IVC? When
So
you
we in the one patient we used the graft that was autologous pericardial graft, sir.
Okay.
The patch repair.
Thank you.
Thank you, Dr. Salesh. So a lot of comments have been made. I had some comments, but I'll skip those for now. The next presenter is Dr. Pallav from Narayana Health at Bangalore. Dr. Pallav, please share your screen. Dr. Pallav, are you there in the meeting? You are muted, Pallav. Please unmute yourself.
Yes, sir. Yes, sir.
Yeah, share your screen.
Sir, if you, I will take next presentation. I think I am having some problem with sharing the screen.
Okay. So fine. We'll go on to the next. Okay, I'm presenting next on our experience of opsoclonus myoclonus. So I'll just quickly present. Good afternoon, judges, and we would be presenting. I would be presenting our experience of the Kingsburg or the opsoclonus myoclonus syndrome in consecutive 18 patients. We have nothing to disclose. It is a rare entity which looks at less than 1.8 per million cases seen in the world, approximately seen in the world. And there are several healthcare workers in the West who will never see a case of opsoclonus myoclonus in their entire lifetime. The four main components of this syndrome are the opsoclonus, the myoclonus, the ataxia, and behavioral or sleep disturbances with or without irritability. OMAS in children has association of almost 50% neuroblastomas. 3 of the above 4 should at least be present to call it an OMAS syndrome. There are a lot of new mechanisms which are proposed, but the main concept is now autoimmune channelopathy, and the autoimmune antibodies are being looked at from the adult oncology sides. But what is interesting is the CSF chemistries are increasingly being used, and the B cell activating factor is something which is extremely important in looking at the severity of OMAS. It is also known that neuroblastomas secrete BAFs, and they also increased lymphokines, which causes increased lymphocytic activity, and these lymphocytes are supposed to have cross-reactivity via unknown immunology. Genetics also plays an important role. So we aim to analyze clinical profile, symptomatology, and management protocol in our patients. This was a retrospective analysis in a single unit, and we looked at patients from June 17 to 21. So what we do is we screen for neuroblastoma in all patients of OMAS, and this is the methodology we go for. We initially did a MIBG scan, but recently over the last maybe 4 or 5 years, we are very comfortable with the Dotanek PET scan, and preferably this is done before an ACTH injection is given. And this data has been published from our nuclear medicine colleagues. Then the pediatric neurology team comes in and looks at the OMAS severity scale assessment and decides on the neuroimmunomodulation. I won't go into details. Then the surgeons are called in for the local treatment, and we reassess the patient commonly together at 6 weeks. And in case of relapse, we start the whole process all over again. So in our results, we had a total of 18 patients with a mean age of 16. Gender predilection was similar in both genders. Almost all patients except for one had myoclonus, 12 had opsoclonus, and almost 14 had ataxia. 6 patients had regression of symptoms and developmental delay, which is a very important marker, and pediatricians should be sensitized to looking at this. The average time duration to symptoms, duration of symptoms at presentation was around 1.7 months in our series. So this girl had this opsoclonus component, which was quite significant. And once the surgery was done, she improved significantly. So the aims of treatment in this disease cohort is to localize the primary tumor. And a PET scan in our experience shows a good localization, but we need to sometimes do an MRI or PET and a CT along with a PET CT sometimes. So it is extra radiation, but sometimes tumor localization is difficult. So surgical anatomy is then looked at with the all basic tenets of how neuroblastomas are looked at, and metastatic workup is also done. We had 2 tumors in the posterior mediastinum and rest were all in the abdomen. So this was a very interesting case, a child who presented with a OMAS with no tumor anywhere after extensive searching. And after 6 months, when repeat imaging was done, this sliver of tumor at the right crus of the diaphragm, which was very difficult for me to pick up initially, but then the PET scan repeated showed a blush over here. And then this child was, this tumor was excised and has done well afterwards. Immunotherapy was as follows. The average duration of the surgery was 100 minutes approximately. We did both minimal invasive and open, but predominantly it was a laparotomy. And what I need to, these were the incisions and the duration we've already discussed. What I need to discuss over here is the IDRFs or the image defined risk factors versus the safety of resections, because most of these tumors are good neuroblastomas, differentiating neuroblastomas, so you can safely leave behind tumors, even though the immunogenicity may be a problem, but oncologically they may be fine to leave behind a sliver of tumor and not do heroic resections here. We had 11 cases of differentiating neuroblastoma and 3 of poorly differentiating. In our results, there was complete resolution with surgery and immunotherapy in 8 patients. 6 had partial resolution, out of which 4 patients have had significant neuropsychiatric disorders and delayed milestones. 2 patients had relapse of symptoms. In these, extensive search and workup for tumor recurrence was done, which was not there. And one of them was started on rituximab, but could not complete therapy because of financial issues. And 2 patients have died. One has died and one we have not been able to trace. There are several articles in literature, but neuroblastoma with OMAS is reported rarely. And the largest series comes from the CHOP, which is 14 patients. So what at conclusion, we had a younger presentation of patient groups. The gender was also equivalent, and remission of symptoms is not just the domain of the surgeons. It requires prolonged immunotherapy, and it is probably time to look at prognostic and diagnostic biomarkers. The image defined risk factors should be kept in mind while taking care of these resections, and minimal access surgery is something which can be used to tackle these tumors. Thank you so much.
Dr. Peters, it was a very interesting presentation. Am I on?
Yes, sir. Yes, sir. Please.
Yeah. You are presenting all your cases are presented primarily with OMAS without any tumor on initial screening, is it? Or?
No, so these are the cases of OMAS which had a tumor with them. We have excluded
obvious,
the case,
which was obvious, yeah. Okay.
Yes,
okay.
Sir. Which we excluded patients of infectious OMAS and other etiologies of OMAS. Only neuroblastoma associated with OMAS.
Was there any diagnostic confusion due to Vincristine therapy and OMAS, children with ataxia?
Thank you for that question, sir. So none of our children had a pre-operative chemotherapy in this series. 2 patients with the undifferentiated neuroblastoma received chemotherapy in the post-op period. So we did not encounter that problem. Point well taken, sir.
Yeah, I'm done.
Thank you, sir.
May I come in?
Yes, ma'am, please. Hello, ma'am.
Hello.
Yes, ma'am. We can hear you, ma'am.
Hello, am I audible?
Yes, ma'am, you're audible. Please go ahead.
Yeah. Yeah, I want to thank you for this talk. It's quite a rare presentation of neuroblastoma, but my question to you would be on duration of immunotherapy. You did show it in a slide, but it was just a very passing thing. So can you elaborate on that? How long do you give immunotherapy to these children?
Yes, ma'am. So the immunotherapy is quite prolonged, and I've not shown that because of shortage of time. The immunotherapy is generally given from, depending, there is a OMAS severity score which we calculate, and we look at the OMAS severity score depending on the symptomatology of the patient, both neurological and the oncological symptomatology. And once that score is, it is divided into mild, moderate, and severe, and then the immunotherapy is decided. The longest we have given is almost 3 years. So the long-term sequelae of steroids and ACTH therapy is also a problem which will come up in these children in the long-term future, which are being looked at by our medical colleagues.
Thank you.
Thank you, ma'am.
Can I ask a question? Ramesh here, Bangalore. Yeah. See,
Thank you, Dr. Nitin. It was really nice presentation. No question from my side. Just a comment that everyone should know that even after the complete tumor resection, the symptoms will not resolve, and parents should be aware of this, and we should counsel about it and require immunotherapy in cases. Thank you.
Thank you, Dr. Sailesh. Thank you. Yes, sir. Ramesh, sir, you were saying something, sir?
Question is what Sailesh was saying, because in most of the cases that we have operated, the symptoms did not go away. It took a long time, and obviously parents are a little confused, but we had counseled them well. So my question is, how long did it take? Because you said majority of the cases, the symptoms came down en masse. So just wanted to know what is the number in which it came down quick, and what number it took longer time.
I don't have a breakup of the time of resolution, sir. So I'm not very sure of that right now. But the answer I would give is that the longest we've given immunotherapy is for 3 years, and these patients have been. Their immunotherapy also decreases with time. So somebody who's on IVIG plus ACTH will come down to just oral prednisolone over a period of time, and that also at a tapering dose. So I don't have an answer to your question of this time difference of their decrease in symptoms. I have not looked at that, sir.
No problem. Thank you very much. Well presented.
Thank you, sir. So we'll move on to the next person. Dr. Pallav, are you ready to share your screen?
Yes, sir. Yes, sir.
Yes, please share your full screen.
So my screen is visible, sir?
Yes, yes. Please put it in slideshow mode.
Yes.
And as soon as you start, we'll look at the timer.
Yes, sir. I'll start my presentation.
Please do. Please do.
Good morning, everyone. I'm Dr. Pallav Kumar from Narayana Health, Bangalore. I will be presenting our experience on outcome of high-risk neuroblastoma. So introduction, neuroblastoma is the most common extracranial solid tumor in childhood. Prognosis correlate with age at presentation, stage of tumor, the degree of differentiation, and site of tumor and tumor biology. While the standard of treatment for high-risk neuroblastoma is chemotherapy, surgical resection, stem cell transplant, radiation, and maturation therapy, there is a growing evidence that these tumors are aggressive and are resistant to these therapies. So the INRG utilizes a classification system that include multiple risk factors to stratify the patient pre-treatment group. These factors are INRG staging, age at presentation, histological category, grading of the tumor differentiation, anemic amplification, 11q aberration, and ploidy. So, and the treatment strategy currently used for patient with neuroblastoma is firstly the induction chemotherapy, where we harvest stem cell at this point, and we prepare the patient for autologous stem cell transplant. And post induction chemotherapy, the child undergoes the surgery, and post surgery there is a consolidation chemotherapy where we remove the minimal tumor that is present with this myeloablative chemotherapy. Followed by this myeloablative chemotherapy, the patient undergoes autologous stem cell transplant, and further radiation therapy is given. Post consolidation child receives maturation therapy, mainly isoretinoic acid and immunotherapies and cytokines. Our aim is to present the outcome of high-risk neuroblastoma. So the study type was as a descriptive, retrospective, and prospective study. It was a longitudinal study. Inclusion criteria is children with high-risk neuroblastoma as per International Neuroblastoma Risk Group, risk stratification, who presented to us from January 2015 to 2021, were included in this study. Exclusion criteria is none. Place of study is Narayana Health, Bangalore. These children received treatment as per COG protocol. induction therapy, surgery, and then high-dose chemotherapy, followed by autologous stem cell transplant, radiotherapy, and then maturation therapy. Longest follow-up period was 58 months, 6 to 5 months. Average follow-up was 20 months. Minimum follow-up period was for 6 months. And outcome parameter assessed was overall survival. Observation, our total number of children included in the study was 22. 14 were male and 8 were female. Age of presentation was from 4 months to 154 months. Mean age of presentation was 54 months. Children who presented with at less than 18 months were 4, and more than 18 months were 18. The site of the primary disease was retroperitoneum in 19, and in 3 it was mediastinum. The stage of presentation was stage 4 in 20 patients, and stage 2 in stage 3 in 2 patients. Metastasis, the common site, metastatic site was bone marrow, but 7 of them has multiple site metastasis. Anemic amplification was positive in 8 of 8 patients, and it was negative in rest of the 14 patients. So the outcome was number of children were 22, lost to follow-up were 5, and 17 patients we followed up. Out of these 17 patients, 6 are currently disease-free at the end of the study, and 10 children had died or succumbed during the treatment or after the treatment, and 1 child is on palliative therapy. So this is the Kaplan-Meier graph, which is showing the overall survival of this high-risk neuroblastoma in our study is around 30 to 40% at the end of 5 years. So my conclusion is that a majority of the children with high-risk neuroblastoma presented to us with after 18 months of age, and the most common site of primary was retroperitoneum, and the most common site of metastasis was bone marrow, and about 1/3 had more than 1 organ involvement. And overall survival in high-risk neuroblastoma in our study was, despite treatment, was around 30 to 40%. Thank you.
Thank you, Dr. Pallav. You finished just in time. So questions from the judges, Dr. Velumurugan, sir.
Dr. Pallav,
yes, sir.
There's one question. I would like to know how many of your cases of high-risk neuroblastoma were mediastinum?
3 were mediastinum.
And did they survive?
Separately, I have not seen, sir. I think they were both, only 3 were the mediastinal, and separately I have not seen, sir. Exactly.
Okay.
Thank you, sir. Dr. Archana, ma'am, any questions from your side?
Yeah, Pallav, I would like to learn from you that how many of your kids who were less than 18 months of age had anemic amplification?
Ma'am, they were children's, exactly, it was not mentioned, ma'am, but they were children less than 18 months. Even at one of our child was at one month of age who presented with this anemic amplification was there in that child.
Okay. Okay. And was there any difference in survival between those who were less than 18 months and more than 18 months with high-risk disease?
Yes, ma'am. Yes, ma'am.
Difference in survival and tolerance to this very high-ended sort of treatment, which is needed in these patients.
Ma'am, a few factors are also there included in this, not only the age, the tumor biology and the tumor differentiation and the tumor histopathology also plays a major role, ma'am. So the thing is that this tumor biology is the major factor. What we see here, that if the tumor is undifferentiated or poorly differentiated, these children will have more risk. They are into more risk, and their survival rates are very poor as compared to the other children. Even if it is more than 18 months of age, we have got children who were more than 18 months of age. Even at 4 or 5 years, they presented to us with mature tumor, and they were completely excised, and they had a good survival rate. And in smaller children having a poorly differentiated or undifferentiated tumor, these children had a very poor outcome, and these children had to undergo this all high-risk chemotherapies and had a poor outcome in spite of this transplant and radiotherapies.
Okay, thank you.
Thank you, ma'am. Dr. Sailesh, any comments or questions from your end?
Thank you, Dr. Pallav. Nice presentation, and you presented the standard treatment regimen, so no confusion regarding it. Just you mentioned lost to follow 5 children. So I would say it's very unlikely in oncology that children are lost to follow. If they survive, they come. So most of the time they are not alive.
Yes, sir. Yes, sir. Yes, sir.
And we have all the data, so we can make a contact to them.
Yes. Okay.
So I would say it's not lost to follow. They will.
But the thing is that my study was a retrospective study, so I've collected data from the past. Also, for past 2015, it is collected. The thing is that contacting those people who mainly these 5 people were difficult. I was not able to contact them as their numbers are changed. They are not coming visiting the hospital. Might be the child has not survived, but still I was not able to follow up. So I mentioned that.
Just I make a point that in oncology it's very unlikely, like other diseases, they lost to follow. Thank you.
Thank you.
Thank you, Dr. Sailesh, for that relevant point. We'll move on to the next talk. Dr. Mehak, please go ahead with your presentation.
Yes, sir. My video is seen and my voice is audible clearly?
Yes, please go ahead.
Okay. Greetings from the Department of Pediatric Surgery, AIIMS, New Delhi. We would be presenting the complications of therapy in survivors of hepatoblastoma. I have no disclosures. Hepatoblastoma is a rare pediatric malignancy with surgery and chemotherapy being the primary modality of treatment. There are significant side effects that are evident in survivors, which are important considerations for their long-term rehabilitation into society. The aim of our study was to evaluate the long-term complications of therapy in survivors of hepatoblastoma treated at our center. It's a retrospective study of patients diagnosed between January 1994 to January 2016. A survivor was defined if the patient was alive more than 5 years after diagnosis, as per the standard definition. The follow-up was according to the international institutional protocol, and I present our interim analysis with preliminary results. The inclusion criteria was children with a diagnosis of hepatoblastoma diagnosed before 1st January 2016, and those patients who could not be contacted, had missing records, or had refused to participate were excluded from the study. At the time of follow-up, any general complaints or any symptoms of organ dysfunction were noted. Anthropometry was noted and was categorized according to WHO growth charts for children less than 5 years and IAP growth charts for children more than 5 years of age. Doxorubicin, for looking at the effect of chemotherapy, in case the child received doxorubicin, we got an echocardiography done to look at the ejection fraction, dilated cardiomyopathy, or any evidence of myocardial dyskinesia. To look at the effect of cisplatin, we got the glomerular filtration rate done using technetium-99 DTPA by 2 plasma sample method, and pure tone audiometry, which was subsequently graded according to the older Brock's ototoxicity grading scale, as well as the newer and more sensitive Sayer-Boston ototoxicity scale. We had a total of 59 patients that we considered as survival, but data was not available or were lost. Patients were lost to follow-up. That way, after excluding them, we had a total of 48 patients, which was subcategorized into standard risk and high risk. We had 15 patients belonging to standard risk and 33 patients were high risk. The male to female ratio was 3:1. The mean age at diagnosis was 19.2 months and the median age was 12.5 months. Majority of our patients belong to pretext stage 2 and 3. Hepatectomy was performed in 42 patients and extended hepatectomy was performed in 14 patients. And metastatectomy was done in 2 patients. 48 patients received cisplatin and 38 patients received doxorubicin as a part of chemotherapy. Other chemotherapeutic drugs were given in 4 patients. The median age at follow-up was 9 years and the median time since diagnosis was 8 years, ranging from 5 to 17 years. Coming to our results, 4 patients reported subjective difficulty in schooling and academics due to social reasons as well as hearing-related issues. 1 patient had a history of suicidal attempt. 1 patient had a conduct disorder. Persistent alopecia areata was seen in 1 patient. Most of the patients were active and few reported other symptoms. Cholelithiasis was present in 1 patient who had to undergo a cholecystectomy after having undergone a left hepatectomy. Right temporal migraine was diagnosed in 1 patient and 2 patients had abnormal ultrasound findings. One patient had a right renal cortical cyst and one patient had hydronephrosis, which was obstructive on a renal dynamic study. We evaluated the anthropometry and found that severe stunting and malnutrition was noted in 41 and 30% of our patients at presentation. However, there was a catch-up in the growth and nutrition. At the last follow-up, severe stunting and malnutrition was noted only in 7.5 and 12.8% of the survivors. Glomerular filtration rate was available for 34 patients and was above 60 ml per minute per 1.73 meter square in all patients. 9 patients, which was 26%, had a GFR between 89 and 60 ml per minute. However, none of them were symptomatic for any other renal abnormality and had a normal renal ultrasound. A pure tone audiometry was done in 37 patients to look for high frequency sensorineural hearing loss. 4 patients had symptoms of hearing loss and 1 patient was using a hearing aid. SIOP grading system was, when we evaluated using the SIOP grading system, we found that hearing deficits were found in 14 patients and severe deficit characterized by grade 3 and 4 were found in 11 patients, with only 4 patients having clinical symptoms of hearing loss. According to the Brock's grading system, a hearing deficit was present in 13 patients.
15 seconds to go.
Yes, sir. And severe deficit in 1 patient. Echocardiography revealed a normal ejection fraction in all patients. 2 of our patients had subacute intestinal obstruction and there was 1 death noted. Hepatoblastoma is a rare pediatric solid tumor and there are more number of survivors. We need to improve their quality of life to improve their social integration. 2 of the most common side effects noted are the ototoxicity and cardiotoxicity. However, these long-term close follow-up is needed as cancer treatment is not the end of treatment. Thank you.
Thank you, Dr. Mahek. You overshot the time by around 30 seconds. So I'll request the judges to be just one quick question each. Dr. Balomurgan, Dr. Velumurugan, sir, sorry.
Yeah.
Yes, sir, sorry, sir.
Not at all. You mentioned how many of your cases had cardiotoxicity. I didn't see that on the slide.
So none of our patients had any cardiotoxicity. Echo was normal in all our patients.
So my observation is other than the renal and the ear problems, the rest of the associated problems could have been just incidental and not causal, right?
Yes, sir.
Okay, I'm done.
Thank you, sir. Thank you for that comment and question. Professor Archana Puri, madam.
Yeah, Mehak, it's a very interesting study. What I want to know from you is that
Ma'am, you're muted. Dr. Archana, ma'am, please unmute yourself.
am I audible?
Yes, ma'am,
Yes,
clearly.
Yes, ma'am.
Yes, ma'am. Between those who received just cisplatin and Plado, did you note any difference in the long-term outcomes of these patients as far as the ototoxicity and cardiotoxicity and other things were concerned?
Ma'am, those patients that were transferred from cisplatin monotherapy to Plado definitely received a higher dose of cisplatin, and there were a more number of patients who had high frequency hearing loss. But we are in the process of evaluating that data, whether the correlation was significant or not, because this was a very limited number of patients. So we are planning a bigger study to evaluate whether it is significant or not.
And just an observation and a little query, that you had 33 patients who were in the high risk category, but the Plado regime was given to 38. That means 5 patients of the standard risk also received Plado.
Yes, ma'am.
So what was the indication for that?
Ma'am, either the tumor did not respond to treatment or there was a metastasis that had developed. So that is why the upgradation of chemotherapy was done.
So in these 5 patients?
Yes, ma'am. They were standard risk at presentation and then they were subsequently upgraded and they became high risk. So they received Plado therapy.
Thank you. Thank you.
Thank you, ma'am. Dr. Sailesh, any comments and questions from your end?
Thank you, Mahak. Nice presentation. If I'm not mistaken, you mentioned that 40 children underwent extended hepatectomy.
Yes, sir.
Right? So in your analysis, was there any difference between the stunting growth between the standard hepatectomy and extended hepatectomy? And second question of same, how much liver can you dissect that to be safe for the future perspective?
So we did not note any difference as such between extended and just a standard hepatectomy. Generally, in pediatric age group, the growth of the liver is adequate, and children generally grow well. So there is no cutoff as such, sir, that we found.
So how much percentage of liver can you expect? How much liver reserve should be there to
Sir,
prevent
around
liver failure?
20 to 25%.
Okay, 65 to 75% you can resect if it is a good liver reserve is there. Okay, thank you.
Thank you, Dr. Salesh. We'll move on to the next presenter, Dr. Rashmi. Yeah, you can start and I'll start your time along with it.
Yes. Good afternoon, respected teachers. I'm Dr. Rashmi, resident at RML Hospital, New Delhi, and I'm presenting a profile of solid tumors in children at a tertiary care hospital.
Yeah.
Pediatric solid tumors are defined as non-hematologic malignancies of childhood, which are the leading cause of disease-related mortality in children, with an annual incidence of about 400,000. In developed nations where comprehensive services are easily accessible, more than 80% of these children are cured of their cancer, whereas the same is estimated to be 15 to 45% in resource-poor nations. The study of demographic profile of pediatric solid tumors may help gain insight into any regional or environmental factors that contribute to the causation of such tumors. So with the aim to analyze and summarize the demographic profile of solid tumors, we started this study with the objectives to determine the age of presentation, sex of the child, stage of the disease, line of management, and outcomes. We included patients less than 12 years of age with pediatric solid tumors and excluded those with associated congenital anomalies and hematological malignancies. We conducted a retrospective observational study during the period of July of 2015 to December of 2020 at Dr. RML Hospital. Out of a total of 103 patients with solid tumors, 77 were male and 26 were female, with male to female ratio of 3:1, and the overall survival of 73.78%. Majority of them were renal tumors, that is 44 patients, out of which 25 were Wilms tumor. Rest included clear cell sarcoma, RMS, and others. The tumor distribution, the majority of the tumors were germ cell tumors, followed by Wilms tumor, neuroblastoma, and others. Wilms tumor patients were treated with COG protocol. Male to female ratio was 1.8:1 and mortality of 24%. Germ cell tumors, the majority of them were mature teratomas. That is, we saw them in 48% of the patients, and then 13.79 patients had immature teratomas. Others included yolk sac tumors and mixed histochemistry. Again, to categorize them as gonadal and extragonadal, we saw 13 patients of sacrococcygeal teratoma, as you can see from this image, type 3 sacrococcygeal teratoma. Apart from this, we had retroperitoneal, gastric, mediastinal, and cervical germ cell tumors. Chemotherapy was given in 14 of these patients, out of which neoadjuvant was given in 2. Recurrent or residual was seen in 6 patients, and the mortality was only 13.7% with an overall survival of 92.59%. These are the images of mature teratoma as seen on X-ray, intraoperatively, and after excision. Neuroblastoma was seen in 12 patients. The male to female ratio was 3:1. Most of them were diagnosed at a later stage with in 75% of the patients. The mortality was about 33.34%. These images, interestingly, are of 2 patients who presented to us on the same day with similar manifestations of distended abdomen and gross ascites. The top image is of a patient who was diagnosed of neuroblastoma but died of the condition before we could even initiate the chemotherapy. Whereas the bottom image is of a patient who was started on neuroblastoma chemotherapy, was given for 2 cycles. And because he did not show any response to therapy, we had to repeat immunohistochemistry and confirm that it was actually Ewing sarcoma. He's still in our follow-up and has shown dramatic improvement to the chemotherapy. The others included malignancies like soft tissue sarcomas, angiomyolipoma of the leg. The right bottom image shows a dermoid of the neck. The left image shows phylloids tumor. Overall outcome, the remission was noted in 76 of the patients. There were 7 defaulters, and 22 of the patients died either of the disease during treatment or during follow-up. Discussion: cancer affects all nations, and therefore it is an endemic disease with considerable variation in frequency according to the site incidence. In the last 3 to 4 decades, mortality rates have improved in more than 50%. The factors responsible for this improvement is reliable and systematic tissue sampling, improved efficiency and availability of chemotherapy drugs, multimodal approach to therapy, improvements in the field of radiological imaging, better understanding of the disease process, and overall care provided to the patient. In low and middle income countries where 80% of the children live, the 200,000 children diagnosed with cancer each year have limited access to curative treatment and only about 25% survive. The difference in survival for children diagnosed with cancer between high and low income countries continues to widen as curative therapies are developed in the former but not implemented in the latter. These are the other 2 studies conducted in India, in Kashmir to be precise. Their results are not exactly comparable to ours. It could be that they have included more other tumors like CNS tumors and osteosarcomas, Hodgkin's lymphomas, which we have excluded from our study.
Dr. Rashmi, could you wind up, please? You're
To conclude, zoomed out image of the current tumor burden is essential to address the finer issues facing their management. Long duration of treatment, poor follow-up, advanced stage of presentation are the contributing factors for dismal outcomes in pediatric solid tumors. Thank you.
Thank you, Dr. Rashmi. Questions from honorable judges, Dr. Velumurugan, sir?
Dr. Rashmi,
yes,
I would like to know what was the aim of your presentation?
Yes, sir. We have noticed that there are not many studies that have established epidemiological profile in the country, sir. There have been very few studies. Most of them focus on a single kind of malignancy, let's say germ cell tumors or Wilms tumors or neuroblastoma. But there are very few studies that have established a proper pediatric solid tumor profile. This will help us mobilize the resources properly with respect to what tumor affects which region. According to my study, Wilms tumor is more common than neuroblastoma. So resources can be mobilized accordingly. Awareness programs can be created. Screening programs, if necessary, can be mobilized. So to establish statistical data of what tumors are more prevalent in our region, we went about this.
Okay.
Thank you, sir. Dr. Archana, ma'am, your comments and questions on this.
Yeah, Rashmi, my question to you would be regarding your data on neuroblastoma, where you had presented 12 patients with 75% having stage 4 disease and with only 33% mortality. So I was very interested in learning from you that what would be your protocol of management for these patients, because this is a very good survivor survival figures for me, according to me.
Yes, 75% is stage 4. Yes. So, we had even patients who had presented with retroorbital mets and scalp mets at presentation, but they had responded very surprisingly well to our chemotherapy regimen. We have followed the AIMS chemo protocols as provided to us. And for neuroblastoma, we have gone ahead with cyclophosphamide, cisplatin, and adriamycin etoposide regimen for chemotherapy. And basically, I think most importantly, these patients, we have counseled, all the patients we counseled regarding the need for long-term follow-up. And these patients, surprisingly, the parents were well-educated and they used to bring them for good follow-up, and they have shown good.
So were they disease-free? Were they disease-free, and are you following that induction, consolidation, and those sort of protocol for your high-risk neuroblastoma, or it is just the St. regime of chemotherapy that is being practiced at AIMS?
The same protocol that is followed at AIMS, ma'am.
So were these patients survivors, or it was just an absence of mortality during the period of study? Were they disease-free?
No, ma'am. One patient after 2 years of follow-up has passed away, ma'am. So in the study period, it did show good response.
Okay, thank you so much. Thank you.
Thank you.
Thank you, ma'am. Dr. Sailesh, question from your side. And I would request Dr. Anju to please share her presentation.
Thank you, Dr. Rashmi. You mentioned in your slide that you assessed age of distribution. So I couldn't see in your presentation the age distribution. My question is regarding the how many tumors were the neonatal tumors, which you diagnosed before 1 month of age, and how many were antenatally diagnosed, like cephalococcal teratoma, ovarian tumor, you can diagnose antenatally. So I couldn't get information in your audit.
Yes, I'm sorry. I removed those things to reduce my time for the presentation, sir. Most of my the tumors were presented between 1 to 3 years of age, the toddler group, followed by 5 to 12 years age group. Less than 1 year, we had only 4 patients altogether, and out of which 3 were sacrococcygeal teratomas. Antenatally detected, we have got only 2 patients, sir, not more than that.
Okay. Can you tell what is the difference between the neonatal tumor or antenatally diagnosed tumor and in the children diagnosed at later age? Histopathological.
For this study, I had categorized as presenting before 1 year of age, 1 to 3 years, 3 to 5 years, 5 to 12 years, and beyond.
Okay.
So according to that age category, I had taken the data, sir. So prior to 1 year and antenatal were combined.
Okay, thank you.
Thank you.
Thank you, Dr. Sailesh. The next presenter is again Dr. Anju Verma from SGPGI. Dr. Anju, please make your screen slides, full screen, and go ahead with your presentation. You are muted, Dr. Anju. Dr. Anju, you need to unmute yourself.
Bottom of your screen, there is a mute button.
Dr. Anju, are you able to find
Yes,
that
sir.
mute button? Yes. Okay.
No,
Please. Yeah. Please go ahead with your presentation.
Good afternoon, respected teachers and judges. I am Dr. Anju from SGPGI, Lucknow, presenting non-Wilms renal tumor difficulties in diagnosis and management. As we all know, 85% of renal malignant masses are Wilms tumor, rest 15 are rare tumor. Non-Wilms tumor are infrequent and around they are less than 1% in all pediatric tumor. They are diverse group of lesion with variable malignant potential, include clear cell carcinoma, sarcoma, kidney malignant rhabdoid tumor, renal cell carcinoma, congenital visceroblastic nephroma, cystic partially differentiated nephroblastoma, and less common tumor like even sarcoma, synovial sarcoma, cystic nephroma, and others. Among these, clear cell sarcoma and malignant rhabdoid tumors are what commonly considered unfavorable Wilms tumor. So due to their relative rarity, acute diagnosis and therapy continue to be challenged. Differentiation is important for better outcome, and currently histopathology, immunohistochemistry, molecular markers are used for definite tissue diagnosis and to differentiate them. The treatment ranges from surgery alone to multimodality therapy, including chemotherapy, radiotherapy, immunotherapy. In the third world countries like India, the lack of awareness, education results in late presentations of the patient. Limited resources and lack of oncology center made the situation unstable, resulting in delayed or incorrect diagnosis and poor outcome. So our aim was to present our management experience in patient of non-Wilms renal tumor. Methodology, it was a retrospective review of non-Wilms tumor cases from January 2013 to July 2020. Data collected regarding presentation, management, and follow-up with special attention on diagnostic difficulties. Total over a period of 7 years, total 10 patients were included. Age was 7 months to 8 years with median of 36 months. Out of this 10 patients, 4 patients had already received chemotherapy before referral. And out of these 4, 3 patients had histopathology reports of Wilms tumor. Report biopsy was done in 6 patients. Now, this is a detail of all patients. Out of 10, 3 patients were of E-Iapscon nephroma, and they were given for nephrectomy. And 2 are doing well, and 1 has been lost in follow-up. And 4 patients are of clear cell sarcoma of kidney. Out of them, 3 patients received chemotherapy, surgery, and radiation, and 1 patient referred to as meds and was very sick. So he managed conservatively but expired during the treatment. 2 patients were of rhabdoid tumor and they were given a chemotherapy, surgery, and radiation and doing well. And 1 patient is of Ewing's sarcoma. She is also doing well in the follow-up after surgery or radiation. Out of them, 4 patients have received chemotherapy before referral. So this is the picture of right renal mass before surgery. After surgery, when the histopathology was done, it shows clear cell sarcoma, which was diagnosed as Wilms tumor previously outside. And this is the right renal mass before surgery, and which came out to be maintained as CD99 positive, suggestive of Ewing sarcoma. Coming to the discussion, renal mass is the most common retroperitoneal mass in the children. Non-Wilms renal tumor account for 15% of all pediatric tumors. The semen has good prognosis after complete oxygen. Most cases of semen are cured by radical nephrectomy and lymph node sampling. The metastasis of lung, liver, brain, and heart have been reported. So they need to be on regular follow-up. Clear cell sarcoma of kidney have poor outcome and has tendency to metastasize to bone. Approximately 5% have metastasis at the presentation. And 4 independent prognostic factors has been described for them, that is stage, age of diagnosis, tumor necrosis, and treatment with doxorubicin. The rhabdoid tumor of kidney has been most aggressive lethal tumor characterized by early onset of local and distant metastasis. Overall survival is only 20 to 25%. Histogenetic origin remain obscure, and 10 to 15% have synchronous or metagonous brain tumors in them also. Even tumor has been extraordinary rare tumor of the kidney, usually seen in young adults. Is there an aggressive tumor and high recurrence rate is there? 5-year survival is less than 10% without chemotherapy and radiation. Aggressive surgery and chemoradiation is the mainstay of the therapy. So various studies said that the age of the diagnosis is most common prognostic factor for rhabdoid tumor. And as per pediatric treatment editorial board, there is no standard treatment for rhabdoid tumor. For clear cell sarcoma, surgery, chemotherapy, and radiation therapy are the treatment mode. And for congenital mesothelioma nephropathy, it is nephrectomy and adjuvant chemotherapy for stage 3 and more. And for sarcoma, also there is no standard treatment. However, multimodal treatment and surgical approach seems to be have associated better outcome. So they are rare tumors, similar clinical and radiological characteristics to Wilms tumor. Preoperative diagnosis not possible without histopathology and animal history. Differentiation is important as each tumor has different chemotherapy protocol and treatment. In our cohort, 3 patients.
Dr. Verma, 20 seconds left. Please.
Yes, 3 patients had reports of Wilms tumor and got chemotherapy, but came out to be normal. One CMN patient was treated with thyroid substance, and 1 patient was expired during treatment. The conclusion: non-Wilms tumor are rare, need tissue diagnosis. Differentiation is mandatory for separate treatment protocol, and it is advised not to rely on previous reports in such cases and should revert the patient from beginning. Thank you.
Thank you. You finished just in the nick of time. So questions from Dr. Velumurugan, sir?
No, after hearing, I am breathless. I don't know why.
Yeah,
no questions.
A lot of data to present. Yes, sir. So, Archana ma'am, your questions?
Yeah, Anju, just a very short question that I may like you to answer.
Yes.
That based on your experience, what are the tips and the tricks that you would like to tell us to avoid pitfalls in diagnosis?
If a patient is coming with a referral from some time, we have to initiate a investigation from initial.
No, you're not getting my question. So Wilms tumor, as we know, is the commonest renal tumor. So based on your experience, what is your carry-home message to us? That what are the various things that you learned based on your experience, which may help us to avoid?
We have to see the children's age and symptoms. If he's a patient is an infant, then we have to think of that Wilms tumor will not be so much possibility in this patient. And if a patient has more than 3 years of age, the chances of Wilms tumor is also less. Then we have to think of other rare type of tumors, though they are less common, but they are we are seeing them. As the treatment protocol is totally different, so we have to think of other tumors and go for investigation for that. If the child is less than 1 year, so we can think of CMN in that patient. If the signal signs are hematuria and other, then we can think of even sarcoma in that patient and so investigate according to them.
No, what I wanted to learn was that at your center, are you doing any spatial cytogenetic tests or molecular tests in these patients to make the diagnosis?
Immunohistochemistry, not molecular.
Okay, thank you.
Thank you, ma'am, for that question. Dr. Sailesh, any questions from your end?
No question. Thank you.
Thank you, Dr. Sailesh. Dr. Preeti, please make your presentation full screen. This is the last presentation of this oncology session. After this, we'll have the session on systematic reviews. Yeah, Dr. Preeti, whenever you're ready, please start.
Sir. Can I start, sir?
Please do.
Good afternoon to one and all present here. I'm Dr. Preeti from Indira Gandhi Institute, Bangalore, here to present my study on neurogenic tumors of posterior mediastinum, which is a very rare condition and has a varied presentation. It ranges from simple benign to highly malignant lesions, and there is no standard protocol to manage such patients. We have retrospectively analyzed 8 children from 2014 to 2021. We have collected and analyzed the data of demographics, clinical presentation, radiology, pathology, and management and the outcomes of 8 patients. So among the 8 patients, 5 were females with a mean age group of 2.7 years, ranging from 1 month to 8 years, most of them being less than 1 year. Among the 8, 5 of them had respiratory symptoms and signs predominantly, like breathlessness, noisy breathing, decreased air entry. 3 patients presented with neurogenic symptoms and signs like opsomyoclonus, gait ataxia, regression of milestones, and dancing eye syndrome. All the patients underwent preoperative investigations of routine blood investigation, chest X-ray, imaging of CT or MRI, and metastatic workup, and MIBG scan and urinary VMA. Coming to the salient radiological features, the average size was around 3 into 2.5 centimeter, with 4 patients showing calcifications on CCT and compressing the adjacent structures and vascular structures, with intervertebral foramina involvement in 1 patient. Coming to the pathology, 4 patients were diagnosed to have neuroblastoma, 3 patients with ganglioneuroma, and 1 patient with ganglioneuroblastoma. This is the CT image showing the posterior mediastinal mass involving the spine. This is the overall picture of the management done at our institute. 2 patients underwent preoperative chemotherapy with VCR endoxin combination, and 1 patient among them had postoperative chemotherapy too. 1 patient presented to us with opsomyoclonus syndrome, which was given pulse steroid therapy by neurosurgeon for almost 2 years, and late diagnosis of thoracic thoracic neurogenic tumor was made. Though USG guided FNAC was tried in few patients, it was inconclusive in some patients, so thoracoscopic biopsy played an important role. 3 patients underwent thoracoscopic biopsy, out of which 2 were diagnosed this year and are still under observation, and no surgical treatment has been done as of now. 3 patients underwent thoracoscopic excision and 2 thoracotomy, and 1 patient underwent combined thoracotomy with laminectomy. All the patients underwent detailed histopathological examination. IHC markers were analyzed, MYCN gene was analyzed, and margins were positive in many of the cases. These are the intraoperative pictures. The first series shows the laminotomy, followed by the thoracotomy of the same patient, and that is the specimen that was removed. The second series shows the thoracoscopic excision of a small tumor abutting the subclavian vessels. All the 8 patients are followed up to date and are asymptomatic at present. As already mentioned, 2 patients diagnosed this year still haven't undergone any treatment, are under strict observations. Though initially postoperatively neurological symptoms had been persisting, they have been resolved over the time. I've compared our study with a few other studies of similar age group, similar presentation, and similar size and pathology. In one series, all the 6 patients underwent thoracoscopic excision with no complications. 2 other studies had higher number of patients, though the period of study was much more compared to our study. They had similar postoperative complications like in ours. In one study, they had a recurrence in 4 patients. The postoperative complications were pneumothorax, persisting Horner syndrome. So I would like to conclude my study with following key points. We should have a high index of suspicion in diagnosing these tumors because it presents with varied signs and symptoms. And formulating the management guidelines is very difficult, and it needs a multidisciplinary approach to manage such patients. Even with the tumor margins positive, surgical resections are safe and has good long-term outcomes. I would like to emphasize that thoracoscopy plays its role in diagnosing, excision, and in following up the patients. Thank you.
Thank you, Dr. Preeti. You've overstepped by around 15 seconds. I'll invite questions from the judges. Dr. Velumurugan, sir.
Yeah, nice presentation, Dr. Preeti. Your topic was neurogenic tumors of the posterior mediastinum.
Yes, sir.
But then you put a slide and you said that you did a thoracoscopic excision of a small tumor near the subclavian vessels. Isn't it incongruous? So you have the subclavian vessels in the posterior mediastinum?
No, sir. That patient actually had recurrence, sir. Initially presented with posterior mediastinal tumor. Later, there was a lesion in the anterior mediastinum too, sir.
Okay,
Initially,
suppose you have
we had given chemotherapy and steroid pulse therapy. Later, underwent thoracoscopic excision.
So if you had a neurogenic, suspected neurogenic tumor encroaching into the spinal canal,
Yes,
in which case, which would you tackle, or would you tackle both together?
Sorry, sir.
Would you tackle the spinal component or the thoracic component first? And if so, why?
Spinal component, sir.
You're correct. Why? Okay, you got a thoracic component. If you remove it, it might cause edema, bleed inside, and can worsen or precipitate a cord compression. Okay, so always do the laminectomy, remove the spinal component together with or preceding a thoracic component removal. Thank you.
Thank you, sir.
Thank you, sir. Question from Archana Puri, ma'am.
Preeti, did any of your patients presented with the spinal cord compression? I could see you had done one laminectomy. So,
yes, sir. Yes, ma'am.
So did any of your patients had spinal cord compression? And in
Yes.
emergency, how did you manage them? What was your protocol of management?
Actually, that was initially diagnosed and treated by the neurosurgeons as opsomyoclonus syndrome. They were giving pulse steroid therapy. Later, it was diagnosed to have thoracic neuroblastoma and then referred to asthma. So initial pulse steroid therapy was given.
Thank you, ma'am. Any questions from your side, Dr. Sailesh?
Yeah, Dr. Preeti, nice presentation. I'm interested in your thoracoscopic excision case.
Yes,
so, as you mentioned, it should be done preferably in small cases. So, can you elaborate about that case? Did that child receive any pre-op chemotherapy? Because in thoracoscopy, there's very small area,
yes, sir.
space, and if you get bleeding, it's very difficult to see. And after chemotherapy, everything is so fibrous, it's difficult even in open. So just want to know about that case.
Sir, in our study, 3 patients underwent thoracoscopic excision, sir, out of which 2 had initial chemotherapy given. The size was downsized and then later taken up for thoracoscopic excision, sir.
Okay, thank you.
Thank you, Dr. Sailesh, for that question. We'll conclude this session. And at the end, I would like to invite comments from senior teachers available in the hall. Professor Kailan Rao is here. Sir, would you like to give any comments on the presentations? Professor Rao, sir?
Nitin?
Sir? Yes, sir.
To add to what Shailesh was asking, because it's from my unit, I agree with him that after giving chemotherapy, the mass actually becomes a little more fibrotic and excision becomes definitely difficult. So it's not that we are gung-ho about thoracoscopy in all the cases. It is going to be useful in only in small cases where there's no intraspinal extension and where it is clearly away from the major structure. And when in doubt, definitely thoracotomy is a better option because tumor excision and removal is more important. Thank you.
Right. Thank you for that point, sir. Professor Rao I think, is not picking up the call. Anybody else, anybody from the audience wants to make any last minute comments? Professor Basu is also here, sir. Any words from your side?
Well, Nitin, generally want to tell the quality of the papers have been very good. I'm very, very glad that the management, especially in surgical oncology, is going steadily up. And I'm very, very pleased to see the variety of papers from all over. So very, very good sign, I feel.
I totally agree with that, sir. So thank you all.
For asking me. I have enjoyed this session. The quality of papers were very good. I hope some of them come for Journal of Indian Association of Pediatric Surgeons. I was also impressed by the immunotherapy that is used quite regularly for neuroblastoma patients, and that has given better results. So congratulations to all the presenters.
Yeah, thank you for your encouraging words, sir. Dr. Partha, sir, any comments from your side?
Yeah, Nathan, you conducted the session very well, right on time, it seems, and it generated a lot of interest, questions, a little bit controversy, which is good for the betterment of the session as also the faculty. I think it is very good session, and I congratulate all the presenters. Thank you.
Thank you for your encouragement, sir. So we'll end this session. Thank you to Dr. Velumurugan, Dr. Archana Puri, and Dr. Sailesh Solanki for judging this session. And thank you to all the presenters for working hard and making this session a success. Thank you very much. I would request the judges to score and submit the score sheets. Thank you. We'll move on to the next session, which is on systematic review. And it is quite interesting. Since the last two conferences, we've been having this systematic review, two or maybe the last one, I'm not very sure. So the quality of papers, Professor Rao, sir, good afternoon, sir. So can you unmute yourself, sir?
Yeah, good afternoon, Nitin. How are you?
Good, sir. Thank you, sir.
Yeah.
Any comments and any suggestions from your side, sir?
No, they were very good papers. There's no doubt about it. The only thing is, I was just wondering what has changed from when I was in service 4 years back. I didn't understand. Okay, thank you. Go ahead.
Thank you, sir. Thank you, sir. So we have a lot of encouraging word from senior teachers in the session. The systematic review session is something which is very, very close to the heart of researchers, and this shows the quality of research which is increasing in pediatric surgery. So we're very happy to have this session. The judges for this session are Professor A.K. Basu, who is also the editor-in-chief of the JIAPS. Welcome, sir. Good afternoon. And we have Professor Ramesh Babu from Chennai, who's also one of the judges. Thank you for joining in, sir. So this is a 4+2 session. So I would request the presenters to stick to time so we can have a minute or two for discussion. And a lot of papers from All India Institutes, a lot of competition in-house over there. The first presenter is Dr. Kritika. So, and she's talking about systematic review on anogenital distance in male urogenital malformations. Kritika, please share your screen and go ahead with your presentation.
Is my screen visible, sir?
Yeah.
Good afternoon, everybody. Greetings from AIIMS, New Delhi. Today, I'm going to be presenting a paper on systematic review of anogenital distance in male urogenital anomalies. I have nothing to disclose. Anogenital distance is measured by distance between the midpoint of anus to the posterior base of the scrotum in males and to the posterior end of foresheet in females. It is a sexually dimorphic measure, that is, it is longer in male children. Anogenital distance is usually expresses the exposure to androgens during the prenatal period, especially during 8 to 14 weeks of gestation, which is termed as the male programming window. The aim of our study was to study the association between anogenital distance and testicular dysgenesis syndrome. As these articles have been published recently, we aim to systematically review these articles and to quantitatively synthesize the results. By following PRISMA guidelines, we reviewed the articles published in PubMed, Embase, Web of Science and Scopus from January 2000 to July 2021. The inclusion criteria for the studies were those which were focused on infants and boys, and those studies which studied on the relation between anogenital distance and testicular dysgenesis, and those which reported the standardized mean difference and 95% confidence intervals. Reviews, meta-analysis, editorials, case series, and ecology reports were excluded from our study. 84 potentially relevant articles were identified and screened, out of which 43 were excluded after removing duplicates, and 25 were excluded after removing reviews in animal studies. And out of the rest of the 16, 6 were excluded because specific value of anogenital distance was not mentioned. And a total of 10 studies were included in the systematic review. The statistical analysis was carried out by chi-square test and I-square test to evaluate the heterogeneity across the studies. Eggers test and Beck's test were used to evaluate for the publication bias, and the analysis was carried out by Stata version 12 software. These were all the studies which were reviewed, and as we can see in all of the studies, the anogenital distance was significantly decreased in cases of testicular dysgenesis, that is in hypospadias, cryptorchidism,
testicular microlithiasis, and testicular cancer patients. All of the studies were qualitatively analyzed under the following subheadings, that is sample size, ascertainment of exposure, comparability, adequacy of follow-up, and assessment of outcome. And all of the studies were rated from 0 to 10 based on the risk of bias, and studies with a higher value of risk of bias, higher value are supposed to have lesser risk of bias. That a study conducted by Thankmani et al. Had least risk of bias, and that by Gilboa et al. Had a higher risk of bias. This is a forest plot for hypospadias to follow the studies. As we can see, the results are statistically significant in all the cases except for the study conducted by Thankmani et al., in which the confidence intervals are crossing the line of no effect. But the overall pooled result is statistically significant. It is not crossing the line of no effect. And we can go on to say that anogenital distance is decreased in patients with hypospadias compared to the normal healthy children. Similarly, for cryptorchidism also, there were only 2 studies which were individually statistically significant, but the overall pooled result was again significant, stating that anogenital distance is decreased in children with cryptorchidism. The limitation of our study was that the data was highly heterogeneous and the study designs were not consistent. And hence, even though the anogenital distance is significantly shorter, we should evaluate these outcomes with caution. And I would like to conclude by saying that anogenital distance is a simple measurement, but it has paramount importance in the prenatal diagnosis of testicular dysgenesis. And it is important in giving prenatal counseling to the future parents. And hence, further well-conducted studies have to be done to arrive at definitive conclusions. Thank you.
Thank you, Dr. Kritika. So questions and comments from Professor Basu, sir?
Has she finished on time?
Yes, sir, she's finished on time. Just in the
time. Nitin?
Sir, yes, sir?
You are keeping the time.
I'm keeping the time, yes, sir.
Thank you very much, Nitin. Kritika, what is the purpose of your study and how is it going to help management of patients of testicular dysgenesis or patients of hypospadias?
Sir, as in, like, these are patients for which we can anogenital distance is a measure which can be measured in the antenatal period itself by using ultrasound. So with the help of this measure, we can go for diagnosis of testicular dysgenesis in the antenatal period, which will help us in proper prenatal counseling.
There are 3-4 types of systematic review papers. In which category you put your paper into? Because you have done your own study and you have reviewed the literature. So in which category you will place your paper into? Okay, thank you.
Thank you, sir.
One question. Yeah.
Yes.
Can you hear me, Kirtika?
Yes.
Yeah. Yeah. So in children with hypospadias, sometimes they have penoscrotal transposition or bifid scrotum. So in such patient, the distance is going to be difficult to measure, right?
Yes, sir.
And also in the patients with the DSD, particularly, this anogenital distance is of big value because the more they become feminized, the anogenital become distance different. So when you look at these articles, did you try to segregate them into, like simple hypospadias and then DSD type hypospadias, the bifid scrotums? I mean, did you differentiate whether they have given those data? I mean, your systematic review is valid depending upon the data you've got. So have you filtered your data? That's what I want.
No, so they haven't mentioned if it was bifid scrotum or DSD or not.
Thank you.
Thank you, Dr. Kritika. So just one question. Your title of the slide said that, are we going to help in the healing? The last part of your title was there. So how have you answered that aspect in your systematic review?
Sir, mine was anogenital distance and urogenital malformations. Nothing about healing. I didn't get your question.
Okay, I'm sorry. Okay, I mistook your this thing for some other thing. No, nothing, no problems. Okay, so any other questions, sir? Should we go on to the next speaker? Right. So the next speaker is Dr. Jagdish from All India Institute. Dr. Jagdish, yes, please share your screen.
Yes, sir. One.
So is my screen?
It's not yet. We can see you, but your screen is
Sir,
not
is my
visible.
screen visible?
Now it's visible, yes.
Yes. Good afternoon, respected faculty members, seniors, and my dear friends. Warm greetings from the Department of Pediatric Surgery, All India Institute of Medical Sciences, New Delhi. Today, I am going to speak about zipper injuries, clinical characteristics, and management. There is nothing to declare. Entrapment of penile skin and more commonly the prepuce within the zipper is a common cause of penile injury. Some describe it as the most common cause of penile injury in children, and others describe crush injury due to toilet seat as the most common. Multiple methods of extraction has been described. So we aim to systematically review the literature to summarize the varied clinical characteristics, age at presentation, and management. So a PubMed search was carried out with the terms zip injury, zipper injury, and zipper injuries on 19th of May. 719 articles were hit by search. 2 independent reviewers selected the articles. Duplicate articles and non-penile injury articles were excluded. 25 articles were chosen for inclusion from the 698 abstracts available as they were relevant to the topic. Of these, only 14 with details of number of cases, age of cases, and method used were filtered. 2 relevant articles from cross-references were also included. So a total of 16 full-text articles were thus finally included in the study. This is the Prisma flowchart which I have recently described. The results included a total of 68 children, which included a large series of 35 cases and 1 girl child. Six years. Case reports also included 5 adults, of which 2 were greater than 60 years. Mechanism was mentioned in 10 cases, 8 while fastening and 2 while unfastening the zip. In 41 cases, it was removed without sedation, in 12 cases under anesthesia, and in 20 it was not mentioned. All cases mentioned method of extraction, of which in 36 cases it was removed by moving zipper tooth by tooth. In 7, bone cutter was used to cut the median bar, and in 2 cases documented the use of mineral oil. 28 cases other methods were used, which included screwdrivers, cutting pliers, of the entrapped foreskin or emergency circumcision has been described. There were no complications described except for 1 case where swelling was noted, which was documented due to lignocaine injection. The picture on the top left corner, we can see the outer faceplate, which is also called the anterior faceplate, and the inner faceplate, which is also called a posterior faceplate, which is connected by the median bar, also called the diamond. Picture on the right shows the use of bone cutter to hold the median bar and later dismantling it into 2 pieces. Here, picture on the top left shows the use of bone cutter to cut the teeth of the zipper. Picture on the right shows the use of a screwdriver, which is inserted between the 2 face plates, and it should be rotated towards the median bar so as to release the entrapped skin. The picture on the lower left shows the use of pliers, where it is compressed from side to side so as to release the entrapped preputial skin. Other method describe the use of mosquito, which is inserted between the 2 face plates and separating it. So in conclusion, zipper injuries are common but infrequently reported. Median age in children is 6 years. Most injuries occur while fastening the zip hastily. Most zippers can be removed without anesthesia. Appropriate method should be planned without hurting the children, and preferred method is moving the zip tooth by tooth. Thank you.
Yeah, thank you, Dr. Jagdish. You finished well in time, around 20 seconds before. So I'll request the honorable judges for questions and comments. Professor Basu, sir.
Yes, a very nice presentation. And a very, very disturbing disease for a child. Could you please let us know what happened to the prepuce after the zipper was forced open with or without anesthesia? What happened to the prepuce? What did you do to the prepuce? What would you do to the prepuce?
Sir, this was not a case which we have seen actually. Sir, it was a systematic review.
And
in the various articles, it was published that in majority of the cases, patients were discharged immediately and follow up under OPD, and no complications were noted. Sir.
So, no circumcision was necessary. These patients.
For 1 case, it was described, sir. Only for 1 patient. That too, he presented very late after multiple attempts.
Thank you very much.
Can I ask a question? See, when
Yes,
you do systematic reviews, you generally do it for a topic which is so rare. You know, one condition which is so rare, like bilateral Wilms tumor, which you probably see only once in 2 years. So you do not have huge series on that. So you want to look at it. So what made you look into zipper injuries, and what aspect of the zipper injury you were interested in looking at it?
The zipper injuries is, as we feel, it's not a very commonly documented or encountered cases. So we just wanted to see which is the most common age of presentation, like what is the most common mechanism, whether while fastening or unfastening it, and is there any proper described method which is successful when compared to the other methods.
Right, thank you.
Thank you, sir, for that question. So I would say, Jagdish, that it is quite a common problem, and it is dealt by maybe not people in institutes, and it is dealt by the local pediatrician and the local surgeons and the local pediatric surgeons, maybe not even the local pediatric surgeons. They go to a general surgeon who is the nearest person. So points well taken what Professor Ramesh Babu had discussed. So we'll go on to the next presenter. Dr. Apurv, could you please share your presentation? Yes, please make it full screen. Yeah.
Is it visible, sir?
Visible, and you're clearly audible. Please start your presentation.
Respected chairperson, session judges, seniors, and my dear colleagues. From the Department of Pediatric Surgery at AIIMS New Delhi, I will be presenting a meta-analysis highlighting the usefulness of tissue sealants in hypospadias surgery. This article was accepted for publication in JP Urology for post-abstract submission. Hypospadias is one of the most common congenital anomalies in male newborns. Despite the literature describing numerous surgical procedures, the repair of hypospadias remains a challenge. It is a well-known fact that the number of proportion requires multiple surgeries for a successful repair of this anomaly. This acts not only as a source of financial burden to the family, but also have long-term social and psychosexual implications on the patient. Therefore, every attempt must be made to reduce the multiple surgeries in these patients. Tissue sealants are one such option that has gained significant attention in the recent past. At present, however, there is no consensus on the same. Hence, this meta-analysis aims to compare the outcomes of hypospadia surgery in children with and without tissue sealant applications. The authors systematically searched the databases PubMed, Embase, Web of Science, and Scopus as per the given prisma diagram. The PICO guidelines were applied with participants including hypospadia patients up to 18 years of age. The intervention was use of tissue sealants, and the comparison group was no sealant use. The primary outcome was the proportion of children developing overall complications. The occurrence of given specific complications, including UCF, were assessed as secondary outcome. The meta-analysis was performed using RevMan Stata software. The pool risk ratio was estimated, and I-square statistics was used to estimate the heterogeneity. A random effect model was used wherever the heterogeneity was significant. The methodological quality of the studies was assessed using the Downs and Black scale. After excluding, only 4 studies were included in the meta-analysis. All studies had a moderate risk of bias. Kappa statistics showed a value of 0.96, highlighting an almost perfect agreement among the observers. Different types of tissue sealants were used in the studies. The procedure and site of the sealant application were reported by all of the studies, while only 2 depicted the specific volume of the sealant used. All studies reported the overall complications. As you can see, this is the given forest plot for the overall complications. One study was censored. The box and the whisker plots show that the distribution of the constituent studies with the size of the box denoting the respective weightages. The cumulative result is shown by a diamond, but since it is touching the midline, the result do not show any significant difference between the 2 groups. However, there was a demonstrable improvement in UCF rate and wound-related complications. Similarly, there was also a decrease in complications pertaining to the neourethra. There were, however, no improvement in flap-related complications or metastenosis. There are several limitations to this meta-analysis. Firstly, all the studies had a moderate risk of bias. Secondly, a non-uniform and selective reporting of the complications was observed among these studies. Information of the cost of the sealant and the surgery was also limited. Cosmetic outcomes were reported in only 1 study. Thirdly, a subgroup analysis comparing the efficacy of sealant with the severity of hypospadias could not be performed as there was selective reporting of the same. Also, the surgeries were performed by different surgeons under different settings utilizing different operative techniques. In conclusion, the current meta-analysis revealed no additional benefit of the repair of hypospadias performed with tissue sealants as compared to without sealants in terms of overall postoperative complications. However, a significant reduction was documented in some complications. Since the heterogeneity among these published comparative studies is high, therefore, a well-designed randomized controlled trials need to be conducted for optimal comparison. Thank you.
Thank you, Dr. Apurv. You finished well in time. Questions from honorable judges. Professor Basu, please. Sir, you are muted, sir. Can you unmute yourself, please?
Sorry.
Professor Basu. Yes, sir. Thank you, sir.
Why do you call it a meta-analysis? Very nice presentation. Why do you call it a meta-analysis? Please go slow when you are presenting. You are very fast presenting to finish it. Your presentation is good. Please tell us, why do you call it a meta-analysis?
So it was this was a meta-analysis because there was a quantitative synthesis of the result. We had quantitative studies which had two groups which could be compared with quantitative data, and a conclusion could be drawn regarding the same.
But he did not give any statistical data.
Sir, statistical data, sir, we had given this means.
So instead of calling it a meta-analysis, it is better that you call it a systemic review. It's not a meta-analysis. In meta-analysis, you pick up similar papers, compile the results, then do a statistical analysis, and then you publish your result, and that is a meta-analysis. So this is a systematic review. Okay.
Okay, sir.
May I ask a question? How many papers were there finally included in that plot you have shown, and what was the total number of patients were included?
So the total number of papers that were included were 4 and two were RCTs and 2 were prospective cohort studies, and the total number of subjects after compiling was 646.
Okay, and you compared the sealant and non-sealant and done a risk ratio. So are they within the same paper, same study? In the same study, they have used
all studies had
non-sealant.
Yes.
And where was the sealant used? Was it on the skin after the closure, or was it in the subcutaneous tissue on the urethroplasty, or where was it used?
Sir, all the studies had at least used it on the suture line. A few of the studies, one by Gopal et al., had used it as a second layer above the dartos as well. But all the studies had used it as a strengthening layer above these suture lines, sir. On
no, I'm asking specific question. Under the skin or over the skin?
Sir, over the skin, sir. After closure of the neomatous, after clearing of the neomatous, the sealant was applied over it.
No. See, there is a urethroplasty suture line. Did they apply the sealant over the suture line, or they were just using like a cyanoacrylate like glue, like what we do for lab closures, on the skin? After lab coats, we use it on the skin. So did they use it on the skin only, or they used it on the urethra also?
Sir, on the urethral suture line, sir.
So they used under in the soft tissue?
Yes, sir. In the soft tissue.
And these sealants, are they like soft tissue sealants? I mean, were they specific for skin use? Because my feeling is that is the sealant which we use for laparoscopic port closures are skin sealants, right?
Yes, sir. Tissel is a skin sealant, sir.
Correct. They are not soft tissue. Anyway, Dr. Basu has got another question. Thank you.
Yeah, you have got into a trap. See, you cannot use these sealants unless the surface is completely dry. And on your urethral closure stitches, it is a wet surface. You cannot use the sealants there. So you have got yourself into a trap. Either you put it on a dry skin, or you cannot use it on a wet surface. So you have really not taken notice of where the sealant was put, whether on the urethral stitches or on the skin stitches. Okay?
So they had actually documented of all the papers. They had specifically used it on the urethral skin only, sir.
Okay.
Congratulations on getting it accepted in JPU.
Thank you, sir.
So, Apurv, I'll just ask a quick question. You said that your
Yes,
research question was asked using the PICO methodology, right?
Yes, sir.
So, do you know what is the spider methodology?
So I have to check up on that.
So that is what both the senior judges were probably asking. You could have used a more extensive methodology to include papers which were better elucidating your research question. So, okay, thank you for your presentation, Apurv. The next presenter is Dr. Nilay. And Dr. Nilay, please share your screen.
Yes, sir. Greetings from the All India Institute of Medical Sciences. I'll be presenting a systematic review meta-analysis on the portosystemic shunts in extrahepatic portal venous obstruction. I have nothing to disclose. Extrahepatic portal venous obstruction is the most common cause of long-standing portal hypertension in children. So Mesorex bypass, a physiological shunt, is a technique of choice today, whereas portosystemic shunt is indicated if Rex shunt is not possible. However, there is no wide agreement on the feasibility, indication, timing, and success of the various portosystemic shunt procedures. So aim was to conduct a systematic review meta-analysis to determine the optimal portosystemic shunt procedure in children with extrahepatic portal vein obstruction. We sourced the data from the various search engines using the search string as shown, and snowballing and reverse snowballing was also conducted to identify all search results. So all children less than 18 years of age with extrahepatic portal venous obstruction in whom the portosystemic shunt procedures were done was included, and the comparison was done using selective shunt procedures versus non-selective portosystemic shunt procedures. And the outcomes compared were the shunt patency rates and the persistence of symptoms post-surgery. We excluded the patients in whom the Rex shunt procedures or the devascularization procedures or the second shunt procedures were done. So data from the included studies were synthesized by 2 authors. And along with this, we also did the baseline information of the studies which were recorded. Then the quality assessment was done using the Townsend-Black scale, and the kappa statistics were used to determine the intra-observer consistency for this assessment. We performed the statistical analysis using the Revman software. The risk ratio along with the 95% confidence interval was calculated for the outcome. The Mantel-Hansen method was utilized to calculate the pooled risk ratio, and the p-value and I-squared statistics was calculated. And a random effects model was chosen if the heterogeneity was substantial. P-value of less than 0.05 was considered statistically significant. So this is the Prisma flow diagram. After the initial search result showing 432 results, we included 6 results in the final meta-analysis. So 6 studies were included in the meta-analysis, and all of these were comparative studies. There were no RCTs. Most of the patients presented with varicose bleeding or hypersplenism in both the groups, and the etiology was idiopathic in most of the patients. So this is a forest plot showing the comparison the shunt patency rates between the selective shunt procedures and the non-selective shunt procedures. So on the right, we can see that the various studies are depicted, and the box shows the weightage indicated to each study, whereas the diamond shows a summary of the result, which shows that it is falling on the line of no significant result. So therefore, we concluded that there was no difference in the shunt patency rates between the various studies. But the heterogeneity of the included studies was minimal. Similarly, the rebleeding rates post the shunt surgeries also did not significantly differ between the 2 groups. And the persistence of thrombocytopenia count post-surgeries also did not significantly differ between the 2 groups. Hepatic encephalopathy post the non-selective shunt procedures was not reported in any study. And the post-splenectomy complications were also not reported in the comparative studies. All the included studies had a moderate risk of bias, and there was almost perfect agreement between the 2 investigators assessing the risk of bias. The limitations were that there were only few comparative studies, and wide variety of techniques of shunting were used, and the duration of follow-up was variable among the studies. So we like to conclude that the meta-analysis though showed no significant difference in the shunt patency rate and the rebleeding rate between the selective and the non-selective shunt procedures. However, the selective shunt procedures give the advantage that this avoids the complications of splenectomy and maintains hepatopetal flow. So therefore, even though there is no significant difference, so in order to avoid this complication, selective shunt procedures may be preferred. Thank you.
Thank you, Nilay. You've completed well in time. Questions from the judges. Professor Basu, sir.
Asking the question. If I understand correct, between selective and non-selective shunts, the incidence of patency is not something which is of great importance. but it is the incidence of metabolic problems and encephalopathy is the thing, right? But you have looked at patency. I mean, you think that patency will be different between the groups, or do you expect it to be different?
So usually in the selection procedure, for example, the Dean Warren shunt procedure, sometimes because the length of the shunt or the width of the splenic vein may not be adequate. So because of this, there may be a change in the patency.
No, but being selective or non-selective is something to do with the metabolic advantage rather than the mechanical advantage, right?
Yes, sir.
Basu, sir. Thank you.
Sir, you are muted, Professor Basu. Please unmute yourself. Professor Basu, sir?
I'm
Yes, sir.
hesitant to ask any question in presence of Professor K. Rao, who is an expert, world expert on shunt procedure. So I will first request Professor Rao to ask any question or give his comment.
Yeah, I think it's a good attempt to, study all right. I think he has quoted one of my papers somewhere in 2004 paper, I think. I think basically, more or less the entire world has given up that so-called selective shunts, because there are empty number of studies now saying that selective shunts are no longer selective. Okay. The question is whether you have been able to reduce the portal pressure adequately or not. Okay. And my strong conviction is that if there's an enlarged spleen and you try to do a selective shunt or do any other shunts without doing splenectomy, it will never work. I have inherited good number of patients and I had to do all of them over the next number of years, go ahead and do a second operation of splenectomy, even in the presence of a patent shunt. Okay, otherwise it's a good study, a lockdown study of meta-analysis or whatever. Thank you.
Thank you, sir, for your...
Thank you, Dr. Rao, Professor Rao.
Thank you.
Very good comment. We have read many of your papers.
Yeah, I know.
And, see, there are two things. One is that if you are doing a selective shunt, the one that was practiced by a person before Professor Rao came in, is a side-to-side anastomosis.
Yeah.
Without ligating the proximal end of the splenic vein.
Yeah.
So that will keep some amount of circulation toward the spleen patent. But if you divide the proximal end of the splenic vein, it becomes a Warren shunt anyway.
Yeah.
Our problem is not only a big spleen, but also hypersplenism. So both the things together, we have to remove the spleen.
Yes.
And the third thing is, there may be less incidence of encephalopathy at the beginning. But if you follow up these patients over decades, you will find loss of weight, you will find there is some neurological deficit coming in, creeping in. So we have patients who have followed up for a long time. They do not do well in the school. So we have to be a little vigilant about it. But it was a very good paper. Thank you very much.
Thank you, honorable judges, for that wonderful discussion. The next presenter is Kashish from All India Institute. Dr. Kashish, please share your screen.
Good afternoon, sir.
We can't see your slideshow. Please make it full screen.
Right, sir.
Yeah,
Can I start, please?
Yes, please, Dr. Kashish.
Good afternoon. Greetings from the All India Institute of Medical Sciences. I have no disclosures. Clinicians, they love to read case reports because they tell us a good story. And who doesn't like to read a good story? They are relevant to our day-to-day practice, and by implication, they are interesting and informative. Yet case reports, they are considered weak evidence in the hierarchy of the research evidence. Case reports are probably the most primitive modes of sharing and disseminating medical facts and information. With the increasing importance ascribed to original articles, by the impact of the impact factor, case reports have now taken a back seat. In fact, a lot of the journals, they have now stopped publishing case reports. At the same time, considering that they are easy to publish, As compared to the original articles, the abandonment of case reports by the standard journals have created a fertile ground for the predatory journals who even charge us money for the same. Having said this, the importance of case report in pediatric surgery is unique because pediatric surgery addresses multiple malformations which are relatively rare, like the conjoined twins, aphalia, penile duplication, penile tourniquet syndrome, as we saw. And pediatric surgery also addresses a lot of variations in the presentations of problems, which may more common per se be, like extrapulmonary form of the pleuropulmonary blastoma. Besides, they are generally the first form of publication for students like us. The importance of case reports was realized, and so was the importance of standardizing the format. Hence, every journal which accepts case reports gives us certain guidelines. Like these are the guidelines from the Journal of Indian Association of Pediatric Surgeons for case reports. Subsequently came the care guidelines. This is a detailed checklist of the care guidelines. However, they were treating both the medical and the surgical cases at the same platform. And soon the surgeons realized that they had to form their own checklist. This came up with the SCARE guidelines in 2016, which was further updated in 2018 and 2020. One of our faculty was also part of this process. These guidelines have been made mandatory by several international journals, including the International Journal of Surgical Case Reports. For example, taking the title, it specifies that the word case report should appear in the title, and the title should also describe the area of focus, like the presentation, diagnosis, surgical technique, or the device or outcome. Similarly, for each of the subheading in the case report, they have specified what all should be included. Now, in the era of evidence synthesis, case reports may be the only type of publication for such topics like trichobazar, Milkert syndrome, penile duplication, penile tourniquet syndrome, choledochal cyst, etc. However, incorporation of such cases into systematic reviews or the statistical bucket of meta-analysis, it requires a certain level of uniformity. Problems arise when we have 4 cases of type 6 choledochal cyst being reported of the same case. The pediatric surgeon will like to talk about the surgical aspect. The radiologist may just discuss the CT or the MRI of the report and not the other details. One report may be collectively by the pediatric surgeon,
Just 20 seconds left.
And so there can be duplicacy of report. Similarly, reporting this case of conjoined twins by different specialities may have different focus. So hence the parameters considered important for reporting them may not be uniform. So case reports are important part of literature, and with the rising importance of systematic reviews, it is imperative as the stakeholders of the Journal of Indian Association of Pediatric Surgeons, we the pediatric surgeons across the country should join hands and form guidelines for reporting such cases. Thank you.
Thank you, Dr. Kashish. An interesting talk. You overstepped your time by around 20 seconds. So, Professor Basu, sir. Sir, please unmute yourself, sir.
Time. Case reports are very important means for young pediatric surgeons to remain in the academic circle. It is true. Right. But the better thing to do will be that you do collect your cases, make an Excel sheet in which you keep all the records of your patients, make an Excel sheet number place where you will mention the number of the folders in which you will have the photographs, and then maintain your own records from the beginning. And while you are doing all this hard work, you can also fall back on the cases of your own department or own teacher, own boss. Try and write up from those materials your own long papers of the original papers so that they are accepted by the journals more easily. Yes, short paper is a very good means to survive in the academic circle, very good means to actually show to people a very interesting thing happening. But I think the way to go ahead is to keep your own records and also fall back on the records of your teacher and build something on it. That will be my suggestion. Thank you very much. Nice paper.
Thank you so much, sir. In fact, just to highlight this point, when I was a resident at AIIMS, the first case of dicephalic paraphagus conjoined twins I got to see. And that is when, as you are saying, make a proper Excel sheet. I made an Excel sheet which had 36 columns in it. And that was my first paper as a resident. And I didn't know whether I'm going to see a case of conjoined twins again in my career or not. Speaking of it, just the last year, I had the opportunity to see 2 pyophagus conjoined twins being separated. And so the first exercise seemed futile, but it helped me when I got to see the other cases of conjoined twins, even though it's such a rare case that maybe it's a once in a lifetime case. So thank you so much for your suggestion, sir.
It will add on, don't worry, it will add on.
Professor Ramesh, sir?
No, thank you. We will move on.
Thank you, sir. Thank you. So the next presenter is Dr. Dhruv from All India Institute. Dhruv, please make your presentation in full screen.
Yes, sir. Am I audible, sir?
You're audible.
Okay, sir.
But your presentation is not in full screen as yet.
Okay, sir. So can I start, sir?
Yes, please. Please go ahead.
Okay. Good afternoon, everyone. Warm greetings from AIIMS New Delhi. I'll be presenting a systematic review on the role of procalcitonin in pediatric surgery. I have nothing to disclose. Procalcitonin has caught the fancy of the whole medical fraternity in the last decade. The adult physicians have embraced this marker in clinical practice. In the future, its use in clinical practice otherwise is also inevitable. As we all understand, it is an acute phase reactant, which increases in both infectious as well as inflammatory insults such as surgery. Surgery as a confounding factor casts a doubt to the efficacy of procalcitonin to pick up any infection, sepsis, or complication in the postoperative period. Very few studies give contrasting perioperative trends of procalcitonin. The role of procalcitonin can only be established if the expected trend in the perioperative period is known. Thus, we conducted a study to investigate the normal expected trends of procalcitonin post non-cardiac pediatric surgery. Studies in which both preoperative and postoperative procalcitonin levels were assessed in children aged less than 18 years who underwent non-cardiac surgery were included in the review. After an extensive database research using PRISMA guidelines, 4 studies were included in the study. The study cohort comprised of 122 patients with a male preponderance, with a wide age variation ranging from 1 day to 16 years, with 46% of the patients being less than 1 year of age. 54% of the patients were the one who underwent liver transplant for liver failure. The rest 46% of the infants underwent surgery for thoracic, gastrointestinal, or CNS abnormality. In the first study, there was a rise in serum procalcitonin level on postoperative day 1 from the baseline values and reached peak on the postoperative day 1 itself. And subsequently, procalcitonin levels decreased to approach baseline by postoperative day 7. In another study on liver transplant patients, a similar peak in procalcitonin was seen on postoperative day 1. The patient cohort was subcategorized into 2 categories from postoperative day 2. One was the non-sepsis group, which showed a gradual decline to normal values by postoperative day 7, whereas the other was the sepsis group, which showed a rise in procalcitonin on subsequent days. In a study on neonates and infants with substratification of patients into systemic inflammatory response syndrome group, sepsis group, and normal group, a similar peak on postoperative day 1 was observed, followed by a mild decline on postoperative day 2. However, there was a significant difference between those patients who fell into sepsis group vis-a-vis those with no sepsis. No such difference was present before surgery. In the 4th study, only mild increase in procalcitonin was noted post-surgery on postoperative day 1, followed by a decline to baseline values by postoperative day 2. Thus, procalcitonin we can conclude that it is an inflammatory biomarker which has been used in early detection of sepsis and has been used in antibiotic stewardship. The literature reviewed by us showed that in children undergoing non-cardiac and non-liver transplant surgery, the levels start declining after a peak on postoperative day 1, and generally after non-cardiac and non-liver transplant surgery reach baseline values by approximately postoperative day 3. Any variation from the normal trend should be interpreted with caution. A large study based on these findings could form the basis of its use for prognostication, guiding therapy, and even management in future. Thank you.
Thank you, Dhruv. You finished on time, well within time. Professor Basu, sir, your comments and questions on this paper? So please unmute yourself, Professor Basu.
Sorry. Dhruv, very nice presentation.
Thank you, sir.
Could you please tell us, did you compare the CRP level and the procalcitonin level in two patients, the categories of patients?
No, sir, in this analysis we did not, but we are conducted a separate study to see the trends of procalcitonin and CRP levels in neonates in our institute, sir. In that, we'll further study this comparison, sir.
Shubh, do you know the cost of one procalcitonin examination in the outside and a CRP estimation?
Sir, generally in private practice, the procalcitonin tests cost around 1,500 to 2,000 rupees a single test, and CRP cost around 400 rupees. But the point is that these are still upcoming biomarkers. In the future, these when it is a standard practice in different institutes, then probably the cost is likely to come down when it becomes a standard among all labs.
Do you think if you do a long prospective randomized study of the estimation of CRP and procalcitonin in similar groups of patients, it is only then you can draw a conclusion on the utility of procalcitonin and CRP?
Certainly, sir. This is just a pilot study, and the literature which we have available is of small numbers only, comprising of only 20-30 patients individually. That is why we conducted a systematic review on this topic, sir. And for procalcitonin to attain widespread utility, larger studies certainly required, sir. And its use cannot replace clinical judgment. That has just, it can be used only as a collaborative marker to guide our clinical judgment and management. And the one thing which can be used is that it can be used for prognostication, sir, as it has been used in adult ICUs when baseline procalcitonin values can give us an objective parameter as to the prognostication of the child, of the patient.
Just tell me one condition in which you will heavily depend on procalcitonin for your further management. One condition.
Sir, in pediatric surgery, sir?
Yeah.
Sir, it can be used even.
Sorry for
its use has been
interrupting.
defined in appendicitis as well.
Okay, sorry, forget it.
Okay, so Professor Ramesh Babu, if you have any questions, could you type it in the chat box? We'll move on to the next paper. So, Nilay, just start your presentation.
Yes, is my screen visible, sir?
Yes, visible, and you're clearly audible. Please go ahead.
Greetings, once again, greetings from the All India Institute of Medical Sciences, New Delhi. I'll be presenting a qualitative systematic review on the application of three-dimensional printing for preoperative assessment of children with extracranial solid tumors. I have nothing to disclose. So high-quality imaging modalities such as computed tomography or magnetic resonance imaging are the basis of diagnostic imaging and assessment of resectability in solid tumors. But both these investigations provide a two-dimensional view. Three-dimensional reconstruction visualization, though available nowadays, but these are also seen from a two-dimensional screen. So therefore, for safe and complete surgical resection of a tumor, three-dimensional printed models provide a 360-degree view of the tumor and the adjoining areas. And they also provide a sense of touch to the surgeons for better comprehension of anatomy. So the aim of this qualitative systematic review was to generate a comprehensive source of information on the role of three-dimensional printing in pediatric extracranial solid tumors. So we did the searching in the search engines of PubMed, Central, Ovid, and Cochrane, and others. Snowballing and reverse snowballing was done. All patients less than 18 years with extracranial solid tumors in whom three-dimensional printing and 3D models and simulators were used, were included in the study. And the comparison was those in which these models were not used. The outcomes evaluated by the role of three-dimensional printing in preoperative planning, training, and counseling of the parents. We excluded the tumors in which the dental or orthopedic tumors were being evaluated. The methodological quality assessment of the included case reports and case series was performed by utilizing a tool proposed in 2018, as shown in here. And this systematic review was also registered in the Prospero. So this is a Prisma flow diagram in which after the initial search result of 68 studies, we included the final 8 studies in the qualitative synthesis. So in among the 8 studies, 3D printing was used in 30 children in total with extracranial solid tumors. And these include most commonly the Wilms tumor, neuroblastoma, hepatic tumors, and retroperitoneal tumor and synovial sarcomas also. And these studies reported that the 3-dimensional printing was helpful for preoperative surgical planning, improved understanding of the surgical anatomy of the solid organs, improving the parental understanding of the tumor and thereby helping in that counseling. Also, 3D reconstruction from the CT or MRI was performed, or either combination of these were used in few cases. However, the studies reported variety of printing materials such as resin or plastic derived materials. Also, the type of 3D printers used was variable. However, only 2 studies reported the cost and the time involved in printing these 3D models. And these studies from US, they reported the cost to be around $400 to $500 and the time involved to be 10 hours to 4 to 5 days. So the technology of 3D printing is gaining immense popularity among the various surgical specialties. And this helps in the better understanding of the surgical anatomy and the subsequent surgical planning. The anatomic representation is much more simpler using these models. These models are also portable objects. They provide a sense of touch and they can be sterilized and taken to the operating room for intraoperative assistance. They're also a great source for the teaching and medical education, as well as for the source of parental education. However, the limitations are, there is a limited availability of such facilities everywhere. The cost is a limiting
Last
factor.
30 seconds.
Time consuming, and the reproducibility of the actual tissue characteristics. Sometimes they also fail to provide the real-time scenarios. For example, there may be post-chemotherapy adhesions, bleeding, which are not fully represented. So I'd like to conclude that 3D printing is useful in the extracranial solid tumors, and they can help in the surgical resections. Thank you.
Thank you, Dr. Krishnan. You've completed just in time. So questions and comments from our judges. Professor Basu, sir.
Yes, I have very little experience of 3D printing, but do they give you any impression about the smaller or aberrant vessels in a tumor from a 3D printing?
Yes, sir. We can from from using the image guidance in the software, you can tell, we can actually describe what all things we want to print. So if we print that region of interest along with it, we get the regional vessel anatomy also along with the 3D printed models. Sir.
What imaging material do you use for?
Either CT or MRI or both in some cases.
And depending on the rest of the thing.
Pardon, sir?
And the computer does the rest of the thing.
Yes, the computer does. But one thing is, even though we know the vessel anatomy, but the intraoperative will not know how firm or how rigid or how friable those things are. So those things will not be available in 3D printed model because the material used is a resin or a plastic derived materials in such cases.
Thank you.
Thank you, sir. Professor Ramesh Babu, sir.
In your systematic review, you were looking at the feasibility of the technique alone, or were you looking at real clinical benefits over simple methods like a 3D reconstruction on a CT scan? You know, we still get the same information by a 3D reconstruction on a CT or MRI. So did you actually look at the benefit, or just looked at, whether it is possible to do? I mean, we all know it's possible to do.
So we did not actually compare it with the 3D simulations using the CT, but these models actually provide that feeling of touch, and we can practice simulations in this, which may not be. And also even though 3D printed 3D visualization of the rendering of CT is available, but these are also visualized from a 2-dimensional screen, so they may not be actually getting the. We'll suggest may not get full idea of the anatomy.
Dr. Krishnan, where would you, what level of evidence would you give to a qualitative systematic review?
Sir, in this case, the case reports and case series are only used. So therefore, the level of evidence is level 5. So that is the lowest evidence in this.
Okay, thank you. Thank you. We'll move on to the next presenter. This is Dr. Shreyas from All India Institute at Jodhpur. Dr. Shreyas, please start your presentation.
Good afternoon, one and all. I am Dr. Shreyas, and I am presenting my systematic review on etiology, diagnosis, and management of acquired tracheoesophageal fistula in children. As we all know, acquired tracheoesophageal fistula is a rare pediatric surgical entity, and it is challenging in terms of early diagnosis, management, and prevention of fatal pulmonary adversities. So the aim of our study was to analyze the various etiologies, diagnostic tools, management, and outcomes in acquired TEF in children through a systematic review. We conducted a systematic search through PubMed, Scopus, Google Scholar, and Embase databases through mesh terms of pediatric or children and acquired tracheoesophageal fistula. All publications, including the case series and case reports, were included, which mentioned acquired tracheoesophageal fistula, and standard exclusion criteria for any review were met. Out of the 339 articles we could gather from database search and 39 articles through other sources, by following the PRISMA guidelines, we narrowed it down to 77 articles, which were included in the qualitative synthesis. The total number of cases included were 119. The median age of presentation was 23 months, and the male to female ratio was 5:4. The most common presenting complaints were cough and dysphagia and drooling. And when we analyzed the etiology, foreign body ingestion was found to be the most common cause at 77%, followed by the iatrogenic causes. And amongst the iatrogenic causes, the most common cause was following the congenital TEF repair, followed by tracheostomy. And in foreign body ingestion, button battery ingestion caused a significant amount of causes. When we correlated the age to the cause of acquired TEF, we found that foreign body ingestion had clustered between 12 to 60 months of age group, and iatrogenic causes were seen mostly in the infantile group. Chest X-ray was the initial investigation in most of these patients, and the definitive investigations were bronchoscopy and contrast esophagogram. Bronchoscopy was subsequently done in most of the cases. Vertebral levels, when we see in 69 reported cases, it was between C6 to T5 and T4 in 26% of the cases. And size of the fistula reported in 49 cases, we found 38% of the cases had the size between 1 to 2 centimeters. Diversion procedures, out of the diversion procedures, 45% of the diversions were of gastrostomy, followed by a combination of gastrostomy and cervical esophagostomy in all the cases. Treatment modalities were mainly single-stage repair, followed by the stage surgical and spontaneous healing. 20 cases were repaired spontaneously, of which the average duration of wait was 2 months, and the success rate was 75%. Complications were esophageal stricture or stenosis and tracheomalacia, and we compared the spontaneous healing with the size of the fistula. We found that up to 2 centimeters, the success rate was up to 100%. Primary repairs mostly was done through right thoracotomy approach in 42% of the cases and cervical in 35% based on the level of the fistula. And soft tissue interpositions were reported in 35 cases, of which the strap muscles and the intercostal muscles were mostly used. Complications were again esophageal stricture stenosis and recurrent fistulas. Stage repairs were done in 18 cases, of which colonic interposition was done most commonly in 32% of the cases. And the complications again here were either esophageal stricture stenosis and recurrence at equal incidence. So when we analyzed these complications with the size of the fistula, we found that up to 1 centimeter of the size, the complication rates were significantly low, and this difference was statistically significant. And also, when we compared the complications between primary and secondary repair, the difference was not statistically significant and they were comparable. Mortality was reported in 9% of the cases. So to summarize, acquired TEF is
40 seconds.
It's an undesirable outcome of the desire of the children for the ingestion of foreign bodies. Cough, recurrent URTI, and difficulty in feed should always be evaluated with bronchoscopy and contrast esophagogram. The size of the fistula is an important factor to decide. When in distress, we should always divert. We should be optimistic if the fistula is subcentimetric and consult. Definitive management needs to be individualized. The complication rates of primary and stage repairs are similar, and follow-up should always be watched for esophageal stricture and stenosis. Thank you.
So Shreyas, you've just finished in time. Thank you for your presentation. So over to the judges. Professor Basu, sir.
Yes, very nice presentation. Thank you very much. You said that 2 centimeter fistula is of significance, and if the fistula is 2 centimeter or more, you need to do something aggressive, otherwise you can go conservative. How do you assess the size of the fistula preoperatively?
Yes, sir. In most of the studies we saw, the size of the fistula was analyzed with the help of bronchoscopy, sir. But in some of the cases, contrast-enhanced CT or HRCT of the thorax could also help us guide the size of the fistula, sir. Although it was underreported in most of the studies.
In bronchoscopy, you get a magnified dimension. How did you measure in a bronchoscopy the size of a fistula in the trachea or the bronchus? It's a magnified view.
Yes, sir. By standard measures and by comparing with the level of the tracheal segments, we can analyze the size of the fistula on bronchoscopy as well.
You measure the tracheal rings.
Approximately through the size of the tracheal rings. Sir.
How many rings will make 2 centimeters?
Sorry, sir.
How many rings of trachea will make 2 centimeters in a, say, 3-year-old child?
Sir, 3 segments, sir.
3 segments?
Yes, sir.
Not 5?
No, sir. I mean, it was not mentioned.
All right. That's all. I raise my case.
Thank you, sir.
We'll go on to next.
Ramesh Babu, sir, anything from your side?
No, move on to next one.
Right. Thank you, sir. So the last speaker for the session here is Dr. Ruchira from BHU. And Dr. Ruchira, please put your presentation in full screen.
Make it slideshow, please.
It's still not slideshow mode.
So I'm not able to see the slideshow button because of the Zoom, all the videos, all the
left upper corner, second button.
left upper corner.
Yeah, this one.
Yes.
A very good afternoon to all. I'll be presenting a systematic review on the epidemiology, management, and outcome of congenital sternal cleft deformity. Sternal cleft is a rare congenital anomaly with an incidence of 1 in 1 lakh live births. We aim to systematically review the literature to summarize and analyze the varied clinical features, management, and outcome of this rare anomaly. A PubMed search was carried out using the term sternal cleft on 26 February 2021. 190 articles were hit by the search. Identification, screening, and eligibility analysis was done by 2 independent reviewers. Articles were identified using PRISMA guidelines. A total of 190 PubMed indexed and 9 non-PubMed indexed articles were screened. 23 articles were identified in languages other than English. 3 articles were on animals. After excluding the non-English articles and animal studies, 173 articles were assessed for eligibility. 12 articles had no clinical description of the patient and were excluded. A total of 161 articles were included. The time period of their publication was from 1965 to 2021. A total of 238 patients were described in 161 articles. The extracted data included the clinical features, management, and outcome. The median age at presentation was 7.5 months. Most patients presented within 3 months of life. Sternal cleft was twice more commonly seen in females. No difference in survival, type of sternal cleft, presence of associated anomalies was seen in both the genders. Among different types, upper sternal cleft was most common, followed by lower and center. Lower clefts had significantly higher associated anomalies, antenatal diagnosis, and use of prosthesis. However, the survival was significantly less. 60% patients had associated anomalies, of which cardiovascular anomalies were most common. VSD was the most common cardiovascular anomaly. The other anomalies were that of skin, pulmonary, airway, chromosomal, renal, body wall defect, gastrointestinal, musculoskeletal, craniofacial, and others. Those with associated anomalies had significantly higher rate of stage surgery, prosthesis use, and significantly lesser survival. 83% of the patients underwent surgery, of which 87% underwent single-stage surgery. Autologous graft was used in 63, prosthetic material in 35, and xenograft in 2. Overall mortality was
11%, and follow-up period, median follow-up period was 1 year.
Last 30 seconds.
There are few limitations of the study. Those with rare associated anomalies are more likely to be reported because of higher chances of publication. Use of different types of processes and xenografts are more likely to be published. Hence, the probability of actually using them may be overestimated. Patients who could not be managed well and did not survive are less likely to be reported. To summarize the important clinical features of this rare anomaly, sternal cleft has a female preponderance. Upper sternal cleft is the most common type. Sternal cleft has high incidence of associated congenital anomalies, and those with associated anomalies had significantly higher mortality. Thank you.
Thank you, Dr. Ruchira. You finished on time. So interesting review and good presentation. Over to Professor Basu, sir.
Ruchira, how many patients did you get of lower sternal defect with all the 5 elements of Cantrell?
Although the number of patients with pentology of Cantrell, sir, just 1 second. 8 patients, sir.
And how many of them survived?
Sir, survival was 3 patients survived, rest all did not survive.
How would you treat the last patient whose photograph you showed us? The full skin cover and the heart pulsating under the skin.
So it's from the one of the articles which we included in our study. If I had to operate this patient, I would first because it is the upper sternal cleft, I would try primary closure first, attempt prime, and the child is small also. The chest wall will be more compliant, and there are less chances of cardiovascular instability in neonates.
Have you studied the long-term follow after 20 years of these patients?
No, sir. And the median follow-up in our study was 1 year. Long-term follow-up we haven't studied.
You have to read up some of the write-ups of Professor Alberto Pina, who used to do a large number of cleft and sternal defects before he started doing anorectal surgeries. So please read them up and find out what happens to these patients in a long-term follow-up. Okay?
Okay, sir. Yes, sir.
Thank you.
Thank you, sir.
Professor Ramesh Babu, sir, your comments.
Is that the last paper?
That's the last paper, sir.
Yeah, I just have some comments, basically, not for Ruchira, but general comments. So, I mean, it's great to see that lockdown has helped us learn to do systematic reviews. And then I applaud AIMS Delhi and Bhubaneswar for starting this, a lot of systematic reviews and meta-analysis. But I also want to tell a point or two for the sake of these youngsters. When the PGs do a thesis, they just do it for the sake of doing a thesis, and that is not the way to do it. I mean, we should have some reason to do, and then some clear-cut aim of doing something. For the sake of doing a systematic review, if you do one, it actually doesn't have much value. So I have got a couple of points, like, there are 3 points basically. You need to ask the right question. Like, are elephants dark or thick-skinned? We know that. And can elephants swim? That's a better question. Can elephants swim better than blue whales? That's even a better question, but we know the answer. And then your systematic reviews and meta-analysis are basically based on what kind of data you are basing it on. I mean, you want to know whether a woolly mammoth can swim. That is an extinct animal, so you can't actually tell. And then whether your study is useful, whether it has got any translational value but what that means is whether there's a change in practice. So like if you ask a question like, where can elephants help you build a house? That's probably a better question. So what question you ask in a systematic review is more important than just collecting some papers and then piling up some data. And then finally, we will reach a stage where the journals will start refusing systematic reviews because, you've spent a lot of time, but still they don't feel there is a value or a value addition from the paper. So that's what I want to say about systematic reviews.
Thank you, sir.
Thank you. I want to just make another point.
Yes, sir.
a systematic review or a meta-analysis we land up doing only when we are faced with a problem. And the problems need to be, the solution need to be identified. And the problems may be, why is this happening? Or I am doing something, I'm not getting good results. Why I am not getting the good results? Or it may be that I am doing something and after a very long time, my patient is getting into trouble. So why I am getting into trouble for such long-term disasters? So for finding out all these, I have my own results and I want to look at the results of the masters in the world. So I collect the articles written by many people, collect all the papers which are similar papers. Diverse papers will not be able to help you in doing a systematic review or a meta-analysis. Collect all the similar results, analyze them, and then only we can get a meta-analysis. And depending on the results of the meta-analysis, I can find out why I am having the disease, why I am having a bad result, or why the long-term results are bad. So that's the scenario. So before starting a thesis, it was told by many of us before that a student must do a search of the literature about a question for which he is trying to find the answer to through his thesis. He is trying to find answer to something through his thesis, and for that he needs to review the literature, and at the end he needs to do a meta-analysis. Am I clear?
Very clear, sir. Thank you for those insightful comments, sir. I would just before closing this session, I would request my teacher and one of the senior persons in the room, Professor Rao, sir, if you have any comments on the methodologies and the research which has been presented in this session.
No, I think Dr. Basu's comments are very valid in this particular situation. There's no doubt about it. Basically, one has to find out as to what is happening when you are facing a problem. That's obviously the situation, rather than simply trying to, compile some papers and come out with some statistics and data, etc. I perfectly agree with Professor Basu on this issue. Otherwise, okay, I think a reasonable attempt on the part of everybody to compile some data and some papers and things of that nature. That's it. Thank you so much.
Thank you, sir. So the session is over when Professor Rao has spoken. And I think thank you all participants for presenting and highlighting your work. And I would request the judges to submit the scoring sheets to the IAPS. And all the participants are requested to move to Hall A, where the postgraduate quiz is going to commence, followed by the valedictory session. The Hall B is now going to be defunct. All right.
Thank you for a very nice conduction.
Thank you.
Very good. Thank you.
Thank you, everybody. We will move on to Hall A. Thank you.
Hall A lagi do.
এবার তুমি একটু ঘরটা ছাড়ো না আমরা এটা পরিষ্কার করব কি করে হ্যাঁ 10 মিনিট আছে
এই এটা তো হলে তো লাগিয়ে ছেড়ে দাও ঠিক আছে
Nitin, is it finished? Hello, Nitin.